Morning. Good morning. Let's start with a Merry Christmas, Happy Hanukkah, and thank you for being here, everybody. It's good to see you. It really is, even on this dreary day here in our Georgia. To start with, I just want to say how grateful I am for Chairman Camp and for the opportunity for us to work on this together. In several places, many people have reached out to both of us recently on some concerns they had. But I said before we get into the meeting we're going to have later today with both of these committees, that the data that was recently presented at a children's cabinet meeting that I serve on the cabinet was profound. And unless we have data, we don't really have anything to work off. So I felt that this morning, I appreciate all y'all pausing and making this work, and some of are joining us on Zoom, I do believe, would be a very good time for us to set the stage for some of the work that's coming up this afternoon and in the months ahead as we appropriate and govern in so many ways. So how about if we do this? If we start off with this, I'm going to ask Chairman Camp to start with a prayer for us because we need that without a doubt. And then after that, let's kind of go down and everybody introduce yourself. Since we have two committees here, some people know some of you, some may not. And so let's just take a moment and we'll start this way and then just come down and around and make sure not only those that are in the room with us, but those that might be watching or watching later also are aware of who you are. So we've got.
All right. Thank you so much. Before we pray, I'd like to just take a moment as well to honor our dear friend Mandy Ballinger, who lost her courageous battle with cancer in October. It was an honor for me to serve with Chairman Ballinger every year I was here at the General Assembly. And it was juvenile justice then and judiciary juvenile later on. And just the dedication she had to the role. So if you don't mind, before we say our prayer, if you could just take a moment of silence to remember her. All right. Our Father in heaven, we are so thankful to be here today to discuss matters affecting our state, these important matters. And we're thankful for the opportunity to gather and to more fully understand the challenges that face us regarding Department of Public Health and regarding our foster children. Please bless us to be prudent in what we do. Bless us to open our minds and hearts so we can fully understand the situation. And please bless us with wisdom so we can make wise decisions moving forward. Please bless those who are not here with us today. And please bless all those who will be presenting, that they will be able to convey their intent. And we ask these blessings humbly in the name of Jesus Christ. Amen.
Thank you. So we're going to let Chairman Camp kind of operate the board and start with, why don't you punch your button too so that we can see it light up and then, yeah, we'll start punching them. And y'all introduce yourself.
All right. Good morning, everybody. Representative Syra Draper, representing House District 90.
Good morning. Representative Esther Panich, representing House District 51, which is Sandy Springs, Roswell, and Johns Creek.
Brett Oliver from DeKalb County, middle of DeKalb.
Good morning, Representative Victor Anderson. I represent House District 10, which is Habersham and Rabun counties.
Representative Karen Mathiak. I represent Spalding and Fayette, which is 82.
Good morning, Representative Carmen Rice, represent District 139, which is Muskogee and Harris County.
Representative Dexter Sharper, District 177, Valdosta, and I'm on the Judiciary Juvenile Committee.
Well, last but not least, I think I have one more after me, but I'm Representative Lydia Glaze down in House District 67, which is South Fulton and Coweta counties.
Good morning. I am the last one. Darshan Kendrick, representing House District 95, which is East DeKalb and South Gwinnett. And this committee has changed names 3 times since I've been on it. So this is the Judiciary Juvenile Committee that I serve on.
Thank you very much. And my name is Beth Camp, and I represent House District 135, which is in West Central Georgia. I represent parts of Spalding, parts of Lamar, and all of Pike County, Georgia.
Katie Dempsey, and I represent House District 13, which is Rome and parts of Floyd County. So now let's get on with all the good meat that we've got to talk about today. Just some great things, some great places for us to start, and to make sure that we are always moving forward to protect Georgia's children and families and help them to be successful. I believe our first presenter is Commissioner Amy Jacobs. Thank you for being here, Commissioner.
To share a few data points with you all. These are very high-level data slides that we use as a children's cabinet to share how DCALP monitors the important work that we do, ensuring that all children have access to high-quality early learning. I'm sure you're all aware that high-quality piece is the most important part, that children are exposed to a high-quality early learning environment in those very critical years where their brain is developing at a rapid pace. So these are just some slides on some very high-level data, just a few that we track on a regular basis as we ensure that children have access to these services. Sorry. So my first data slide is Georgia's population, birth through age 5. Of course, the majority of the children that childcare serves in Georgia are birth through age 5. And so this is a really important piece of data where we look at the actual population of our youngest learners in Georgia. The biggest takeaway from this chart is we have seen a decline in the young children population. So our birth to 5 population has declined by a little over 1.5% from 2020 to 2024. And of course, we watch this trend because it helps us to anticipate the needs in our Georgia Pre-K program and our CAPS program, and of course in childcare in general in Georgia. Next, we also look at our licensed childcare capacity. So the children that I'm talking about and the services that we provide are provided in licensed childcare in Georgia. And this chart shows you the actual capacity. So the number of children that the licensed childcare facilities in Georgia are licensed to serve. And the good news is this has steadily increased since 2017. And right now the capacity is at 389,000. I will say this is different than actual enrollment. Very rarely do you see a childcare program that's serving at their actual capacity. They usually have an enrollment cap. But the good news is in Georgia, our latest numbers show that there are 336,000 young children served in licensed childcare, and that number has remained very, very steady over the last decade. This is probably my most used set of data. It is child level data, and it shows you the distribution of age of children that are served in licensed childcare. So of course you'll see from infants all the way through our school age population 5 through 13. And we monitor this to see the number of children, but also the age distribution. I think it's really interesting to see that only 14% of infants are in licensed childcare, but you can see 85% of 4-year-olds are in some type of licensed childcare, which would include Georgia Pre-K. Really interesting in this is we monitor this on a regular basis, but over the last decade, this distribution has remained the same as well. So obviously we not only monitor capacity, but we look at the actual number of programs that are throughout our state. So this chart shows you 2017 through current 2025. We have 4,367 licensed childcare programs throughout our state. The number of centers, which is that blue part, has increased, but what we're seeing is the decline in family childcare learning homes. Those are smaller environments that are usually in a person's residential residence, and they serve 6 or fewer children. This part is not unique to Georgia. We have seen a decline nationally of this type of care, but the overall number of childcare programs in Georgia has remained steady. This is a newer metric for us. Of course, I talked about capacity and enrollment, and then we look at attendance. So the children that are actually attending on a regular basis, we're able to capture this data during our monitoring visits where we send our childcare licensing staff to monitor for health and safety at childcare programs at least twice a year. And what this shows us is attendance, average attendance, and average children present during our visits. So in 2025, the average number of children present were 45, but I think the biggest takeaway here is we have returned to pre-pandemic numbers. So children are attending childcare programs like they were before the pandemic, where we did see, of course, a decrease, where more people were staying at home for good reason. So this is some quality rated data. Quality rated is Georgia's tiered quality rating and improvement system. Again, I go back to that high quality piece. So this measures that very important piece of actual quality of the learning environment. This is our distribution over time of 1, 2, and 3 stars. So we have a 3-star program. Depending on your assessment, you can earn a 1, 2, or 3 star, 3 being the highest quality. This shows the distribution between 1, 2, and 3 stars. And the biggest takeaway here, we're seeing an increase in 2 stars, which is good. 1 star is kind of that foundational level. We're beginning to see really good quality, really good processes, foundational practices for increased quality. But what's good here is we're seeing an increase in quality, and especially 2-star, and we hope to see that in 3-star. The other good news is we have about 3,000 quality rated programs throughout the state. So there is good access across the state for children and families to access that high quality early learning program. And then my final slide is Georgia Pre-K, which I know you're all very familiar with. You've always been very supportive. We're in our 33rd year of Georgia Pre-K. It's a nationally recognized model which provides high quality early learning to 4-year-olds. We know that these 4-year-olds leave Pre-K with a strong foundation and enter kindergarten ready. What we're seeing here, and this is the first time I'm sharing this slide this year, but we're seeing a decline in pre-K enrollment. We weren't sure if it was a trend or not coming out of the pandemic. Before COVID, we served about 80,000 4-year-olds on a regular basis. During COVID, it went down to the 60,000s, which was to be expected. But since then, when things are back to normal, we're seeing between 71 and this year, we're right at 68,000. We don't know exactly what's happening. I do think this mirrors what we're hearing from our kindergarten enrollment and just decreased enrollment in elementary school across the state. We are going to study this a little bit more because the slots are available. We know how important it is to get children ready for kindergarten and beyond. But we are seeing a decrease in enrollment. We think parents are using early learning a little bit differently. They're working differently. They've moved to different places. So we are studying this, but I did want to bring this to your attention. But I do think it's very similar to the trend we're seeing in kindergarten and elementary school in general, as we see a lot of population declines in school districts. So again, those are very high level, just a few slides from DECAL. I'm happy to answer any questions you might have.
Hang on one second. We're having logistics issue. What's your number? I'm 20. Okay. All right. Rep Sharper, hold that thought. I think Representative Oliver had a question. We're going to start with her, then you're going to be next. Okay. Go ahead.
Good morning. I forgot, are the Head Start numbers included in your 68,000 or not?
Some of them. We do have so Head Start serves about 22,000 3- and 4-year-olds. So the percent of 4-year-olds in a blended Head Start pre-K classroom would be in here. So
How many Head Start programs closed in the last few months?
So none have closed permanently. They definitely had some disruption in services due to the federal funding closure. Some of them we were able to fund temporarily with some pre-K dollars, but they're all back open now, is my understanding. They definitely had some financial challenges though.
Madam Chair, the question that I'm thinking about that we'll answer, or others will answer, is if we have a savings of money in pre-K from our lottery money, where is that money going?
So that money goes directly back to the lottery account. We surplus that money at the end of the fiscal year.
And
we don't spend it.
Does that mean our surplus lottery money is increasing? That's just something we'll talk about perhaps later on.
That's a wonderful question. Thank you. Thank you. All right. Representative Sharper, go ahead with your question.
Thank you. Just wondering when you mentioned about the decline with the pre-K, is there additional monies that the families have to pay? Like whenever they do go to pre-K, is there still other monies that may be keeping people to say, well, I can't afford to pay any extra fees on top
You know,
of
it
it.
could be. So the pre-K school day is a 6.5 hour day, just like a regular kindergarten day, and that is paid for by our lottery dollars that we receive from you all and the governor. So that is free. If they need before care or after care, they would need to pay for that. We do have a subsidy program in Georgia, which would help pay for that for low-income families. And then there can be some meal fees, but we do try to cap that so it's very, very reasonable. And in certain circumstances, they would have to pay for those. But it's a very small fee compared to the cost of childcare in general.
Okay.
But it could be.
There
Yes,
could be some
absolutely.
data that extra money that have to pay could be high.
Sure.
Okay.
All right, thank you so much. Chairman Mathiak, I believe you have a question.
Thank you, Thank you, Chair Lady. Thank you for being here. Part of what I was going to ask, Representative Sharper asked, is after school included in childcare?
Yes. In
Okay.
childcare it is, but not in pre-K because pre-K works like a regular school day.
School-
So childcare is usually a 6 a.m. to 6:30 p.m. type program, but pre-K is that 6.5 hour academic day.
Okay, and can you define high level? You've used that word
Yes, ma'am.
a couple of times and help me to understand what that means.
Sure. So we measure that through our quality rated system. We measure both structural and process quality. So our structural quality is looking at teacher qualifications, ratios between teachers and students, developmentally appropriate curriculum and materials. But the biggest part that determines quality is when we go out, we do an assessment. We are looking at your classroom. We're looking at your teacher to child interaction, make sure they're language rich environments, have developmentally appropriate practices and routines. So it is a very tight system where we assess that with really qualified assessors to do that. So it's a uniform system.
Okay, and that's throughout the state?
Yes, ma'am, it is. We
As
have
far
about-
as urban and rural?
Absolutely.
Okay.
Yes, ma'am.
Can I ask one more? Okay, there was 6 or fewer in-home licensed, but you did say licensed,
ma'am.
correct?
Yes.
I see a lot of that in my area. I think that's all I had. Thank you. Thank you.
All right, thank you, Chair Mathiak. All right, and Representative Panich has a question.
Thank you, Chair. Good morning. The Head Start program, do you know how many kids went back or didn't go back once the government reopened?
I do not have that data. We do have a Head Start collaboration director at our office who works directly with the federal government, which I can see if I can get that for you. I do not know. I know that they all reopened, so I'm assuming that they all went back, but I don't know that for sure. But we can see if we can track down something like that for you.
That would be
Yes,
great.
ma'am.
I'm trying to gauge if kids just dropped out entirely or
Understood.
the parents had to make other plans.
Right, right.
Thank you.
All right, thank you, Representative Panich. Let's see. Yes, Representative Glaze has a question for you. Thank you.
Thank you and good
Good
morning.
morning.
On the last data,
Mhm.
it says that the waiting list in 2025 is around 3,500.
Right.
And you also said that the decline is there. So if we've got a waiting list, why is the waiting list so high if we've got?
It's actually decreased over the last few years, but unfortunately, the way pre-K works, it's a voluntary program. And we don't always have classrooms where the need is or providers that want to have a Georgia pre-K classroom. I'll give you an example. A lot of times we see a high wait list in DeKalb County because it's an urban area, metropolitan, and we just don't have enough high quality providers or school system classrooms. They just don't have the room to serve the 4-year-olds. So sometimes there is a wait list in certain areas.
And I wanted to ask, is there any movement in around, I think a year ago, we actually were giving money to third parties that would be willing to start up a preschool, and we were giving startup money to get classrooms prepared. What are the numbers looking like in that area?
The money that was added a few years ago, almost $100 million for Georgia Pre-K, and a piece of that was to increase that startup funds. Did we increase that to 30,000? So $30,000 a year for a startup classroom. So we have been able to add 100 new classrooms every year.
So how many students is that?
we're at how many students? The same number of students. So at the same time, we reduced the class size. So we were at 22 students. We knew we needed to get down to 20 because that's better for teachers and students. And so we spread that same number of students over more classrooms. So we're still serving the same number of students in smaller classrooms and more classrooms throughout the state.
So do we have data where those new classrooms are
Absolutely,
located?
yes,
Could we
yes.
get that
Sure.
kind of information, please? Okay, thank you.
Thank you, Representative Glaze. Thank you so much for being here. Are there any further questions from the committee? Thank you so much. This is very informative as a parent whose child went through pre-K. Yes, so thank you so much.
Thank you, Commissioner. Next is Commissioner Toomey.
Something a little different than sit at the table.
Okay.
And not use slides, except that you have the slides in your packet. For those of you who didn't have the experience of watching the budget hearing last week, the slides kind of took off independently, and I was trying to chase them. This way I can make sure that we're looking at the same thing at the same time. And I'm very grateful to be here today. I have never, I don't believe, presented this committee. And many of you don't know me. I'm Kathleen Toomey, Commissioner of the Department of Public Health. And so some of you know me too well and have heard me talk about these issues before, but I'm just very grateful to take a little different look at some of the issues around child health and well-being for children and families, as we have been able to do with your support over the last several years. I wanted to start with a look at infant mortality. You know, we have here in the state and with your support in the General Assembly, really been focusing on maternal mortality as an issue that we needed to address here in the state. And something that has always bothered me about that kind of unilateral approach is that mothers and babies go together. A healthy mother is going to have a healthy pregnancy. A woman who isn't healthy prior to pregnancy is unlikely to have a healthy baby as well. And so I like to think about it as a dyad, the next gen approach, really, and thinking about how we approach maternal and infant health together as a continuum from women's health prior to pregnancy through pregnancy and postpartum. And I had never looked at these data in this way before. And so we looked here within the Department of Public Health at infant mortality in Georgia, beginning in the 1950s. And it was stunning to me, the decline that's occurred over that period of time. Really, if you look from the 1950 down to more recent years, there's an 80% change, improvement in infant mortality. And that is, I think, shocking how much it's improved, and is due to a number of factors. Certainly the improvements in medical care for mothers and infants, even in the time that I was in med school to now, those improvements have just been astounding, including both in perinatal care and NICU services and other kinds of medical interventions. There's also public health interventions that I have to point out, because I think it's often not well appreciated how much public health played a role in improving these outcomes, including immunizations, something that I feel very strongly about, as well as things like smoking and smoking cessation, which had led to small birth weight babies when a mother smokes during pregnancy, and a lot of intervention around those. Antibiotics. When I was a youngster, we didn't have the kind of antibiotics we have now, which can protect everyone from these kind of infections that prior were killers in the infant years. And so I think this is the kind of thing that really makes you realize how much progress has been made. But if you also look at the last 15 years, we've kind of been stuck. And we are really have stayed exactly where we've been, and have really not deviated from that. And so that leveling off and without improvement in infant mortality reflects in some ways some access to care issues, but also maternal health issues, which we again are addressing thanks to your support. But these are the areas where I think we need to be able to intervene because we will improve the health of the mothers and the babies, and I hope begin to see that decline in infant mortality further. The next slide is infant mortality by race. You'll see that the non-white is how it's described, which is described that way because in the 1950s, that's the way it was collected. And I wanted to be able to look consistently across the years. It's about twofold higher than the white infants. But again, overall, all infants have a higher rate of infant mortality here in Georgia. And again, an opportunity for us to intervene. So I wanted to also point to some of the leading causes of infant mortality here in Georgia. And I think later the Family Connection speaker is going to talk about injury and other causes of mortality in kids across the age group. And it really is illuminating to look at the by age, because with, as Commissioner Jacobs was saying, with these data, you can really focus your interventions. And for kids less than a year age, so infant mortality, that's all infants from 0 to 1. Prematurity, low birth weight is a leading cause of infant death. Again, something that we can address with improved outreach and prenatal care, but also congenital anomalies, SIDS, and suffocation, which can occur with co-sleeping and some of the other things that we've seen. And so the reason I'm leading into this, into the next slide, is that what we had proposed to address the maternal mortality, but also the infant mortality issues we see in the state, is a home visiting program. And I've talked specifically with some of you directly about this, but this program was something that we developed here in Georgia based on Georgia data, recommendations by the Maternal Mortality Review Committee, based on what we're seeing about the outcomes of our births here in Georgia. So it's not a national program that is kind of one size fits all. It was a Georgia-specific program based on Georgia data, looking to improve the outcomes as we need them here in the state and address the needs that we saw. And what was exciting about this program, and I'd be happy, I did pass out a one-pager, it's actually, I think, a three-pager about the program for you. What's exciting is that it provides a full array of services. So it's medical services to find high blood pressure, other diabetes during pregnancy, but also can address social issues, behavioral health issues, substance use issues in the home, linked to things like WIC program and other services for which this family may be eligible, whether it's a first pregnancy or a mother who's had many other babies before. And so there's not limitations to getting into the program. And we really will see all mothers in all stages of pregnancy. And it has been just an extraordinarily a positive program leading to measurable outcomes in a relatively short period of time. With your support and that of the governor, we started in fiscal year 2024 with 21 sites. The next year, with an increased appropriation, could expand to 50 sites. And with last year's appropriation, we're now expanding to 75 sites, all in rural areas that have a lack of access to care, as many of us have talked about, whether it's OB services or pediatric services, or even services to ensure the mother is healthy prior to her pregnancy. And the full array of these services that we can provide through home visiting is quite impressive and very cost efficient, because we were able to cross county lines and work together with community health workers as well as nurses working together to address this. So this is I think, very cost-efficient model as well. And just to also identify the fact that these programs have been recognized to be so valuable. Several of my Southern colleagues, particularly in Mississippi, where they have identified infant mortality as a public health emergency in Mississippi, is implementing this, the Georgia model statewide in Mississippi, because they've seen that this is an approach it not only pays dividends, they can address this broad array of health, social services, mental health, other issues that is needed for a healthy mother and baby. And so, obviously the potential for a statewide expansion would be a tremendous opportunity. And we're focusing specifically on rural areas or areas outside of Metro because there are so many assets we have in Metro. Although quite frankly, every county in Georgia, 159 counties could benefit. Our potential statewide expansion could be 154 counties minus Metro or including all. But I think the most important thing is I wanted to leave you with an idea that there's a way that we can address and improve healthier birth outcomes for mothers and babies, but also identify in the home some of these social problems and provide that intervention and long-term support through pregnancy to 1 year of age and beyond, linking to pathways and other programs that can provide healthcare. And also, as I said at the time when this was implemented, my goal is to eliminate the need for DFACs to come into homes because we have created the environment for a healthy pregnancy and support for that family through these programs. So that's my pitch, but yes, of course, but it's a very, very good program that isn't, I think it's visible across the board because it's kind of behind the scenes working to reach these high-risk moms and babies.
We have a couple of questions
Sure.
for you. Could we go ahead and do those and then get you
Absolutely.
back presenting some more?
Oh, I know, I'm done.
Oh, well, then we better ask a lot of questions, y'all. Anybody have?
All right, let's see. We're going to start with Representative Panich.
Thank you. Good morning. And just first, thank you to your continued commitment to public health. I always learn something when you come, and I appreciate how invested you are and to move the state forward. My question is, we know how Georgia ranks nationally in maternal mortality. How do we rank nationally with infant mortality?
And I think if you look at, I don't like looking at state rankings because often states measure things in different ways and it's apples and oranges because demographics are different from state to state. You can't compare us to Vermont, for example. It's just a different way of looking at things. But I think we're equally not at the top of the pack, so in infant mortality. And I think as our maternal mortality is improving, I'm hoping that we can also begin to make a dent in what is this leveling off of our infant mortality for the last 15 years. And many of those interventions that we have for home visiting should be improving that because if we can improve the health of the mother, we can improve the health of that infant. But also those other interventions, like the talking about co-sleeping, even the addressing other needs of the family during that time will help improve those infant outcomes.
I have a follow-up question. So if we were ranked really well, we would be hearing how great we are, notwithstanding that the factors may be different for how we get there. What is preventing us from getting to not be at the bottom of or close to the bottom for infant mortality?
I think it's the same issues as maternal mortality. It's access to care, ensuring everyone has that information, social supports. And I think that you can name them as well as I. And why I think the home visiting program has been so important because it looks in a comprehensive way at all those factors, whether it's social, behavioral, whether it's nutritional, whether it's even kind of literacy issues can be incorporated into these home visits. And it's personal because you can focus on that educational. But I think that it's I think clearly both access to care, but also ensuring that access is easily accessible. If you think about the expansions you have supported through our perinatal centers, it's been tremendous. But if a mom can't get there because she doesn't have transportation, it isn't going to be beneficial. And so that is a factor that we're trying to address, even with our OB programs working in partnership with the centers so that we can help have mothers being seen in the health department through telehealth. and not have to travel like that, because it's all those factors, what we used to call the social determinants of health, may affect these outcomes, both for mothers and babies. Thank you.
All right, thank you so much, Representative Panich. Representative Anderson, Chairman Anderson, I believe you're up next.
Thank you. Thank you, Dr. Toomey. Thank you for the presentation and the work y'all are doing. I noticed in the home visiting pilot sites in 24, there are 4 counties in Northeast Georgia that apparently dropped the program for one reason or another. I was just wondering if you could share any information on what happened in those 4 counties.
Well, I don't think they dropped the program. I think there was some problem in hiring, so they're slow to kind of start up. There was a hiring issue. We're trying to get our community workers. I believe that really will be very beneficial. And Northeast Georgia Hospital, as you know, has really been doing a very good job with some of their outreach. So they haven't dropped out. They're actually just a little slow to start up.
Okay. Okay. Thank you.
All right, thank you so much. Representative Oliver.
Good morning. Visiting nurses has always been a high priority in terms of effectiveness, but it's never been sustainable over my long political career. Do you think that's going to change? Do you think this can be sustainable?
Well, this isn't visiting nurses. This is visiting community health workers supported by nurses. Do you know that what we've calculated what the cost is per county? About $112,000, that's all. And the reason is that we can work so efficiently within the health department as opposed to say a CBO that has limited catchment area, and we can backfill.
This model will be less expensive than the nurse model, is what you're saying.
Absolutely.
Do you know, if I may, do you know yet, or in any conclusive way, how much the loss of CDC money is affecting you in public health of Georgia?
In this particular area, it's not, because all of the maternal and child health has been funded by HRSA.
Broad.
We're still 51% of our funding is federal. In public health, what has been cut only at this time has been the smoking program, tobacco program. As of yet, we haven't had a reduction in HIV, TB, STD, which are the programs where we receive much of our funding from CDC. I will say that what we have lost is some of the technical expertise, because that was a big part of our interaction with the federal agencies, not just CDC, but HRSA as well. And we're trying to use experts at Emory, Mercer, and other places to get that expertise when we need it.
Madam Chair, I'm guessing that as we move through the appropriations subcommittees, we'll be trying to ascertain exactly 51% is not CDC money, it's all federal money.
All federal money.
So we'll be trying to figure that out. Thank you very much.
Thank you so much, Representative Oliver. And before we go to the next person asking the question, we had 2 members to come in, and we're so glad that you're here, Representative Donahue and Representative Wilkerson. And Representative Wilkerson, I believe you have a question.
Thank you, Madam Chair, and yes, Dr. Toomey, I was listening to the presentation of the car, so but thank you for the presentation. You mentioned vaccines. Back in September, when Georgia was one of the few states that could not give out the COVID vaccine because of our unique state laws, is there, and we talked about the Georgia way a couple of times, as in your presentation, is there a way that, are we looking at changing state law to allow us not to rely on the ACIP committee for recommendations? Because there's a fundamental change in the vaccine beliefs in DC. And I just want to make sure that families in Georgia can get access to hepatitis B vaccines, or get, we don't go to Florida's way, the measles. But is there any possibility that, will you be making a recommendation against the Department of Health, because we do see the importance of vaccines, to allow us to make those decisions ourselves and not rely on the ACIP committee?
The linkage to the ACIP committee is not my decision. That was made for me. I'm not a policymaker. Emma Darnell told me that when I worked for Fulton. She made it clear to me, you're not a policymaker. You implement our policies. My job is to ensure that everyone has access to vaccines who wants to have them. And we will continue to do that. And I want to reassure you that We do have access, to COVID vaccines. We do have access to hepatitis B vaccine. So those changes have not affected our ability to provide those shots.
When we were on hold, and the ACIP committee, the advisory committee on immunization practices, we were on hold because we specifically only, I think, carve out the flu vaccine, is my understanding, I believe, that does not require the ACIP committee each year to come back. So every other vaccine, if they say that it's not, even if it's FDA approved, if they don't say it's approved for us and the CDC takes that recommendation, we therefore will not be able to give out vaccines. So if they came back tomorrow and said, we're taking this off our schedule, would that impact them or no?
No, it wasn't that they couldn't provide vaccine. It was the ability of pharmacists to provide vaccine without, seriously.
I get it, but that's where I get my vaccines as a pharmacist.
People get vaccines in pharmacies.
Okay.
There was that ambiguity about their being able to operate independently. And I think that there's certainly discussions, but, I really see my role as facilitating everything I can to ensure there's access to vaccines.
Okay.
I know I'm not answering your question.
No, you're not, and thank you. But I mean, I don't mean to be whatever, but it is a very serious thing that I did not understand the protocols until September was like a crash course on protocols. And if DC is making changes, I think it's important for us to understand what those changes are and then to plan ahead, because my fear is that even if people want it, they won't be able to get access to it. And again, you're not the policymaker, but I just think it's a conversation that we need to have internally of what we are limited to do. And we can't, because other states, I think, did make that call policy-wise. They did make a policy decision, Virginia did, to give out the vaccine, not waiting for ACIP. So anyway, it's just something that I think we need to have on our radar. But thank you, Dr. Toomey.
And that shared decision-making, I think, is confusing to people, because what does that mean? And as someone who trained in primary care, everything we did with a patient should be shared decision-making.
Thank you so much. All right. Let's see, Representative Rice, I believe you have a question.
Yes, so thank you. First of all, thank you, Chair Lady. Thank you for the presentation. Very good. Particularly, I appreciate the bridging of the home visiting sites provides in our rural areas. It helps us with that gap that's there in the medical care and the availability. My question to you, it kind of is a follow-up with Representative Anderson's, but can you expand a little bit more on the workforce when you have these pilot sites and you have the visiting sites? How many of these slots are vacant versus filled? Is there difficulty in getting them filled when we're looking at serving our primarily rural areas? It seems like that would be a great challenge. So I just wanted to hear from you as we look at specifically serving our rural areas and underserved areas. What are those workforce challenges and how are they being handled?
And I think that in the description, we talked about the number of people on board. What this program has done, interestingly, in the workforce for public health, is given a sense of purpose that I think had kind of been lost at a bit of a morale concern, because I think they've seen the value of this program. And so we have been able to, particularly in these rural areas with high risk mothers and babies, do a very good job of recruiting and have a training program that addresses across the board these issues. But I can get you the exact numbers. We did have trouble in North Georgia. We were working with a number of folks in Habersham County in particular. As you know, we'll continue to do so. And but I'll be happy to get you that information. And there's also some on that page describing the program.
Thank you so much. Chairman Mathiak, go ahead with your question for Dr. Toomey.
Thank you, Chair Lady. Thank you, Dr. Toomey, for being here. It's always an honor to have you with our committees. I wanted to know about the Department of Health per se, per county. Do the Department of Health, I understand the workforce, I get that, but are our pregnant ladies going to the Department of Health? Are they receiving Medicaid, so they are going to private practice? What does that look like?
Now, that's a really great question, because that is something that we have tried to help with, even with enrollment into presumptive Medicaid. because with now 65% of our births covered by Medicaid, it's really important for us to be able to be part of that. And so we've been working very closely with DCH and DFACS as well to ensure that we are helping to enroll. And my understanding in my discussions is that DCH has expanded pathways after 1 year beyond that for Medicaid access to moms who qualify. And so that too can be a role for us. So we don't specifically provide prenatal care, although we have these new programs, thanks to your support, to be able to link the perinatal centers through telehealth with our health departments where they're being seen, where particularly high-risk mothers can be seen prior to pregnancy and postpartum. So I don't have to make those long trips to the fetal maternal medicine experts who are scattered throughout the state, but certainly are not, we have our cup runneth over here in Metro, but not in South Georgia and some in North Georgia as well. And so we do kind of provide those linkages and although we don't provide prenatal care per se, our home visiting program almost is a glue that allows us to pull together all these different systems of care, including arranging transport, which is an issue, and making sure that that women get the services and their families get the services that they need to have, regardless of what that is. And so we are more of a facilitator than actually providing the actual care. But I really love the fact that we have these programs available that we can enroll women and families into. With that health department, we're the only entity that's in every single county, 159 county health departments. And so we can provide that service throughout the state.
Follow up, Chair Lady. So is their first touch when a woman finds out that she's pregnant, I'm assuming that she's doing a home birth test, or where's their first touch to get the information? And I was on the rural health care for cancer treatment. And one of the number one things that we heard was transportation.
Yes.
So I'm glad to hear you say that you're addressing that. But I digress. So where would their first touch be? Where would they understand? Because I see this in a rural area. I understand the urban areas. Because everything's compact, but not in the rural areas. And then I worry about prenatal care with those rural moms. Do you see where I'm headed with
exactly
that?
what
Okay.
you're saying. And I think that's why this whole program was developed several years ago. It's often the health department because women come to us for either family planning or because they think they may be pregnant, and then we have access to pregnancy tests, and then can begin that process of right there on the spot, enrolling the women into Medicaid if they're eligible, but also recommending that they become part of the home visiting program at any stage of pregnancy. A high-risk teenager, who's having her first pregnancy would be enrolled early if we had identified that she had.
So then they would get the prenatal care if they actually are getting to our departments
But
of
not
health.
from our
Yes.
department.
No, I didn't say, I didn't
Yes.
mean that. I meant,
But if they
They would
perceive that, if that is the touch point where they recognize pregnancy, those referrals can be made right there in our health departments, regardless of where those health departments are located.
thank you. I appreciate your work. Thank you so much.
This is intriguing to me. My daughter was born many, many years ago, but I was a high-risk pregnancy. And so I could, just as you're talking, I could see the support systems that could be in place, especially to someone who didn't have transportation or access right there in their own community to be able to talk to others that could be helpful. And the last page of your presentation, where you actually gave some real life scenarios where individuals were assisted, I think that's very powerful.
Right.
Especially, another person coming in, having another set of eyes, especially trained medical
Right.
professionals that can give that assistance. I think it's very, very important. But I have a question, actually. This is our floor leader, Wade. He is on Zoom, and he asked the question regarding SIDS. He said, have we seen an increase or decrease in children with, oh, I'm sorry. And no, it's not sudden infant death syndrome. I'm sorry. I apparently cannot read. I apologize. Have we seen an increase or decrease with children born with STDs? Very different
Very
scenario. Very different. I apologize. Over the past 5 to 10 years, is there any data available on infant mortality related to sexually transmitted diseases?
And the answer is yes. And we have, and some of you have heard me talk at great length about congenital syphilis, which is to me one of the greatest public health tragedies to see in Georgia at this time, because we've had penicillin to treat this for many, many years. There was a national increase in syphilis, and when there's an increase in syphilis, particularly in women, you will see a reciprocal increase in babies being born to women with syphilis who therefore contract congenital syphilis. And many of those infants are stillborn or have long-term sequelae from the syphilis if not treated. And that is something that it's coming down a little bit in Georgia, but not as much as it has in other states. So we have a lot of work to do. Again, with your support last year, we have a worker doing outreach and trying to ensure we're linking care to the women at high risk and testing much more proactively for syphilis, because I think as one OBGYN told me, everyone in my practice says there's no people with syphilis here in our practice. And then when they started doing routine syphilis testing, we're surprised to find women with syphilis who weren't aware of it. And we have had a lot, really kind of a full court press, as it were, across the state to try to address this, because it's something, a particular interest to me, because it's so preventable and should be preventable in this day and age.
Oh, without a doubt, without a doubt. Are there any further questions from the committee?
And I'll be happy to give you those data.
Okay, yeah,
I just
definitely.
happen to have them, so
Oh,
not with me, but I'll get it right. to
Okay,
you
thank
this
you,
afternoon.
thank you. I know Representative Wade would greatly appreciate it. I think the committee would as well, especially, I mean, that's such a preventable aspect of this whole mortality, infant mortality or maternal mortality. So thank you. And thank you for presenting today. This was a wealth of information. Oh, hang on a second. We've got someone online. Thank you. Chairman Gullett, are you with us? Representative
I'm
Gullett?
here. I'm here. Yeah. I didn't have a question
right.
at this time. Thank you.
You do not have a question.
I do not. No,
Okay.
I did not. Thank you.
Perhaps I can let you know your Well Times update is coming out this week.
Well, thank you.
He has encouraged us, and we have a regular report now on EMS Well Times.
I was looking at that yesterday, to be honest with you, with our
Thank
hospitals
you.
as
Thank
as
you
we
for
were
your
had
interventions.
some trouble.
Thank you for that.
Thank you.
We do have, I think, a follow-up from Floor Leader Wade. Would it benefit young adults if we were to update our high school sex education courses to highlight this risk, back to the STD conversation?
I mean, I'm a great believer that education really helps people make better choices, regardless of your age. And I think people don't understand, I think, in many cases, that chlamydia is the leading preventable cause of infertility. And for those of you who have experienced that heartbreak of not being able to get pregnant and realize that it was an unrecognized STD when you were young, it's, I've had young women say, no, nobody told me that there's any consequences of this. And I think this is the kind of thing that I think that that kind of education can help for everyone. I think parents as well as the young people. But I think my interest is in ensuring everyone, regardless of their age or location, has the information they need to make good choices for themselves and their family.
Thank you so much, Dr. Toomey. You know, just by the questions, how much we value the work you're doing and just the great wealth of experience that you are for all of us. I'm so excited to see some of these measures really starting to take place. I do think the visitation program will be a profound game changer for our state.
And I'm so grateful for having the opportunity to talk to you today for the first time. So thank you.
Thank you. Thank you. So next up, we have Christy Doyle from the Department of Behavioral Health and Developmental Disabilities. There, Tom, I tell y'all, when you see us up here looking like we're trying to manage some people on Zoom. We're trying to the unique opportunity of two chairmen trying to do this. So it's not that we're not paying attention, and just be aware that we're kind of busy too, trying to make it all work. Thank you.
Well, if I can make this get short enough for me. Good morning. It is a pleasure to be here. Thank you to the chairs and to the committee for this opportunity to be with you today. I would like to take some time to share with you some information about the Georgia Apex School-Based Mental Health Program, as well as a few other programs of interest from DBHDD. School-based mental health, as I believe most of or all of you know, is one of the primary initiatives that the Department Office of Children, Young Adults, and Family has focused on for the last 10 years. Apex is in its 11th continuous year of operation, and the fundamental underpinnings of its operation are these three, if you will, legs of the stool. Support students where they are. Our children spend the most of their time in school. That if you wish to assure that children have access to the services they need, what could be more logical than taking the services to the children, not just for the children, but for their families? You know, those of us who have been parents have fought the struggle of having to arrange your work schedule, having to take time off, having to figure out how to get your child to their appointments. Again, this is more service family friendly to the family as a whole and to the community as a whole. In addition, Apex was developed to address children's needs as early as possible, identifying the children who needed the extra services and supports and assuring that they were available at the time, rather than waiting for problems to develop and become more acute over time. And finally, opening the doorways to care, providing the access, particularly in our rural communities. As my colleague stated, you know, the differences between access in the metro areas and the rural areas can be quite significant. So again, bringing those services to the child to make sure that they are accessible. This is a visual representation of where Apex was in its is now in its 11th year of operation. You can see from the map that we are all over Georgia. We are not just urban, we are not just rural, we are in all 6 DBHDD regions. In addition, we continue to grow each year. Last year, we provided over 250,000 behavioral health services to children in Georgia's schools, which represented a 14% increase over the previous year. We reached over 15,000 students, and we grew from 808 to 868 schools in our 10th year of operation. One thing I would very much like to emphasize about Apex is that it is not simply a clinician moving into a school, sitting in an office, seeing children. It's a community, a multi-system engagement and effort to make sure that services and supports are wrapped around the child and through the community. So you can see that there is the state level of provider preparations that partners with DBHDD, also the schools. Apex is very much a local system implementation relationship. So the schools partnering with providers, partnering with DBHDD, partnering with their communities and their parents, again, to be sure that the services are happening when and where they are most needed. In addition, there is our partnership with the Center of Excellence at Georgia State University to collect data and provide reports and quality assurance, in addition to provider technical assistance and training. So it takes a village to provide services to a child. We touched on this briefly. The programmatic goals are early identification, find the children who need the service, be sure they have the service, provide access to that service, and then again, coordinate. And one thing I would like to point out is that these goals and underpinnings of APEX are highly aligned with the goals and intentions of HB 268, the school safety legislation, to again be sure that student needs are identified as soon as possible and met as robustly as possible to assure the well-being of our schools and communities. Improving access is one of our primary goals, and we are pleased to continue to increase access. We served over 7,000 children for the first time. So these are over 7,000 children who had not received any behavioral health services prior to receiving APEX services last year. In addition, over 12,000 referrals were made for service. So again, points of connection and access for the child. And in our parent satisfaction survey, 71% of parents report that their children are better able to handle just their daily lives because they are receiving services. The model of APEX, again, mirroring closely the work that was done in the school safety legislation, aligns closely with the PBIS, Positive Behavioral Interventions and Supports, tiers of support for schools. Tier 1 is the universal supports that every child gets. This would be promotion, awareness, and education. Tier 2 are targeted early interventions that might be group interventions or less intensive interventions. And Tier 3 are the more intensive interventions, perhaps a child who needs a individual therapy relationship, who needs a referral to a psychiatric or a prescriber evaluation. So those highest level of services. And here's a visual representation that can help you understand. The belief, the knowledge, is that the majority of children will do well with those universal services. Kids are resilient. We know this. So if we are giving them those universal supports, most kids are going to do just fine. 80 to 85%. However, there is that smaller percent who are going to need those two-tier supports. A psychoeducation group, a support group, more intensive education. That's going to be 7 to 10% of our children. And then at that highest tier, also the smallest percent are the kids who are going to need the most support. And APEX is structured to assure that the resources are provided in a way that meets all of the children's needs. Although APEX does wonderful work, no program is without its challenges. And like so many of our behavioral health providers, APEX does face staffing challenges. In the last year, 72% of our providers reported that they did have a challenge with recruiting and turnover in their programs for the reasons that we are all familiar with: salary, workload, other opportunities that have been provided. In order to try to address this challenge, DBHDD has partnered with the Center of Excellence on a grant to pilot a supported internship. And the results of that were so promising and so positive that beginning in the fall of 2026, how did it get to be 2026 already? We will be standing up a supported internship for 20 students. It will be a competitive process with a focus on serving rural and underserved areas. The students will receive tuition for their second year of a clinical master's program in exchange for a service commitment of 2 years to APEX following graduation. Our goal, of course, is to encourage students to enter school-based mental health, which is a unique field of service and is not to everyone's skill set or taste, if you will. To give them the underpinning of training and experience to allow them to be successful in the long term in those environments, and also to help them grow in a community over time with the hope that many of them will choose to remain and flourish in these communities. Another program I'd like to briefly mention to you is the MATCH, the Multi-Agency Treatment for Children program. This was established in HB 1013 as in recognition of the fact that the very highest needs children in Georgia are often those children that Georgia is least equipped to serve effectively. And MATCH was created in order to facilitate multi-agency, multi-partner collaboration to identify the children who need the services and bring supports and services, identify what can be served, and serve the children. In addition, however, MATCH was also developed to serve a more system-wide purpose of identifying those gaps that we keep seeing over and over and developing solutions to those gaps, filling the holes that we all know are there, and using data to drive what the holes are and how most effectively to fill them. The target children of MATCH, again, are those children with the very highest needs. They may have mental health or other complex behavioral health needs. One that we see most frequently and are seeing more and more often are children with mental health and autism spectrum diagnoses. And these are children that often have challenges finding the necessary services in their community. So we are developing that. Our children who are referred to MATCH are typically enrolled in Medicaid, be it SSI Medicaid, CMO Medicaid, or part of the uninsured population. And anyone can refer to MATCH. One of our most frequent referral sources are the local interagency planning teams that are embedded in each community. But a school can refer, an Apex team can refer, a parent can refer. There is no wrong door access to MATCH referral. Since the operational beginning of MATCH in August of 2023, over 200 kids, 236 to be exact, have been reviewed by the MATCH team, and 196 of those kids have been referred for admission to a pilot program. So a moment ago, I mentioned that one of the primary functions of MATCH is to identify and fill service gaps. The way we are determining the efficacy of our approaches to filling these gaps is by developing pilot programs and then analyzing the data and determining whether or not that's meeting the needs of the kids we've identified. What we have found is that most of these programs are meeting that need. I'd like to highlight two of them specifically for you. One in particular is a partnership with Devereaux to serve the needs of young men with complex mental health and autism spectrum needs. We have a specialized unit there at Devereaux that has proved highly successful. We've served 13 young men in this program so far. It's been operating slightly over a year, and we have many lessons learned from that. For instance, in its initial inception, our thinking was that it would be a 6-month program. What we have learned is that to provide the benefits these young men need, it's looking more like a year. Those are the benefits of pilots that we can then modify to take to scale. In addition, the Youth Villages Intercept program, which is an evidence-based, trauma-informed model delivered in the community to children with high mental health needs or who may be at risk for home displacement and removal. Intercept is a 24/7 availability mental health service that's provided to both the child and the family where the service is needed. So the Intercept team will go to the home, they will go to the school, they will go wherever the child requires the service. Finally, another couple of programs I'd just like to make you aware of, the GMAP, the Georgia Mental Health Access in Pediatrics program. It has been a collaborative program to provide training and support to pediatricians throughout Georgia, particularly in rural areas. GMAP consists of ECHO trainings in area of interests that have been identified by pediatricians in Georgia communities as areas that they would like more information on for mental health topics. In addition, we have been able to provide consultation for pediatricians in Georgia. So although we cannot take CHOA or MCG to the most rural parts of Georgia, we can make sure that pediatricians in the most rural parts of Georgia have access to pediatric psychiatric specialists in those facilities. and thus spread that expertise throughout the state. And finally, I'd just like to say a word about our mental health resiliency clubhouses. We've talked a lot about deeper end services, but there are also a lot of services available to children out in their communities. We had talked about meeting children where they are, delivering the services where they are. They're not in school 24 hours a day. So we provide clubhouse services specifically to support kids in a broad age array, ages 6 to 21. And with a variety of services such as educational services, group services. Educational, there may be tutoring, group services, employment. Some of our clubhouses have co-sponsored job events for older children with their community employers, that sort of thing. Peer support, youth peer support specialists are available to talk and work with kids, because no matter how knowledgeable or well-meaning an adult may be, kids hear things differently from kids, and it's important to have that messenger. Again, family engagement, I'd like to reiterate, because children do not exist in a vacuum. They are the diamond in the ring of their family, right? So the setting is essential for the gem to shine. And finally, pro-social social activities and interpersonal engagement that doesn't involve a screen, getting kids together with other kids. So that is my information. Thank you again. Are there any questions I can answer?
Actually, you do have a few questions. Thank you. That was a great presentation. I'm very interested in the Apex program and learning more about it. It sounds phenomenal. But Dr. Doyle, you have a few questions. I believe our first question is from Representative Oliver.
Thank you very much. Remind me, please, what is the amount we appropriate for Apex now with the increases we've funded? And what is the dollar amount it would take to complete this map to 100% offerings across Georgia of Apex?
Apologies, Representative Oliver. I do not have the exact dollar amount with me. I will get that for you though today.
And the amount that would complete the map.
That is a simple question with a more complicated answer than you might think, because participation in Apex is voluntary at the school system level. So there are some gaps in that map that are due to local choice.
I'm aware that some of that is staffing issues and other local issues. One other budget question, if I might. Also in 1013, there was an appropriations of $10 million to do educational support, student loan incentives for people to complete these mental health related degrees. Do you have any current information on what happened to that money? Has it all been spent or has it been withdrawn by the governor? Because obviously you're going down another path about helping support these students, and I'm confused about that and hoping that we can clarify what happened to that $10 million at some point. Do you have any information on it?
I do not, ma'am, but I will get it for you.
Thank you.
All right. Thank you so much. Representative Panich, go ahead with your question.
Thank you. That was a fabulous presentation, and most of it I had no knowledge of. So thank you for educating me. My question is to clarify something on page 2 of the slides. It says at the top, Apex program overview, 2024 to 2025 school year delivered 264,940 behavioral health services that reached 15,617 students. So I did some calculator math, and it would look like it's almost 17 services per child, but I don't know that that is how to correlate them. How do you have 264,000? What counts as a behavioral health service that's reaching 15,000 kids?
Understood, ma'am. Let's get back to the tiers. I think this one's better. I think understanding the tiers is helpful to that, because this is every child at every tier. And again, tier 1 service, all kids would get. So those would be those mental health first aid training throughout a school. So Christy, if she receives mental health first aid, would count for that. But if Christy is a tier 3 access student and also receiving weekly mental health counseling from a trained Apex counselor, my weekly sessions would count for that as well. So there is going to be a range of those children who receive that lowest level contact, but then also those highest needs kids who are receiving a lot of supportive contact. And that averages out, as you mentioned. Thank you.
All right, thank you so much. And Chairman Yafiak, I believe you have a question for us.
Thank you, Chair Lady. Thank you. Great information. I noticed that Chair Lady camps in my districts, counties, I think are not being served by Apex. Spalding, Pike, Fayette, Lamar. Am I right? Am I looking at that map correctly? Is? Well, it doesn't matter. It looks like the 3 of them aren't. How do our systems get involved? Do they have to call you, or what does that look like? How do they?
The superintendent may reach out to me directly. We do encourage a superintendent to have a conversation with a local provider because, of course, the local school superintendent is going to be best positioned to know who the best partners in the community are. But if they're not aware, we're happy to help them make that connection.
When you say partners, are you talking about the psychologists, psychiatrists, counselors that are in the community?
Because
okay, now I get it a little better.
Apologies. We don't hire clinicians specifically through us or for the school. We partner with clinical partners there in the community to send their clinicians and co-locate in the school.
Okay, and you talked a little, can I continue? I'm sorry. I just keep running my mouth. I'm sorry. You talked a little bit about child safety and the bullying programs that I'm very familiar with that within our community. Do you have something specific? Does Apex have something specific in child safety, quote unquote, bullying area? By any chance?
Bullying programs are frequently woven in at that tier 1 level, and obviously specific services for specific children who may have experienced bullying. We don't have a specific model per se. However, as part of the work of HB 268, we're working with our colleagues at the Department of Education to meet that mandate for an hour of bullying training per year. And
does that continue into high school? The bullying programs?
Yes, ma'am. It's all schools.
Thank you. And I'm sorry. Shut me up if you need to shut me up. The 3-tier program, does that include an IEP as well? Or is this just psycho counseling?
It's both and. So for a child with an IEP for whom behavioral health services are an identified need and support, Apex could be and should be worked into that IEP as part of their support.
Thank you so much. I so appreciate you.
All right, thank you, Representative Matiak. And Representative Sanchez, I believe you have a question for her.
I do. Thank you. How do you share the opportunity with the schools to participate in the Apex program? And if they decline, have they provided you the reasons for that?
It is at their, regarding declining, it's at their discretion. The local school superintendent decides what's best for his or her district. In terms of promoting access, we work with our colleagues at DOE. We work with our provider partners. Sometimes the partnership will originate in the schools. Sometimes the provider will go to a superintendent and say, we'd like to partner with you to bring Apex. So we do try and share at professional events, conferences. You know, for instance, recently I was invited to the school board professional associate or support association. So we try and saturate the community with the opportunity in any way we can.
Okay, may I ask another, Chairman? So if you stated that Apex should be in the IEP program, I would imagine that it supports IEP students.
Mhm.
So the children that do not have the Apex program, are they, what are they not getting that you think highlights the need for Apex in IEP students?
For me, one of the key components of Apex is its co-location there in the school. Just the ability of a child to get there, to receive the service, and to be identified for the service. Our educators spend so much time with our children. They are the most likely, other than parents ourselves, to see when our child's behavior changes, to just raise the red flags that say, maybe Christy needs a little more attention. I don't think you can overstate the value of having the eyes, the concern, and the capacity all in the same place.
Great, thank you so much. And let me make a correction. I mispronounced your last name. It's Representative Santos, and I apologize. Dr. Doyle, I have a question for you. As Representative Mathiak pointed out, there's an area that we represent that's not really that far from Metro Atlanta that's not being serviced by the Apex program. And I know that we have a huge shortage of mental health professionals in our area. Is that a factor that you're maybe seeing? I'm looking at this map, and again, there are some areas that are not so far from Metro Atlanta. Then there's some areas that are. The lack of having those professionals to call upon to be a part of the Apex program, is that part of the reason in your experience why these might not be in a district?
It could be. I did neglect to mention that telehealth can be made available as an Apex option as well. So we have identified that that is definitely a barrier in communities and are trying to surmount it that way. It varies so much from system to system.
All right. We, if I'm not talking out of turn, Representative Mathiak and I had a meeting with the school system this week that we represent, and that this is a challenge that they're saying they need more help with mental health intervention, mental health providers. They're overwhelmed. Their school counselors are overwhelmed. So these are talking points I'm going to take back to that superintendent. So thank you.
And please ask he or she to reach out to me to discuss further if they would like.
Will do. Thank you. And thank you so much. I don't believe there are any further questions. Bless you, Representative Oliver. I don't believe there are any further questions. So thank you so much for being here today. This was illuminating. So thank you.
Thank you all.
Hey, next up is Director Judy Fitzgerald for Voices for Georgia's Children.
Good morning.
Good morning.
Morning, Madam Chair, members of the committee. It's a delight to be with you this morning. Thank you for the opportunity. My name is Judy Fitzgerald. I'm the Executive Director of Voices for Georgia's Children. Ironic, given my voice this morning. As many of you know, Voices for Georgia's Children is a nonpartisan research, policy, and advocacy organization. And we are also the home of GSAN, the Georgia Statewide After School Network. We take a whole child approach, and with that lens, we cover a broad portfolio of youth well-being areas. Today, we are specifically going to focus in on two areas, which replicate what we presented to the Children's Cabinet. So again, we've got broad interest, but today we will specifically speak to two of our top priorities for the work ahead. And I've brought experts with me who can speak more clearly this morning to both of the issues. So first up is going to be Holly McKinney, our Director of Advocacy, who many of you know, who is going to address issues related to transition age youth in foster care.
Hi, let me see, I'm not sure how to advance. I don't know if I can speak more eloquently, but I can certainly speak louder than Judy. So, hi, everybody, thank you for this opportunity to present. I really, really am grateful. I would be remiss, my little section is housing, and then Katie Landis is going to do the out of school time. I would be remiss if I didn't open up by saying that the housing conversation is vast, and that Voices is one piece of a very robust conversation that's going on around housing that includes the Barton Child Law and Policy Center, which just turned 25, by the way, the Transition Age Youth Housing Coalition. Elizabeth Apley has been instrumental in a lot of this for a myriad of clients that she also has. And it is a robust conversation. Georgia Appleseed is also at the table. The agencies are at the table. We're all trying to figure out how to make this better based on data that I'm about to tell you about. But I wanted to say that at the front end so that you know that I am not like the only person who has information on this. There are many far better versed people than myself, though I try to keep up. So basically, housing instability is one of the most common drivers of child welfare involvement in Georgia. Nationwide, 40% of young people exiting foster care experience homelessness by the age of 21. And Georgia youth repeatedly tell us that housing is one of the most fragile parts of their transition to adulthood, as you can imagine. You know, any 18 to 22-year-old will tell you that, especially kids who are coming out of the foster care system. There are basically two programs that address housing vouchers that affect these youth. And I'm going to talk about each one. And I'll tell you too, it gets very complicated very fast because it's a local, state, and federal policy discussion all the way through. But to try and keep it simple and in my allotted time, we have the Family Unification Program, which is not on this slide, but I wanted to give you the full sort of landscape. The Family Unification Program, or FUP, as it is affectionately referred to, provides unlimited duration housing vouchers to families when inadequate housing is the primary reason for a child's imminent removal or delayed reunification. For youth ages 18 to 24, FUP also offers 36 months of rental assistance along with required supportive services. This is a tool for preventing unnecessary family separation and for speeding up reunification when housing is the final unmet case plan requirement. The other voucher, the FYI voucher, Foster Youth to Independence, which this slide is about, serves young people exiting foster care and provides 36 months of housing assistance, extendable to 60 months under federal law. But Georgia currently ranks 45th in the nation for FYI utilization, with only 8 applicants in 2024, according to the data that we have looked at, despite hundreds of youth being eligible. And while 9 Georgia public housing authorities participate, there are many more that are eligible but lack the MOUs with DFACS. And I do know that this is a thing that DFACS has been working on from what they report. And I know they've been doing some restructuring to get MOUs with the public housing authorities in place. Also, sort of it's really so too complicated for the 15-minute presentation. But the FUP and the FYI work in tandem. So local housing authorities who get FUP voucher allotments need to have used 90% of those awarded in order to ask for an FYI allotment of vouchers from the federal government. So this is why I wanted to present together, is because they're related. Once a housing authority has an FYI allotment and they use those up first, and if more needed, they can request additional vouchers once they've used those up. And if they are denied those vouchers, they can also do vouchers on demand from HUD, from the federal agency. Let's see. So DFACS can make referrals for these with housing authorities, but they have to have an MOU in place to do this. This is my 2-second version of this very complicated thing, so I'm probably not going to nail it 1,000%. But DFACS can develop MOUs with local housing authorities and have this voucher process work with referrals. Also, Department of Community Affairs covers the areas where there are not public housing authorities, but they too can develop MOUs with housing authorities to help them implement this voucher system. Does that make enough sense? It's very complex. So But the MOUs aren't all in place. Everybody's trying to figure this out. All the agencies have been working together. There was a big meeting, I think it was last week, right, Devin, with DCA and DFACS and a lot of advocates trying to get around how this is going to work. So just to be perfectly transparent, there are a lot of moving parts in this process. However, it is complicated and kids are not getting housing vouchers that they need is the bottom line. So we're all trying to fix that. And we have a few quick recommendations I'm going to throw out there to expand the MOUs statewide and to make sure that those happen, which is hard to do, like it's a journey. To make sure that DFACS staff are trained to make referrals for the youth is very important, and to use Chaffee funds to support HUD required services that the youth must receive while getting these vouchers, and then to track the outcomes publicly. We have some federal data as how we get to some of these numbers, but it would be really great to have a better dashboard and more transparency around who's doing what and how, which would have helped me explain this process better today. So, oops, I hope that's, and I'm happy to try to take any questions. Or I can introduce Katie, who can talk about after school.
All right, we do have a question. Good question. Representative Glaze, go ahead.
Well, thank you for
Good morning.
the information this morning. I wanted to see if the new law that we just approved and was signed into law around students who have been in foster care can get up to $30,000 to help with housing and other costs around getting prepared for a career. Is that money going to be used to help with the vast array of students who need housing?
I am going to defer to Devin on that, who actually worked on that legislation, but it doesn't relate to the FYI or the FUP voucher. I can tell you that this is all federally funded and with the FYI and the FUP vouchers. And the key is to get the implementation to work in our state. But that funding, I'm sure, is going to be helpful, if not already. And Devin can speak to that better than I.
Then students would likely
And don't forget to say who you're with.
Hi, everybody. My name's Evan Riddy. I work with Georgia Empowerment. And the hope is that once that is funded and appropriated, then students would likely use that before they need to use the FYI or FUP voucher. And just for some clarity or maybe more confusion about the housing vouchers, part of the problem is there is confusion about the FUP and the FYI vouchers. I don't believe they actually need to use 90% of the FUP vouchers in order to get the FYI vouchers. They are completely separate, and FYI is non-competitive. But my understanding is that in order to use the FUP vouchers for young people who are aging out of care, they do need to use that 90%. So both of those things can be utilized, but there is a wide availability of the FYI vouchers that can be used.
And they can be like on demand.
Yes.
This is how you get past the 90%.
Yes, and
Yeah.
like that's a common misconception we're finding with the PHAs and making sure that this happens. So we're also working on making sure everyone's educated as well.
Yeah, and I will just say, additionally, the other challenge with the local housing authorities is staffing. Kind of like we were just talking about with Apex and things, it's around having somebody in the jobs long enough to get an MOU, to understand this complexity and to be aware of youth aging out of care in the first place.
All right, thank you so much for answering that. We've got a couple more questions. Representative Wilkerson, go ahead.
Madam Chair, you mentioned federal money a couple times. Are there any federal cuts that are going to impact the programs that you're doing?
I will venture to say yes, but I don't have. I'll have to get you those numbers and get more detail on that for you.
Thank you.
Great, thank you so much. Representative Oliver has a question. Go ahead.
This is really, for my colleagues, just an expression of frustration. There are two people, the judge and the caseworker, that are required to follow federal law, that a transition plan for foster care children beginning at age 14 must be implemented. And sometimes it's the judges that are saying, where is the housing voucher? Sometimes it's the caseworker. But for me, the federal law says it should start at 14. And when we have a statistic that 40% of our foster care children are homeless within 3 years, it shows that that federal law is not being followed. That's my frustration.
Agree.
Some of the leaders on this voucher program have come from some of the judges, and I just want to thank them this morning for that leadership. We could use some leadership in every one of the 159 counties on this issue. Thank you.
Thank you.
Well, thank you, Representative Oliver. And it is kind of disheartening to see we're 45th ranked nationally in implementation. That's hard. So thank you for bringing this to light, and we look forward to finding some ways to help these kids moving forward so they're able to utilize these vouchers. So thank you.
Thank you. And not Katie Katie Landis, Dempsey.
All right, Katie Landis, thank you for being here today.
Thank you. Good morning, Madam Chairs and committees. Thank you for having me here today. I'm Katie Landis, the director of the Georgia Statewide After School Network. So I want to share just a few numbers with you about after school and summer learning, or what we usually call out of school time programs in Georgia. These programs, out of school time programs, they offer safe and enriching places for our young people ages 5 through 18 across our state. Not only can youth in these programs get caught up on their academics, but these are also places where they can access behavioral health supports, nutritious meals, and just an opportunity to engage with their peers in a more relaxed setting. These programs also strengthen families. 9 out of 10 of Georgia's parents agree that after-school programs help them keep their jobs and make them more productive while they are in their jobs. Unfortunately, the demand for these programs in Georgia is far outpacing our supply. The first number you'll see at the top is, according to Georgia parents, there are over 850,000 young people in our state who those parents would enroll them in an after-school program if they could. The biggest barriers to access these parents report are in order. It's cost, affordability, transportation, and then simply just access to a program in their local community. With the new state appropriations that y'all put in the budget this year, we have started to begin to address this problem of demand in Georgia. This was the Boost Grants program. With the $12.5 million that was put into the budget this year for the Boost Grants program, we now have, this is that map you see, 63 grantees across the state of Georgia. These 63 grantees are operating they're operating sites in 117 of our 159 counties. So those are those teal and dark teal counties you see there. The difference in those colors, that light teal color, those are counties that were high priority for us because those are counties that do not already have any, that previously did not have any government funds, whether that be state or federal, supporting after school or summer learning programs in those counties. These programs offer a wide variety of supports, but we had 3 different areas of priority for the Boost Grants program this year. And those are the small numbers you see on the right-hand side of your slide, where 85% of the current grantees are offering literacy programming based upon the science of reading. 82% are offering numeracy programming, and 69% are offering programming on workforce development. So this is just a snippet of the wide variety of programs that are happening in these out-of-school type spaces, again, in the after-school hours or in those summer months. But participation in these programs, it also helps to improve school day attendance. I know there's a lot of conversation around chronic absenteeism, and so that's something that we've also been looking at. That 68% number you see there, that's actually not specific to the Boost Grants program. That is around the Georgia's 21st Century Community Learning Centers. This is our federal funding we have in Georgia for after-school programs. It goes through the Georgia Department of Education, and it's about $40 million per year that is going out to school-based and community-based programs across Georgia. That 68% number, that is showing that of these 21st Century Community Learning Center sites across our state, they're reporting that 68% of the young people who are participating in their after-school programs who have been chronically absent the year prior have improved their attendance that year that they've been participating in this after-school program. And so again, I know I went quickly, I know we're a little short on time, but I wanted to just lift up a couple of these key highlights around what are some of the benefits and the impacts of after school and summer learning in our state for our young people and our families, really creating those foundations of support that so many of the families need in our state. If there's any questions.
I don't have any questions so far, but I would like to ask a question. I live in a county that is gray, and I was curious. I know you're in 117 counties, which is fabulous, but we have 159 counties. So, can you give any reasons why some of these other counties might not be participating in the program?
Absolutely, because the demand for these grants was far surpassed the amount of funding that we had allocated.
Well, that's an important thing to know.
Yeah, I'll give you a little more specifics on that. There was just this round of grants that launched this summer. They were awarded in October. There was over $30 million of funds requested by the applicants. And the applications were amazingly high quality. You had to have a score of over 80% on your application score to get funding. And so we were able to fund it was around 42% of all applications. So that means there's a lot more applications that went unfunded. So I can absolutely pull for you if there were some in your county who did apply. They may not have applied, but they may have, and simply the demand outpaced the supply again.
That's important. Thank you for letting us know that.
Of course.
All right. Well, thank you. My question did not spark any further questions. So thank you so much for being here today.
Thank you.
And thank you all for the great work that Voices is doing. Appreciate it very much. So next, Executive Director Gay Smith and Jacqueline Jordan for the Family Connection Partnership.
Good morning, Madam Chairs and members of the committee. Thank you so much for inviting us to present to you. We also left at your place the Who We Are cards because some of you may not be familiar with Family Connection. So by way of a quick introduction, before I turn it over to Jaquan, I'll just remind you, I'll just remind you of our vision statement, which has been our vision statement since we were created, and that is we envision a Georgia where every child, family, and community is healthy and thriving. The Georgia Family Connection mission, so a lot of people get confused. There's the Georgia Family Connection Network, which is the statewide network of the 159 county collaboratives who work together to try to harness the power of collaboration and data. We craft locally driven solutions that maximize resources, fill in service gaps, and make systems that support families more effective and efficient. The way that the Georgia Family Connection Partnership supports that is we try to leverage statewide knowledge, resources, and relationships to better outcomes for every child. We strengthen the local action of the local collaboratives. We also improve policies, practices, we build partnerships, and foster informed decision-making through data, research, and evaluation. So the data piece in our wheelhouse is what we want to share with you today. We're real excited about all the suite of tools that we have for you. And I'm going to turn it over to Jaquan Jordan, who is our Kids Count Data Manager. He's been with us for 2 years. He comes with a background of programming and data analysis. He has also, in his quick tenure, been asked to serve on the National Kids Count Advisory Council for the Casey Foundation. And when he's not being a data nerd, he's a medic with the U.S. Navy Reserves. So we thank you for your service. So with that, I'm going to turn it over to Jaquan.
Right. Thank you, Gay, for that awesome introduction. And thank you to the committee and the chairwoman for inviting me and having me here to talk about some data with you all. So I'll be talking about Kids Count data. So Kids Count is the national project from the Annie Casey Foundation, started about 35 years ago in 1990. Our original ranking in that ranking was 48th. Yep, and that is out of 50. And so 2003, 2004, we raised or we rose to our highest ranking, which was 37th. And so you'll see here in 2025, the latest ranking that just came out in June, we did have a regression. We fell 2 spots to 39th. And in case you're wondering who is now 37th, 38th, that would be Tennessee and South Carolina. And so what is that? Well, what does that look like and what are the reasons, right? So this ranking is done within 4 domains. I'm going to go through them here, 4 indicators per domain. And you'll see our largest regression was in the economic well-being domain. We went from being ranked 32nd to 37th. You'll see that there was an increase in that population of children living in households with high housing burden. And so kind of to echo something that we briefly touched on in a previous presentation is that housing is a multifaceted, right, conversation. But we know that there are many ways to measure that. And this is the way that the Casey Foundation and Kids Count does that here or attempts to. So we also see in the education that we also regressed. We went from 31st to be ranked 32nd. And this, you'll see the losses in Georgia, or some of the, like I said, the regression in Georgia mirrors that national kind of trend. And so you'll see that in the 4th grade reading or proficiency in reading that we unfortunately rose to 70% of our 4th graders not being proficient in reading. Similarly for our 8th graders, not being proficient in math, we saw a rise, right, from 69% not being proficient to 76%. And so let's touch on some maybe a bright spot, right? So our health, there was an improvement. We were ranked nationally 43rd in health. And you'll see that we did improve to 40th. You'll see that our low birth weight, which is something, our low birth weight rate, sorry, which is something that we have talked about briefly as well today, but that it had plateaued in 2022 and 2021 at 10.6%. And so you'll see that the 2023 number in this Kids Count ranking went down to 10.2. And so that did represent the first time that it has actually decreased in those previous 4 years of us tracking that, right, with Kids Count data. And so you'll also see the child and teen death rate per 100,000 has also increased. And that's, again, another trend that is mirroring the national trend, right? And I'll get into a little bit more about what that looks like in Georgia. But lastly, I did want to finish on a kind of a positive note of the teen birth rate. So teen births per 1,000 is also decreasing in the state of Georgia, as well as it is across the nation. Okay, so bunch of numbers. I just wanted us to kind of key on a couple of them and what that actually meant and what that looked like, right? So the percent of 4th graders who scored below proficient reading levels, right? That's risen to 70% in Georgia based off of this Kids Count release, right? What does that mean? That means that if you have 10 4th graders, 7 of them cannot read to the ability that they need to go to the next grade. Right. And so that's something that, obviously is troubling for us and for us to take a deeper look at. That child and teen death rate. Right. As I said, there's been an increase over the years, but since 2019, right, there's a 21% increase in that number. So what does that look like? So that's the per year death rate. Right. So in 2019, from 2023 to 2019, there were 174 more children, right, that died in the year of 2023 than there was in 2019, right? And as I said, that does match or kind of mirrors that national rate, but you'll see that national rate was 16% increase, bless you, as opposed to 21%, right? And so lastly, as I talked about with that high housing cost burden, so that increased by 3% from 2019 to 2023. Bless you. What does that look like? That's 69,000 more children, right? So, I think sometimes it's easier for us to hear that data, but we don't, it's a little bit, means a little bit more when we actually think about that in a concept of, okay, that's 69,000 more actual children and kids, right? As opposed to just whatever the numbers are, 3%. Okay, so all of these data are, as I spoke, the Kids Count release data. The National Kids Count Project, they utilize ACS 1-year data. They utilize the National Center for Education and Statistics, NAEP data. But in addition to that, they also have a grantee in all 50 states that our responsibility is to add additional, right, like context and collection for our local data and to contribute to that national site. And it just so happens that GAFCP is that Kids Count grantee for the state of Georgia. As Gay touched on, we are on the advisory committee. I sit on the data working group for that committee. And so each grantee maintains our own Kids Count. So Georgia Kids Count, instead of it being made up of those federal sources, we are made up of sources like the Georgia Department of Public Health, the Georgia Department of Education, right? Those are all of our partners. We also have DCAL, we also have DJJ, the Technical College System of Georgia. A lot of the trusted sources or the large trusted sources of data in Georgia serve as our partners, and we aggregate our data from them and place them in a repository that we are, one, hope that's very accessible, but two, we are very proud of. I have a fantastic Kids Count team that, as I said, or as you see here on that slide, maintains all of these data across 2 static tools as well as a number of interactive tools to not only help local decision makers engage with the data, right, and to make sure that they're evaluating and using the data for that, but also for the general public, right, because we know that data is information is a public good, right, and so we want to make sure that it's also available for all those seeking it. And so you can access these data by going to the gafcp.org website. You're going to scroll over data, and then you'll go to the data tools page. And I'm going to give you a brief overview of what each of the tools are useful for what and what we offer. However, if you would like a more in-depth explanation on how to actually use the tools, we do now have a data tools tutorial page where you'll get a option where you'll get the opportunity to see all of the tools and hear my voice even more explain to you how to use them. So we'll start with our static tools. As I said, our static tools are just portions of the suite that we have to offer, but we really look at these more so of ways to get other people interested in the data. Starting with our birth to 21 profile, we like to call it the data appetizer, right? It's going to give you a teaser and get you interested, kind of whet your appetite for some more data. And so those 9 indicators will be the indicators that we determine to be most important from birth to 21. We also have our Georgia profiles. That's going to be our exhaustive list of all of our indicators, comparing it to the state of Georgia rate, as well as giving you demographic data for each county. And our indicator improvement calculator designed for that our coordinators, but also any local stakeholders that are basically beginning program implementation or grants are able to use this tool for SMART goals. To help them set SMART goals. And then we also have our comparable counties map. This tool helps you identify other potential sources of collaboration outside of your own geographic area, right? To help you kind of think outside of your local space. It's going to help you. It's going to match your county to other counties based off of demographic data. Your median household income, educational attainment, things like that. And then we will have our Indicator Explorer. So our Kids Count Indicator Explorer is our most exhaustive tool. It's going to give you trend data for all of our Kids Count indicators, as well as all of the demographic data that we hold. And it's going to be able to not just put it in a visualization that you're able to share and download, right? Makes it easier for you to read, but it'll also give it to you in a CSV file. So if you, like me, like to play with data in spreadsheets or SQL, you're able to do that as well. Our indicator, in our interactive indicator map is going to be a way for you to disaggregate data. So sub-county level. So in addition to having all 159 counties in our Georgia Family Connection Network, we also are able to, so because we have all of those 159 counties, we keep track and maintain the data for all. But we also able to offer you sub-county data in the form of census tract data, as well as state Senate and state House data. So just a caveat on that, I'm sure we all may know or may not know, but the ACS data, so the American Community Survey, has been delayed. It normally comes out December 11th. It will not come out until January 29th of next year. And so that does put a little, unfortunately puts a little bit of lag on how we'll be able to update this. But once we do have that data for everyone, we will make sure that it's available. Lastly, I want to show that our another way for us to disaggregate these data is this data disaggregated by race and ethnicity. This is, again, just another form of disaggregation that's going to allow you to best utilize the resources that you have, right? Because we know that there's not an infinite number of resources that we have, right? But we do know that there's particular best ways for us, most efficient ways for us to utilize that. And so here's another way for us to disaggregate and attempt to do the same. So I know that that's a lot, and I was trying to move so that way that there was any time for questions for Gay or for me, that I didn't delay everyone this morning. But I would love for you all to, based off of this information that you all heard today and the data that was shared by some of these fantastic folks up here, to definitely take the time to reach out to a local family connection coordinators to see what's going on in your local communities, but also to please continue to do what you're doing now, which is looking at the data and thinking about the data and actually making decisions based off of the information. So
thank you so much for your presentation. I think all of us love data. So this is phenomenal, especially all the ways that it can be viewed based upon county and district and so forth. So thank you for that. And thank you for going through this program. I've never actually gone to this website, I'm ashamed to say. So it is, and we have a great family connections person, and he's phenomenal, and I'm remiss. I'm going to be checking this out soon. We have a few questions. Representative Rice, we're going to go with you first.
Thank you, Chair Lady, and thank you for this presentation. I'm just going to say, honestly, this is new to me, so I am very excited. I'm just wowed by this, and I think moving forward that it's going to be a very useful tool for many of us, and I'll be diving deep into that. But just if you can jumpstart me real quick, and I will be looking at it. On page 3 under education, those indicators, very disheartening, obviously, but looking forward on the things that we're doing and working on, what is that year number that it's comparing to? My glasses are not.
What were we talking about?
Yes, so on the bottom graph, the education, and it had, 4 different categories. And what was the year that was the base, the former year?
Yeah, so the far left year is going to be 2019 for 2 of them. And then so for the youth, basically not in school, right, that 3 to 4 range, they do the cohort. So it's from 2014 to 2018, and they compare that from 2019 to 2023. So the methodology for the Annie Casey Foundation, their kids count, is to do a 5-year comparison. They believe that it gives them the best, it gives you the most amount of information about for trend comparison. We in-house typically do 3 years, but and so the Casey Foundation, if there's 2023 data, they're going to compare it to 2019.
Okay, thank you very much. This is great.
Thank you. Thank you. And Representative Wilkerson has a question for you.
Yeah, thank you. Real quick on the same slide, what's the reasoning behind, or do you know, is it a timing difference that young children, fourth graders and eighth graders are all going down and get in their proficiency, but our graduation rate's going up?
Yeah. So that
I'm sorry, I didn't mean to crack everybody up.
there's a lot of conjecture, but also questions about that same kind of how can you tell me these indicators of academic success are going down, but at the same time we're graduating more people, right? And so I may not necessarily know the answer to that off the top of my head. I'm not really sure a lot of people in the education necessarily know what the answer to that is. And I can definitely look that up, but I do know that as we kind of talked about, right, absenteeism and things like that. And I'm not really sure if that contributes to it, but
even if you're absent, you can't graduate from high school, I would assume. And I mean, I'm just curious because I know we spent a lot of time on literacy and science of reading, et cetera. And basically this graph is saying that it's not working.
Yes. So short answer is yes. Yes, and I have, and it's funny you say that because my girlfriend's a teacher. So I asked her, just plain frankly, what do you think is going on, right, with literacy rates? And there was a whole kind of litany of answers that I was getting from her, right? And she's been teaching for 11 years. And so I think that just kind of is kind of a symptom where it kind of shows, right? Like there are a number of we're starting to realize now post-pandemic that these numbers are what they are, that they're real, right? You now finally have a trend. And so I think a lot of maybe some of the academic kind of ways that we went about things pre-pandemic, we realize are no longer working post-pandemic, right? And so, as you said, that I think that takes a deeper dive into the data, far deeper than I currently have done on education data. But so yes. Thank you, sir.
Thank you. I think we probably could have a discussion most of the day.
Yes.
So thank you for touching on that. And thank you for the question. I have a question on page 4, the second slide on the page, where it said there had been a 21% increase in the number of children and teen deaths since 2019. I'm curious, when you say that number, is that all deaths? Is it disease, accidents, overdose?
Yes, ma'am.
Suicides, everything?
Yes, ma'am. So that's all deaths as defined by the Casey Foundation. And so what they have largely kind of what the literature has attributed it to so far, right, would be an increase in the leading causes of deaths in that age group, which are accidents, right, homicides and suicides. And we have seen an increase, right, in suicide rates, particularly in that 5 to 14 range. So we may know some data that are associated with it, but we do not know any correlating data, right? We can't definitively say, well, yes, it's because of suicide, or yes, because, right? However, we have we are looking into that data now and seeing the disaggregated portions of where those deaths are coming from. We're starting to analyze that.
I think that would be probably wise to see where exactly the challenge is, especially with such a substantial increase. So I'm glad you're looking at that in that direction. And I believe that Chair Dempsey has a question.
Thank you so much. I don't really have a question. I have a comment that I just want to make sure, because I'm always grateful when people say, I wasn't aware of this.
Yeah.
And this is amazing information that's been put together for years and years. Each year on your desk, you get a book that is the Kids Count book. I know we get a lot on our desks, and I know sometimes things get lost. You might go back to your office and look for it. It may be there. It's, it's sizable. It's not quite an inch, but it's pretty good and some great comparisons. I encourage you to look out for it. I bet if you don't have it and you need it, I bet we could work to try to get you another one, maybe.
I can get you one right now, as a matter of fact.
So they are a tool. It's amazing. I have had people call me and say, that book, do you have one? And they'll go in my office and look something up, literally, because it is true. The Casey Foundation is wonderful, and the work that they do to compile all of this is really important. So thank you. Thank you. I don't see any other questions. Y'all have been great this morning. I want to especially thank everyone who has been here to present. This, as I told you, is such powerful data that we all need. We can all speak factually in places where we go and in decisions that we're making. There will be more of that as we begin the afternoon session at 1:00. I do want to tell the committee there is lunch right across the hall. I hope you'll avail yourself of that and be strong and ready when we come back at 1. So, because we've got a good afternoon to work on as well. And I know there will be lots of questions and discussion at this time, but I cannot say thank you enough to everyone who is here and presented. I, as you know, was so touched by this information, and I wanted everybody to have it as much as we can. So who knows, maybe it'll become an annual event. We'll just see. Thank you so much. We are going to temporarily suspend for now. Good afternoon. Hey, how's everybody doing? Thank y'all for pausing. I know this is a very important conversation. We're getting ready to have Katie Dempsey joined by
Beth Camp.
our new chairman for Judiciary Juvenile. The name changes, so I have to look at it to make sure I'm saying it just right. We had a great morning of some data digging, I guess you could say, to be prepared for this afternoon. And listen, so that's what we're going to be doing. I know there's a lot to be said, and we are going to move quickly, but I want you to feel like you can say all you want. Our committee has, there's some other meetings going on that some people are at, so they had to step away, but also some people are on Zoom. So we'll be watching. You'll watch us juggling, and don't think we're being rude. We're watching for emails or text messages that may be coming in with a question from someone that couldn't be in the room but has some great concerns. So we will do what we can as we move forward. And thank y'all. Let's start off with our first presenter, who is Allison Ash with Wellroot. Oh, yeah. Sorry.
Thank you, Chairwoman Dempsey and members of the committee for inviting us to be with you today. I'm Allison Ash. I'm with Wellroot Family Services, which is one of the state's oldest child welfare organizations. We were formerly known as the United Methodist Children's Home and have been doing work in partnership with the state for 154 years. I'm joined by Mary Vincent, our Senior Vice President of Programs, and Christina Lennon, our Chief Innovation Officer. We are here on behalf of Together Georgia, as many of the providers that will speak to you today are. And we are proud that we are partners with each other and work collaboratively to come up with the best solutions for the children and families of our state, but also partners with the state and the Department of Children and Family Services, and are sorry that we have to be here today to talk about this difficult issue. Wellroot is, as I said, 154 years old, and we provide services across the continuum of child welfare. We provide trained and well-supported foster parents when needed. We provide services for youth aging out of foster care, but we've also, for the past 5 years, been very heavily focused on prevention work and keeping children out of the child welfare system. As a part of that, backing up, I know that you heard from a number of people this morning about the state of child welfare in education and all the things that impact children and families. But I don't know if they shared the statistics from the Annie Casey Foundation. Georgia ranks 38th overall in terms of child well-being and 48th in access to mental health services for children. So I feel like our state has done a lot of good things. We've seen a lot of progress over the past few years under the Department of Children and Family Services and Commissioner Brose in decreasing the issue of hoteling, looking for lost kids, working on trafficking, and we are thrilled about that. But we also know that even before these recent cuts happened, that we were not faring well overall in the national landscape when it comes to child welfare, and there's tremendous amount of work to be done. So now experiencing cuts gives us significant concern about potentially backsliding even further. So as I said, 5 years ago, Wellroot decided to get into the work of prevention services. We launched a home visitation program, which I know you heard about from Dr. Toomey this morning. We're now doing home visitation in 7 counties. We have a functional family therapy program, which is an intensive therapy program for families in crisis. And we also do family coaching and family support and parenting coaching and teaching. A big part of our prevention work was, at that time, we also decided to pursue a delivered services contract with the state of Georgia. That's wraparound services. Those services support both children in foster care and children at risk of going into foster care. Services such as behavioral aids for children who are really struggling with behavior, and for families who are really struggling to either biologically parent or foster a child with behavior needs. Transportation to vital appointments for kids with autism. Transportation to mental health appointments. All the kind of things that are needed both for supporting
foster families well, but also keeping children in the home. Those services are now under significant scrutiny, and we absolutely support that the department wants to make sure that the money for those services are utilized well. But the partners that you will hear from in the room today are all highly respected partners that are doing the work well. And the scrutiny has changed the lens of the conversations that our staff are having with the department staff. Having, instead of the child's needs being the central lens for what the decision is around a behavior aid or transportation, the lens is the cost and the money and who else can pay for it. And we certainly understand that they're facing a significant deficit, but when the child and the family's needs aren't centered, what happens is that kids fall through the cracks. And we're very concerned that kids are going to start very rapidly falling through the cracks with these cuts. I also just had one other thing I wanted to make sure I addressed in my time with you, and that is one of the solutions that I have heard being talked about in groups that are trying to help the department figure out how to face the budget shortfall is that Medicaid could jump in and fund some of these services. I want you to know that is a very difficult proposition. It took WellRoot. We became a Medicaid provider last month, and it took us 4 years. So to assume that an agency who's not currently a Medicaid provider, which many of them are not, can switch over and quickly become a provider, that just can't happen without your help and without the Department of Community Health help and the Department of DBHDD's help. We, Christina Lennon, our Chief Strategy Officer, partnered with the Georgia Association of Therapeutic Services. We wrote a white paper about the impediments that we faced as we worked to become a Medicaid provider. I think maybe a couple of those recommendations have been adopted, but there are quite a few more recommendations that have not been adopted, and we would strongly recommend looking at that as a part of your solution today. Also, it's not everything that happens in the delivered services unit can be covered by Medicaid. So either there has to be codes to cover those services, or the money needs to come back from the department so those services can be provided. So we would be happy to take any questions about the impacts that this has had on us. I'm not covering the areas that I know that the cuts have impacted some of the other providers here in the room, because I know they'll cover that for you. Any questions?
Are there any questions? If you'll just touch your button and let us know.
I actually have a question. What codes are there specific services you're providing that are not covered, and are they not being covered because they're not medical codes, or why are they not being covered? And for full disclosure, my daughter is a provider, so I'm just curious.
I don't know all of them, but I don't think, like, for instance, I don't think transportation is covered.
Transportation?
Yeah.
Okay. So how is transportation being funded at this point with your company if it's not?
So what I'm hearing in our company and what I'm hearing from other providers is that we're being asked to self-fund it. And you should know, and I think this is an important thing for all of you to know, we don't make money on our contracts with the state. Our contract with the state covers about 65 to 70% of our foster care costs, and it's only 60% of our costs to run our transition age youth program. And we did not sign up to be a delivered services provider because we anticipated that we would operate in the black. We knew when we did that, we'd be operating in the red. So then to be asked for our staff, who's already stretched, to do the transportation services, it's definitely challenging.
And I'm sure there's some legal ramifications, putting a child in a car and all those other, or a vehicle, the insurance and everything else involved in transporting those kids. All right. Well, thank you so much.
And one more thing. We do work very significantly with transition age youth, and I really believe this age, that the teen age and the age where kids need behavior aids and a lot of the services that come with delivered services, those are the kids that are going to end up, if we let them fall through the cracks now, they're going to end up in a transition age, still in the system, still needing providers like us. And in the long run, this is going to cost the state significantly more money.
Thank you. All right. Looks like Representative Glaze also has a question for you before you leave, if that's all right. Sorry.
So I'm going to act as though I literally have a blank screen, and I just want you to answer just how will this funding gap affect the children you serve today, starting January 1?
Right. Just the idea that the providers or that PPACs have to look at each case through the lens of saving money versus what's right for the kid means that poor decisions will be made. And right decisions for children and care will not be made. I think kids will fall through the cracks, meaning, whether it's a delivered service that a family needs for prevention service they don't receive a behavior aid when that's all a child needs is to get on the right track is a behavior aid that can work with them, and they don't receive that, then that kid will likely end up in the system. If it's a kid in the system, they could also fall through the cracks, not have the right supports. I've heard stories of kids who are right now not getting to see their biological parents because they don't have transportation to go see their biological parents. That causes trauma. It's very important that kids that have somewhat healthy biological parents, that they see them and stay connected with them. So to disrupt that is the kind of trauma that could have lifelong impacts on a young person. I do also want to say it's also unfair to the foster families that have stepped up to foster high need children. They did that because they were told they'd be wrapped with support, and that support is being taken away. Many of them will probably keep working with the children in their home. Not all will be able to. And so those kids could end up being in group homes instead of in a foster home. And we know that home-based care is the best care when possible.
Thank you. All right. Thank you so much. Certainly appreciate your time here today.
And thank you, Allison, for all y'all do. I know it's a heavy lift at times, so thank you so much. Next, we have Melissa Carter from the Barton Child Law and Policy Center.
Amber, this looks like something I don't want to mess with. Thanks for your help.
While we're waiting to get that loaded, I will tell y'all that we're here this morning, that the Barton information, some of it was also presented at the Children's Cabinet. So kind of had both feet, one in the morning and one this afternoon, and we just asked her to wait and do now.
Yeah, thank you. I do think it's a good bridge between the conversation you started this morning and where you're headed this afternoon. So good afternoon. I'll start there. Thank you for the opportunity to appear before you today and contribute to this important conversation. I appreciate your focus, both on to what I took from this morning when I watched online to now, on both outcomes and fiscal stability. Those two issues are really inseparable in child welfare. We're about investing in the outcomes we want to get. And if nothing else, that's the theme I want to leave you with from my remarks. The Barton Center engages in a lot of activities in this space of generally system improvement, for child welfare and youth justice, primarily in this state and a few others. We do that through education and training, through policy and research, through advocacy in the courtroom and here at the Capitol. Today, I'm mostly in that role of education. You have a deep lineup of folks, so I'm going to jump right in. I've been asked to provide some information about system outcomes and financing and let you know what we're hearing at the Barton Center through the cases in which we're involved about the impact of the recent program cuts and service suspensions. And I hope really that in the end, because we're not providers, so they have all of really such rich information to share with you. But in the end, I hope that this provides you with some context for what you'll hear from the rest of the witnesses that will testify this afternoon. My testimony draws on publicly available data, both federal and state, some recent reporting and direct accounts from providers, foster parents, children and youth and families who have reached out to us in reaction to the budget and policy shifts. So as you know, starting with the outcomes of the child welfare system, the system itself is designed and financed at multiple levels to achieve three broad goals. One is child safety, one is permanency. We want children living securely and in legally permanent families in a timely fashion, and the other is well-being. So I'm going to give you a quick take on what the data show. This is the work from the Children's Cabinet with respect to child safety here in Georgia. And I know this is dense and small, but I'll give you the kind of takeaways and happy to follow up. Georgia's rate of child abuse and neglect reporting, so from mandated reporters and community members, is slightly above the national average. That generally tells us that concerns about child safety are being identified and reported at expected levels. So that's where we start, walking this through from the time of report through where we get to in the foster care placement. However, Georgia's system response differs markedly from national norms. The state investigates reports at about half the rate, half the national rate. We substantiate victimization, meaning we confirm that there has been a victim of the alleged abuse and neglect at about half of the national rate. And we, as you can see from this chart, remove children into foster care at a rate that's just below the national rate. For the most recent data, that amounts to about 430 children per month that enter our foster care system. On the surface, I think those figures could be taken as kind of interpreted as some restraint from the government's perspective. From a broader perspective, and maybe I'll actually go back here. From a broader perspective, that removal data does point to some particular system pressures that I think are worth highlighting in this conversation about the capacity of the system with respect to services and programs. Most foster care entries involve parental substance use. That won't probably surprise you. That's about 41% of the entries into foster care. We also have a high number of entries for reasons of neglect, that being the allegation. Again, around 35-40% is typically true. For context, compare that with removals for these other primary types of maltreatment that generally the public understands as the drivers of child welfare. We have about 9% of children in our foster care system are there because of physical abuse, and about 3% are there because of sexual abuse. We can have a different conversation about underreporting and detection and all of that, but for where the data stands right now, those main types of maltreatment pale in comparison to what is driving our system's intervention in families and separation of families, which is really neglect, primarily in parental substance use. Georgia also stands out as a national outlier with respect to some particular reasons for removal that are reported to the federal government. Inadequate housing, you heard about that some this morning, I believe, accounts for 19% of removals in Georgia compared to 11% nationally. And parental incarceration is recorded as a reason for removal in 13% of cases in Georgia. That's more than double the national rate of children that enter the foster care system for that reason. That removals in Georgia are driven heavily by substance use, housing instability, incarceration, and neglect is probably a fair signal that poverty-related conditions and unmet service needs are major contributors to the separation of families. Feels like a reasonable deduction. In states with stronger prevention infrastructures, you would see that those conditions of adversity within families are responded to without the need for foster care. They're responded to in the community through family strengthening initiatives. We also see, and what you see on the chart to the right, which is even harder to read because that's 159 of our counties, is the great county by county variation, which again won't surprise you. You know Georgia is a diverse place. But for, again, this conversation, I would just note that that probably suggests from a systems perspective, uneven access to supports across the state. Again, not anything you haven't dealt with in many different contexts. So moving on, the other component, if you're thinking about the basic hydraulics of our foster care system, is permanency or exits. How do we get those children that have entered foster care back out into families, back out into the community? As we sit here today, there are approximately 11,000 children in Georgia's foster care in the system here in the state. That number has remained relatively stable since about 2020, though it is ticking up incrementally, gradually over time. So what you see here on this chart, that black line is really what I'm referring to. That is Georgia's foster care population tracked over time. And you see this significant volatility, right? Peaks and valleys. Again, an important conversation to have at some other time, what might be driving all of that. Of course, we're looking here at this tail end piece where I'm talking about it being relatively stable with some fluctuation. A sustained foster care population of this size does create some structural pressures on the system. We see that demand for licensed foster homes outpaces supply consistently. We see particular capacity gaps, most acute for adolescents in the areas also of kinship or relative placements, and then also therapeutic placements. Again, conversations that I know will be elaborated on through the testimony today. Because we don't have that full and robust and adequate placement array, we see increasing reliance on congregate care. congregate care, residential care, group homes, certainly appropriate and needed in our continuum, but generally not where we see the best outcomes for children. Children need to be raised by families in the community. So these pressures are associated both in Georgia and nationally based on research with poorer child well-being outcomes, higher per child costs, and greater difficulty achieving timely permanency. Those challenges around permanency are sort of depicted here at one level in this chart, which shows discharge or exit dynamics by quarter since 2009. So some specific trends to note: reunification, which is depicted in red, remains Georgia's dominant permanency outcome, but the trend has been flat to slightly declining in recent years. This suggests increasing difficulty stabilizing families within reasonable or statutorily required timelines, and not a lack of reunification itself as a goal. So we want reunification, we're having more difficulty pursuing that effectively and timely. Adoption, which is depicted here in the green section of those bars, has grown modestly but unevenly, indicating progress for some children, but limited capacity for legally complex cases, especially older youth and sibling groups. That yellow part is a relative custody or relative discharge. You'll see an interplay with the blue bar, which are relative guardianships, mostly to relatives. So you see some offset there because we've really done more to create frameworks and policy supports and incentives around guardianship. But still, guardianships remain relatively underutilized compared to many peer states, which points to an urgent and pressing need to support relatives more with subsidies and other supports to help them navigate the court system, services, financial resources. There has been, just so you know, some new federal rules that were issued in 2023 that would allow DFACs to create separate, simpler licensing standards for relatives and kinship caregivers, making it easier for them to become licensed foster parents, which then means they have access to the same per diem that foster parents do, and then reducing some other barriers as well. So that's a new opportunity. Lastly, that purple bar at the top is what's referred to here on this chart as non-permanent. That really, for the most part, represents the kids who are emancipating or aging out of the foster care system. And that remains a persistent issue in Georgia. Pretty consistently, we exit about 500 or so youth every year to emancipation, meaning that they're without family-based legal permanency. And then lastly, the Barton Center, as a dashboard measure internally, we track the rate of family separation. This is not a federal measure. This is a bit of a conglomerate or amalgam of federal measures. What this metric represents, bottom line, is the number of days that a child in Georgia is not with family, meaning days placed in a non-relative foster home, a group home, or institutional setting, or on runaway status. Again, the bottom line for us being that sort of a broad capture of the outcomes that we are looking for is really reflected in the idea that every child should be safe with a permanent family. So this kind of represents that. So that takes us through safety and permanency. As we turn to well-being, you are aware that well-being outcomes encompass physical health, emotional and behavioral health, cognitive and educational development, social skills. When the federal government added this outcome area to kind of the child welfare paradigm, it was really intended to move systems beyond thinking about just safety to include those broader life conditions like stable housing, relationships, resources, et cetera. This committee has taken lots of testimony, explored some of those sub-issues extensively. So I'm really only going to flag one today, and that's education. I want to make you all aware that there does seem to be an unanticipated consequence of House Bill 268 from last year. That's the school safety bill, that omnibus school safety bill. And that is, we're hearing and being drawn into cases throughout the state where some local school authorities are not enrolling children in foster care timely in school because they're waiting for the transmittal, the compilation and transmittal of that set of documents that's required by House Bill 268. That is in conflict with a whole set of state and federal laws that say you've got to get children in foster care enrolled immediately and not delay even for records. The records can follow later. So I just want to make you aware that that's maybe something worth, or maybe you'll hear more about, but something maybe worth exploring further. But we also have persistent endemic challenges with education for children in foster care. Those outcome areas have been deficient for some time, challenging for some time, which is why even in the Kenny A lawsuit that we've had for 2.5 decades, there are education outcomes written into the federal oversight of the system. The Georgia Department of Education supplied data to the Children's Cabinet showing rates of chronic absenteeism for children and youth in foster care. That's a school measure of the percentage of enrolled students who miss 10% or more school days for any reason. The overall state rate is 26%. The rate for children in foster care, I think I want to emphasize here, for whom the state is acting as parent, is closer to 30%, especially in the last few years. So we know that chronic absence means children are not learning. Unsurprisingly, research has shown a steep relationship between missed days and graduation odds. Studies also show us that chronic absence impacts broader domains of personal well-being and development, which I think is something to note when we're really talking about a child or youth in foster care who may not have continuity of routine or stability of relationships outside this classroom, that school really becomes something so central beyond the education goal itself. So the consequences of the recent program cuts and service suspensions, I would say in what reached my office, I would describe them as immediate and significant in all of these outcome areas. Upstream services intended to keep families intact, such as parenting supports, visitation, behavioral therapy, respite care, and family assessments, have become harder to access and have been paused entirely in some instances. Specialized services providing education supports like to achieve those graduation goals, and some specialized interventions for children with disabilities or complex medical or developmental needs have been abruptly discontinued, which causes immediate destabilization for that child or youth. So what research would tell us is, in fact, what we're seeing, which is that well-being outcomes deteriorate first as children are destabilized by the loss of these supports and the loss of the relationships through the people that deliver these supports. But because safety, permanency, and well-being are all interdependent outcomes, failure in one certainly predicts failures in the other. So what we're hearing, directly hearing a lot of confusion and uncertainty about the current status of service authorizations, access to the routine and core and essential services that have always been provided within our child welfare system, which again are sort of routine in the case management process. Youth parents and court professionals have told us about canceled visitation and shortened visits. Allison mentioned that. I think you'll hear more about that. I don't think we need to draw those connections for you about how problematic that is when we're trying to reunify a family or just maintain a child's general sense of health and well-being and identity and belonging. Provider staff have told us that they've been directed to contact clients to terminate services such as parent aids and respite care. Treatment providers have shared accounts of delays in connecting families to services due to the new process, requiring that paper service authorizations be submitted from the local level to the state office for approval. Foster parents and children's lawyers have shared concerns about decreased per diems, which may affect their ability, placement stability, their ability to continue to provide care for a given child. One memorable example came up recently where I was told by a child's lawyer about a developmentally disabled infant whose foster mother lost her enhanced per diem and also her access to respite care, which were really those critical supports that allowed her to accept the risk and challenge of being a foster parent to a child in that condition. And so there was some concern that she wouldn't be able to continue doing that. Case managers and program staff are reporting really just kind of suffering under some of these additional burdens. You heard about transportation, that's been crippling to add to their requirements, and also just generally expectations that they manage increasingly complex situations with fewer tools. The temptation, I'm sure, is to dismiss these and other accounts as isolated anecdotes and outliers. And while not all impacts are fully yet represented in our administrative data, because the data lags the effect, it will be. And sudden fiscal contractions produce pretty predictable effects, including reduced placement stability, increased strain on foster parents, fewer available foster homes, greater reliance on higher cost placements, downstream effects that include elevated child safety risks, delayed response, increased foster care entries and re-entries, entries into other systems. You can imagine juvenile justice being a primary one, declining reunification rates, longer stays in foster care, the workforce strain that we just touched on, and ultimately higher long-term costs, both in human costs and actual direct costs. Those reasons for the service suspension and program cuts, the agency pointed to its inability to draw down federal Title IV-E funds, implementation of QRTPs to sort of mitigate, soften the negative effects of the Federal Families First Prevention Service Act's congregate care limitations, and lack of TANF funding during the federal shutdown. So I think it makes sense then that we consider the investment decisions that have been made in child welfare policy choices with these measurable outcomes. As you know, of course, there are a mix of federal dollars, state dollars, and local dollars invested in this system. In Georgia, we rely most heavily on TANF and state funding to run our child welfare services, our system in general. The federal share, we hear a lot about Title IV-E. You've heard a lot about Title IV-E. It is a complicated funding stream. It is the most robust one available to child welfare because it's still one of the few remaining entitlement funding streams at the federal level. But that federal share, particularly through Title IV-E, it does offer a really significant match, but only for a tiny fraction of the children who qualify in our system. Title IV-E pays for core operations of child welfare, including foster care maintenance payments, incentives for adoption and guardianship, though we don't participate in the federal subsidized guardianship assistance program, and a broad category of administrative costs. Works as a reimbursement scheme for all eligible costs. The state can claim up to 50% reimbursement in most cost areas, and then beyond that, like 75% for training, for example, and then be repaid. But again, that's true for only about a third of the children in our foster care system, because there are really particularly one restrictive eligibility criteria that effectively means in practice that a child has to be removed from a family who is deeply poor. As a technical policy matter, it's tied to the 1996 AFDC rates, a program we don't ever have. I haven't had since, the mid-90s, and a rate that was set and never adjusted for inflation. So we're talking about families who are deeply poor, and so we don't have that many children that qualify. The opportunity for Title IV-E to really leverage it comes from a recent federal act called the Family First Prevention Services Act, which was passed in 2018. The goal of that act was to promote two broad policy aims: family-based care for children, and also prevention services to keep children out of foster care, to prevent unnecessary foster care placements. And they did that through a refinancing scheme, because that's how the federal government influences what we do in this area at the state level. So for the first time under this new law, the state can claim federal reimbursement for the provision of evidence-based mental health, substance use, evidence-based mental health, substance use and treatment, and skills-based parenting to prevent children from coming into foster care or returning to foster care. The law also imposes restrictions on federal funding available previously for most base congregate care, kind of that base group home environment. The state can, as of October of 2019, states can only seek federal reimbursement for that base level congregate care for the first 2 weeks of placement. There are a set of specialized residential congregate care options that are still tied to federal funding. One of those, which is the new innovation under Family First, is what you've heard about as a QRTP, a Qualified Residential Treatment Program. That program, to qualify for federal funding, of course, has to meet federal statutory criteria. Importantly here, Title IV-E is not a funding source for direct financial support to families or for therapy or medical expenses. For those, we have expenses, those medical expenses, we have Medicaid. For direct support to families, we have temporary assistance to needy families, TANF. Georgia receives about $330 million annually in a block grant and has broad discretion to define the services that will be paid for broadly to help low-income families with children achieve economic stability. Any unspent funds can be carried over and maintained in what is often referred to as a reserve account. The reported balance as of the end of fiscal year 23 for Georgia's TANF reserve was over $205 million. One of the express goals of TANF is to provide assistance to low-income families so that children can be cared for in their own homes. Yet Georgia makes little of the funding available in the form of economic and concrete supports, things like cash assistance or childcare that's directly provided to families. This is primarily attributable to a financing strategy employed to mitigate the impact of the Great Recession in 2008, at which time TANF began being used as a budget balancing tool to fund child welfare and foster care, and we've never really revisited that decision in full. One direct effect of this TANF financing strategy is that child welfare crowds out basic assistance and core economic support programs that could be used to stabilize families and mitigate the financial stressors associated with poverty that often then show up in child welfare as reports of neglect. Because TANF is a more flexible and discretionary source of fund than these other federal child welfare funding streams, again, particularly 4E, which we just touched on, we continue to use it to reinforce and expand our system infrastructure rather than invest in direct supports to families. As one example, in the renewal of the TANF state plan that's currently available, the department is proposing to fund the Special Victims Unit to add positions of state employees to use TANF for those purposes. And so we continue to follow that same pattern of reinvesting in the system itself and not in the families directly. So that's going to continue to drive foster care, use foster care, extend it in ways that it's not really meant for, doesn't need to be used for, and continue to strap then whatever services capacity we may have. We want finance policy, we want a finance policy rather to get the outcomes that we're seeking. Federal financing tools are most effective when aligned with outcome-driven services, not emergency stopgaps. This is a high-level summary to continue to guide your understanding of what we'll navigate here. And it's really because the services and programs that these folks are concerned with, that you all are concerned with, are primarily funded through TANF and state funds. So some realignment, refinancing, that's kind of part of the broader conversation here, not necessarily the task at hand immediately. But where we see opportunities is to think not of Medicaid as a true substitute for all of the services that child welfare is not currently paying for or paying differently for, but that clinical, medically necessary care for Medicaid eligible children in foster care should be billed to Medicaid. The problem is this area of services, this whole array of services was funding a lot of services for families who are not Medicaid eligible, or services, as you've started to hear, that are not deemed medically necessary. So filling a lot more of those gaps that families need to be strong and healthy. Of course, for those services billed to Medicaid, our CMO should be held accountable for the quality of services and the adequacy of the provider network. Title 4E should be maximized by fully implementing the Family First Prevention Services Act. And by that, I mean both legally compliant QRTP models and prevention services that will avoid unnecessary foster care placement. And TANF dollars then should be freed up to use for what they are best designed to be used for and provide cash assistance, childcare, family preservation, and prevention services that are not medically necessary. That is hopefully, again, intended to provide you with some foundation of context for which you can then understand the considerable views and experiences and expertise of the folks who will continue to speak with you this afternoon. I'm available for any follow-up or questions that you may have.
All right, thank you so much. That was a lot of information, and that is phenomenal.
How close did I come to 15 minutes? I don't know.
No, that was great. I mean, wow, that was phenomenal. All right, so we do have a few questions for you, if you don't mind standing by. All right, the first one we've got Representative Sharper. Please go ahead with your question.
Thank you, Chairman. Thank you so much for being here. You mentioned there's a lot of money in reserve, right? And then we had the question this morning about pre-K dollars. And I see in here, when we look at the Georgia TANF spending, that we're not putting anything in pre-K. Is that correct?
Yeah, that's right. So you see the spending outlines here. These generally map to those categories that TANF can be, there's authorized spending for. And you see the comparison between the areas where Georgia is most deeply invested with that funding source compared at least to what you see nationally. And so I think the places where there has been advocacy, maybe even critique, come from the absence of investment in those concrete supports that we know could mitigate the financial stressors that are associated with poverty that then produce neglect and that big driver of 40% entries due to neglect. Not all of those are the same, they have different circumstances, of course, but think about, if we had made a greater investment in childcare and how that would affect the volume of cases that come in for inadequate supervision. Think how much if we invested differently in basic assistance, cash assistance, how that might mitigate some of these, concrete support cases where parents don't have enough food or clothing or shelter. And so that's really the areas of choice, policy choice that are represented here. So there are other opportunities as well, for sure.
Because I know they mentioned a 6.5 hour day long for pre-K, and maybe a lot of parents can't, don't have the money. I'm wondering if there's some way we can utilize some of that money to help these parents with the before care and after care of those 6.5 hours, which could bring up maybe our pre-K and also touch some of those areas, get the kids in front of somebody that if there is a problem, they can address and get the resources they need. So.
Yeah, that's right. We have mandated reporters, of course, in those settings. That's been a real issue for not just Georgia, but when we think about the vulnerability of young children and how young children are most at risk of entering foster care for that reason, it's often because we don't have that detection system in place. Children aren't in school in those younger years, and so we're not able to know and therefore provide appropriate responsive interventions.
Thank you. I just want us to be aware of that, something that we really need to look at. Thank you.
Sure. Thank you.
All right. Thank you. Thank you, Representative Sharper. All right. Representative Rice, I do believe you have a question.
Yes, thank you very much. I appreciate this information, and it was a lot. But I wanted to get your insight on something on the permanency outcome and takeaway. What do you have any insight on why we are having more difficulty of making those placements within 12 months? I see the adoption rate is also significantly down. Do you have any insight that you can offer us on what those delays are and why that changes there?
Certainly there are a number of contributing factors, to be clear. And in any individual case, you might have a different set of drivers. From a systems perspective, we see delays in adoption because we have two levels of court involved in the adoption of a child out of foster care. The dependency preceding the abuse and neglect proceeding and the termination of parental rights is going to happen in juvenile court. And then that whole case has to be transferred with all of the requisite documentation and proper legal filing to Superior Court and be put on that docket to be heard by a Superior Court judge for finalization. So in two places in that process, we encounter more significant delays. One is in getting all of the material, all the records and documents prepared, compiled, and in the right legal form when we're moving from termination to that adoption finalization. So that requires, DFACS case managers and service providers and lots of folks are collecting a certain set of information that has to happen timely. For workers, I was one many years ago in a different state, so I want to disclaim that. But I can tell you that, when a case is stable and you have all the pressures of everything else going on, it's easy to let that case kind of be put on the back burner, right? So there's a little bit of a workforce capacity issue. There's the actual extensive documentation that's required. And then it's the transfer from one court process to another. And sometimes getting calendared for, I've also done adoption work in the state, sometimes getting calendared for that final adoption hearing in a Superior Court in some places in the state can take too long. So those delays all add up to a longer delay. For other permanency outcomes like reunification, that really to me is a reflection of service capacity. That really is about, are we making enough contacts between our case managers and the parents, case managers and foster parents, case managers and children, and integrating the set of information and really being intentional and thoughtful about a comprehensive service plan that speaks to the needs of that family. And that's just hard to do. It's getting harder to do, which is why we're having this conversation today. That is the hard work of this system. To put fragile families back together in secure ways requires a whole lot of capacity and skill. So that kind of speaks to some of that. If there are other particular areas, can address them but those are the two big, I think, drivers of our permanency outcomes with respect to the timeliness of those outcomes.
So just to follow up on that. So I'm foster parent and adoptive parent. So I understand the two court system and remember going through that, but that's remained the same. Are we having just a little bit more slower case processing? Is this on the judicial side that you see a difference?
I hear both, and my experience has been both. Sometimes it's a court-based delay. Sometimes it's that worker or the Special Assistant Attorney General representing DFACS hasn't initiated the process or hasn't facilitated the completeness of that process in a timely way. That's really where those individual case examples, it could have different narratives attached to them.
Right. And one more, and that's my final question, sorry. And a lot of times you're saying sometimes there's delays and the touches to, the parent home. I know that, having the workforce and social workers, that's a real challenge that we have. Are we seeing high turnover in the social workers, and sometimes that's causing the delay in the process of these cases?
You know, stability, both the retention, recruitment and retention of the child welfare workforce is one of those endemic challenges. I'm not really, to be honest, aware recently. I know there have been questions posed to the department to get information about turnover. Those numbers and the way that we collect those data, those metrics across state government are complicated, right? Like how we count positions and whether someone's just on leave, which makes them unavailable for a case, but they're coming back, that kind of stuff. So I would say that I would need to absolutely defer to the department and whatever data they can provide to you about workforce stability. That I know at times in the recent memory, but probably going on, 3 or so years ago, we were at a, 35% turnover rate. And so that is highly disruptive given the real need for consistency in our cases for decision-making purposes, for service connection, for stability for the families, all of those things. But I don't have the current numbers. I don't know that those are published publicly in a routine fashion.
All right, thank you so much for your comments on that. Thank you, Representative Rice. Let's see, I've got a question from Representative Oliver.
I expressed a little frustration a little bit earlier today about failure to comply with the federal law on providing transition plans that resulted in greater cost both to the individual foster care child and to society. I'm concerned that this deficit relates to noncompliance with the Families First Act. We had a lot of hope about prevention being provided, and I'm troubled right now about trying to put the deficit together with possible other management issues under Families First and the obligations under all these timeliness issues. If we fail the basic statutory benchmarks, does it result in more money? Can you comment upon that in relation to the deficit?
In full disclosure, both because I'm proud of it, but also shows my bias, I helped write the state's prevention services plan to be approved by the federal government. So I'm familiar with it and familiar with the decisions, both in terms of the strategic financing choices that were being made, as well as the policy aims at that time. The idea of Family First is, some people lauded, I think certainly the advocacy moment, that could transform systems. I'm actually not subscribed necessarily to that. I do think there's a great opportunity for some significant improvement and to do the work that everyone in the system has been wanting to do for so long, which is prevent children from coming into this system and reserve the system to respond to those cases that are really acute and serious. And I think it does that in principle. There are, certainly any federal law, and particularly those that are wrapped around these financing mechanisms, are complicated to implement. But I do think we have the right policy on the books. We have all the compliant laws. I've helped with those, with all of you over the years when we were preparing to implement this. So I do think there's a readiness. And I have characterized publicly that I think our implementation of Family First has been anemic in this state. I work in a number of states on these same implementation issues around this act. And again, while I don't think it is the panacea for all of child welfare problems, I think leaning into it through the refinancing both allows us to access services and have interventions that are more responsive and effective to what families actually need, and then to sort of, delimit the system in the way that we've been wanting to do and use those interventions differently. So the money is the driver of those policy aims. Georgia neither has, in my understanding, compliant QRTPs, so we're not drawing down federal money, and we couldn't, in my understanding of the features of those pilots. And likewise, we're piloting the prevention services and not drawing down 4E funds for those either. I will say, by the way, it's important, the restrictive financial eligibility criteria that keeps us from leveraging 4E for foster care doesn't apply to prevention services. So we have a greater potential there for funding those services with more federal money. And because we haven't been compliant in either of those financial drivers, we continue to then have to use things like state funds, and for us, a lot of TANF, to fund the status quo, right? So we're funding base foster care. We can't use federal money anymore for that. So we're just continuing. We didn't change our utilization of congregate care, and in fact, it's going up. So we have to find a different funding stream. If we plug that hole with TANF or state dollars, those more flexible funding pots aren't available for other things like services and programs and innovation of practice. So I do think that has had is a big reason we may be in this particular financial crisis. I think the other one is that with the drive to respond to the hoteling crisis, that was a pretty narrowly defined practice and policy moment. And the respond to that, a big strategy for that was that the enhanced foster care payments, the enhanced rates. And so I think over time then, many cases came to be defined as exceptions to and sort of novel in the way that what the child's needs were. And providers and foster parents and others in their own minds and in their own defense started negotiating for essentially non-contracted rates. That's the reason we have contracted rates is because we can plan around budgeting in particular. And so using those kind of one-off non-contracted rates, I would say is a pretty expensive way to run a system that provides custodial placement for 11,000 children.
May I have one follow-up question just to share with my colleagues? The example, and tell me if I'm right or wrong about this, because I easily could be wrong. The example of a prevention service for the third most common reason that a child loses family and has to go into care is housing.
Mm-hmm.
All the tension we have with the families in the extended stay hotels or under the bridges, families with children, a third of the homeless are families with children. Couldn't we be using prevention money for those families that prevents the danger to those individual families and to society, but not spending it that way?
Two-part answer to that, Representative Oliver. One is, so to be clear, Family First housing was the one thing that got negotiated out at the federal level. Those monies that are not directly available to provide housing, they are available to do what we've learned over time is more effective to respond to some of the, again, adversity within families or the deficiencies of parenting that may be associated with homelessness, right? So we can provide evidence-based substance use treatment. We can provide evidence-based parenting. We can provide evidence-based mental health intervention. So those, I think, are a big part. These things travel together in the conditions that afflict families. Housing, recently there's been a federal bill passed called the Strengthening and Supporting America's Children Act that just went into effect, I believe, in October. That addresses Title 4B, which we didn't even cover in our 15 minutes. And that's a more limited funding stream for child welfare, but it directly speaks to family preservation and prevention services. And in that new act, Congress made some very clear findings and gave some very clear direction around addressing and distinguishing between poverty and neglect, and authorized now the use of those funds for all kinds of concrete supports, including transportation and housing, and some other things that, again, can always are difficult burdens that our system routinely needs to address.
A new opportunity for federal funding that we need to manage and go after.
Correct. That's an estate plan as well that goes to the federal government. So our state commits to how we're going to use those funds. And then that goes to the federal government for their oversight.
All right, thank you. I believe you have one more question by Representative Panich.
Good afternoon. Did I hear you correctly when you said that TANF funds, which are intended to go to the child or the family, are being used to establish a special victims unit?
Yes. And that's the plan. That's the proposed use of them. So TANF, right, has really 4 broad purpose areas. I don't mean to give everyone a headache, but these are kind of the 4 big, broad, funding areas, authorized use of TANF. So TANF's a block grant. That means already it comes with less reporting, less oversight, more discretion, more flexibility. Those generally are good things that we need in our financing scheme. And it's tied to these 4 broad areas. Generally, TANF, in the history of TANF, and probably in our shared understanding, is really about economic supports for families that are financially insecure. And yet, again, lots of discretion. So we do use it to pay for child welfare services. We use it to pay for some position in our child welfare system. We've used it a lot to do the reinforcing of the infrastructure as opposed to the outward deployment of what is also available, which is concrete supports for families. And there's right now the TANF state plan. So again, this all has to be documented by the state and sent to the federal government in terms of our intended usages. That state plan is up for renewal. So it's publicly available. And the department has included both the hotline for reporting and responding to commercially sexually exploited children, and also the special victims unit as proposed authorized uses for TANF. That's arguable. Reasonable minds are going to differ about that. But I will say that's in the pattern that Georgia has gotten accustomed to, which is to use TANF in all of its discretion flexible form to really invest in the system itself, as opposed to other choices we have, like the ones we were just talking about, where we could use it to keep people from ever being system involved. So those are the policy choices that we have to make, and the funding can be used in either of those directions.
Can I ask a follow-up? So the Special Victims Unit, this is law enforcement.
That's my understanding. And case management, I think it's a specialized team of law enforcement and case management specifically tasked to investigate instances of suspected or known missing or exploited children in foster care, and then coordinate between child welfare and law enforcement for further action.
But law enforcement now coordinates with DFACS in order to decide whether to prosecute or not.
We have lots of protocols and a lot of established kind of foundation to ensure we do that in the best practice way.
Do you know what the department's reason to have a second law enforcement related to children would be?
To them.
Okay, thank you. I will ask the commissioner that when she attends.
All right. Well, I look forward to doing that. Thank you very much. All right. Thank you. So
Thank you. I appreciate your patience and your
No,
thoughtful
this-
interest. Thank you.
thank you so much.
Sure.
I appreciate this very much. And thank you for being here today.
Amber, do you want me to do anything on this up here? Okay, thank you.
Thank you so much. That was good information. Next we have Cindy Simpson with Murphy Harps Children's Centers, maybe on Zoom. Let's see. No, Zoom.
I am on Zoom. Can you hear me?
Computer audio is on.
I can hear you. Sorry.
Okay, sorry about that.
Great.
Okay. I appreciate you allowing me to be on Zoom. So appreciate that. And I know from my picture, that's just kind of where kind of relax. So that's what that's all about. I'm going to keep this really short because some of the things you've already heard from Allison and Melissa, and I'm sure you're going to hear more of it. But some of the cuts have definitely affected providers, especially for the transportation. And I will say that Murphy Harps, with its multiple levels of programming, from CCI to foster homes to QRTP, and with the Pilot Evolve program, we have decided to provide our own transportation when children need to have a visit and or go to court. But with that came some economic problems, and that is the cost of insurance. So we have helped individuals get the right kind of auto insurance in order to transport children. So I am concerned that budget cut has impacted providers, but it's also, most importantly, it impacts the children because they need to have those family visits. They have to be in court when they are supposed to be in court. So that's something definitely to look at with cuts. The other thing is, as you well know, to begin with, as providers with foster care youth, it's, as Allison said earlier, we already work at, only the amount that we get paid only covers anywhere from 65 to 75% of the costs. And those costs are going up. And so that's something for the state to really take a look at. And that's because if you've noticed, the food prices have gone up, transportation has gone up, clothing has gone up. So that's something definitely to consider and take a look at, is the typical rates there are. The only other thing I really wanted to take a look at is, well, two other things, is as we move forward with whichever CMO, and I'm still totally confused on which CMO is going to be the next Medicaid foster care provider. But I'm not here to promote one CMO over the other. Because it hasn't really been provided or decided, or I'm not sure exactly what's going on, but we need a process in place for if there's a change or whatever provider is going to be contracted with, there needs to be a process for providers to be involved. And if we're changing providers, then there's going to be a change system. The last time we did this, it took providers a year to a year and a half to make that adjustment, and there was a lot of money lost and a lot of youth not seen for mental health reasons. So, or they needed to be seen but couldn't because the system changed. And so if they got providers in place and kind of took it in steps, I think that needs to be looked at and considered. The other thing, with that is just, taking a look at the whole billing system and to be able to become a core provider. As Allison noted, even if you are a core provider and you begin to grow and you want to add another location to your core provider, or your core provider 2, and you're in Cedartown and now you want to add a location of Augusta to your core providership, it will take you a year to a year and a half to get a Medicaid number for Augusta. That is a problem. And that's a system error that we need to look at. So I wanted us to kind of be aware of that and begin to look at that. The other thing that has come up, and I don't know if the other providers might mention this, but years pass as you begin to look at what children, what's the best placement for them. So a child is going to be placed in a foster home, or they're referred to a foster home, or they're referred to CCIs, or they're coming out of a PRTF and they're looking for a placement. We were, and I don't really want to get DFACS upset, but we were told like a month or so ago that you could no longer interview the child or meet the child even virtually before you looked at where the child's going to be placed. As a provider, we have a hard time with that. I definitely see the side that DFACS is looking at. Another rejection is hard for the child, but also not the right placement is hard for a child. And you can't learn everything on paper. Also, I want to hear the child's voice. What are they interested in? What do they like to do? What makes them angry? What's a trigger? And what coping skills do they know? I want to know all those things so I can identify the right home with the right foster parent with the other children in the home. And not being able to do that, just look at everything on paper, is a problem. So I think that's another, and I do agree that there were providers that had one open bed and they interviewed 20 kids. That's hard for the children and that's a long process. But it would be good to get with providers and DFACS together to look at what's the best system for an interviewing system or non-interviewing system. Well, how can we do this? Can we do this in steps? So that's those are the things I wanted to bring to the table and have you all kind of take a look at.
Thank you. Are there any questions for anyone? You did a great job of presenting, and I'm sure we pretty much all wish we were sitting where you are right now. Thank you. We've got it. Appreciate it.
If you're asking me questions, I can't hear it.
I think you did so well. We don't have questions. We're just jealous about sitting where you are right now.
Sorry, I'm really not there. It's just
I know. We know that, but we want to be too.
Right. So, well, if anybody does have a question about QRTP, Murphy Harps has the QRTP program.
They do.
I know Melissa mentioned it several times, so.
And we appreciate that work you are doing right now with the QRTP. Thank you
Yeah,
so
I'm excited. It's got an 81% success rate of step down into foster home or other placements, and they're only there 60 to 90 days.
That is good. Y'all are doing a great job. Appreciate it.
All right, thank you.
Mhm.
Appreciate it.
Okay, so next we have, I believe, empowerment. Devin Rudy. That is great. We'll switch it up, get y'all there. Just make sure when y'all are speaking that you are speaking into a microphone, especially for, how we're streaming this.
All right.
Great.
Good afternoon, everyone. My name is Devin Rudy Johnson, and I am here serving with Georgia Empowerment by way of the Multi-Agency Alliance for Children, otherwise known as MAC. Our mission is to ensure that anytime policies and practice decisions are being made in the state of Georgia about young people in foster care, that their lived experience voice is involved in those final decisions. Two of my colleagues, who are lived experience experts, would like to share their experience and insight with you. But first, I also want to share with you a message from a young man who came to us. We did not solicit it. He came to us with his frustration on December 4th. He wants to let you know how it is impacting their life currently right now. And I will also add that he has worked very hard in school and is set to graduate in May, which is a year early ahead of schedule. But for some context also, before I read his statement, he attends a specialized school that best fits his needs. And he earned the right to go in person, and it has made a huge difference by being able to do that. However, it's quite a distance from his foster home, and his foster parent cannot transport him there as a result. So I will refer to this young person as RC, and he says, for the last couple of weeks, I've been very frustrated and overwhelmed because I can't go see my family. I've been missing school, and I don't have my BA, otherwise known as a behavior aid. My BA and I have built a brotherly relationship, which means I treat him as a big brother, and we do brother stuff, which is something I never had until I met him. I haven't been able to see him, and it's very hard for me. Also, school has been overly frustrating because I worked hard from the beginning of starting the academy to be able to enter the school building and interact with my friends and also my teachers and do activities with them. And now something I worked hard to earn was taken from me, and it's not my fault. I learn better in person, which is really putting a toll on my mind right now. My visits are also very important to me because I really love my family. When I go on my visits, it reconnects me to my family and everything that's going on with them. And I haven't been able to go. I've only seen them twice since September. And when I did go on Thanksgiving, I couldn't stay as long as I normally would, which is frustrating. Also, I really appreciate my foster parent for letting me go and paying out of her pocket for an Uber to make sure that I didn't miss time with them. But I don't want all of these changes to impact my ability to stay here. I really like it with my foster parent. So I want to encourage that the people with all the power to make decisions, that kids like me in foster care can have what we need to have a fair chance. And RC is observing today. We have some more statements that I believe I've provided hard copies to y'all. I've also provided an email copy to Ms. Amber because there were more people that wanted to share, but we also know that there's a time constraint. So there's a few more in that packet as well. We're happy to answer any questions when we are done speaking. But with that, I will pass this over to Reginald. Yes, please.
Good afternoon, everyone. My name is Reginald Holloway, and I am also a former foster youth with close to 17 years of lived experience in the care system. I'm also a graduate of the University of West Georgia as of fall 2024. I'm here today to share what instability in the foster care system actually feels like and how the loss of key supports makes that instability worse. During my time in foster care, I experienced multiple placements in different homes. Each move meant a new home, new rules, and often a new school, and starting over again. Within those disruptions, they didn't just affect where I lived, but they affected my development education, and overall my sense of safety. Like many children in care, I also had siblings placed in different homes, some far apart with them being halfway across the state of Georgia. And maintaining those relationships was difficult, even when transportation support existed. Without it, sibling connections can quietly disappear, leaving children to carry the loss on top of other losses, which creates trauma. These services that have recently been cut are the kinds of support that reduce these disruptions. Behavior aids help stabilize placements. Transportation allows children to stay connected to siblings, schools, and court. Educational advocacy helps ensure that frequent moves do not permanently derail a child's future. When those supports are removed, the system doesn't become more efficient, it becomes more unstable. Children move more, caseworkers carry more, and the trauma compounds. I don't share my story nor those things as a story from the past. I'm sharing it because children in Georgia that are in the care system are experiencing this right now, and the consequences will follow them into adulthood if not careful. If Georgia wants better outcomes for children and families, these supports must be restored because stability should not be looked at as a luxury in foster care. It should be seen and cherished as a foundation for healing, growth, and permanency. Thank you for your time and consideration.
And now I'll pass it to Michael.
Good afternoon, committee members. My name is Michael Conger, and I'm a lived experience leader with the MAC Georgia Empowerment Team and a second-year PhD student in my public policy and administration degree. I want to state that these views are my own, shaped by my time in care. I will be speaking to y'all today on the effects that these budget cuts will have in rural South Georgia compared to metro areas. In many parts of South Georgia, transportation is the only way youth can stay connected to both parents and siblings. Public transit does not exist in South Georgia compared to metro areas like Atlanta. Distances are long and caregivers often cannot cover the cost of transportation. If reunification is the goal, youth must be able to visit family consistently, not just when someone has extra gas money. And in South Georgia especially, counties often don't have enough foster homes, which pushes youth to be placed 3 to 5 hours away in North Georgia. When I entered foster care, I was entered in Berrien County, and I was eventually placed in Metro Atlanta because there are not enough homes in foster care in South Georgia. When distance becomes a barrier, family connection becomes almost impossible. Educational support is also essential. Youth in care switches schools more than most students will ever experience. I personally switched schools 6 times in 4 months in my senior year of high school when I entered foster care. Without tutoring or credit recovery, teens fall behind for reasons that have nothing to do with their ability. Graduation becomes harder because access is limited, not because motivation is missing. And extracurricular activities are more than extra. They are a lifeline, place for belonging, confidence, friendships, emotional regulation, connection, and normal development. Whether it's sports, band, agriculture, theater, or robotics, these activities help teens stay connected to schools and community. Removing these supports may save money today, but it risks longer time in care, more instability, and fewer successful reunifications. In South Georgia, where geography already creates barriers, the impact will be even greater. If we want reunification to remain the goal, we have to fund the supports that make reunification possible, consistent family connection, access to education, and opportunities that help youth stay grounded and hopeful. Thank you for listening and for considering the lived realities behind these decisions.
Thank you.
Thank you. And thank you both for sharing your story. Glad you're strong today. I'm glad. Looks great. Great educational opportunities you have seized. So, and that's something you did, period. Are there any questions or comments from the committee? Do have.
All right, we're going to start with Representative Oliver.
This isn't a question. You have other empowerment folks with you here today. Would you ask them to stand?
Yes.
How many folks are involved in this engagement from former foster care?
With empowerment,
Mhm.
we have a policy team, and that's made up of right now about 10 people. We're growing to about 12. But empowerment as a whole, like we have like 400 people in our database. Once you're an empowerment member, you're always an empowerment member, and that's on purpose. We don't have a cutoff age because that feels just like foster care. So we're able to stay a community and fellowship with one another and support one another as you know, at any point in your life. But yes, we have TW or Ty right here. And there's they have a statement in the packet as well. And Rodriguez is joining us too.
Thank you. I think you all have a lot to offer. I appreciate you coming.
Thank you.
Thank you so much. And on a personal note, thank you both for being here. I want to echo what Chairman Dempsey said. I've been a part of our CASA Board of Directors in my judicial circuit for the past 6 years. And you guys, that's awesome. Thank you for pursuing education, and thank you. You have a story to tell, and a story that's going to impact a lot of people, both of you. So thank you for sharing it with us today. All right, Representative Sharper, I believe, has a question or a comment.
It's good. Thank you guys for being here, and all the others that came to support. And Michael, speaking up mainly for South Georgia. So I appreciate you advocating. I see you social media and different things. So I really appreciate you, Valdosta area. So thank you personally for being here, all of you. Thank you.
All right, thank you so much. And Representative Glaze, I believe you had a comment or a question.
Yeah, just a comment. I certainly want to say thank you to those who came today, those who were able to speak. But I also know that you represent those who fallen through the crack. And while we say that your work and what you've done in your life is commendable, I do know that you're speaking up for those who were not able to make the choices, didn't have all the needs, and you're afraid that there might be more on the way with these cuts. So I hear you. I'm one of those children who was the oldest, who took care of my siblings and my mom so that we didn't end up in foster care. And so my heart is wrenched by this effort today, and hopefully we can make a difference. You guys are sitting there, but for the ones we can't see today. So thank you again for your testimony.
Thank you, Representative Glaze. That's a wonderful point. You're speaking for the ones who can't speak. So thank you for that.
Mhm.
And that's all the questions we have right now. So
Thank you so much for giving us the time and space.
Thank you for sharing your stories. We appreciate it. Okay, next is Brittany Kluger from Family Menders.
Your screen. Good afternoon. Can you hear me okay? Close it? Yeah. Thank you. Good afternoon, Chairwoman Dempsey and committee. As everyone said, thank you so much for allowing us to speak today, give you the perspective through our lens of the crisis that we're currently in. So my name is Brittany Kluger, and I'm the CEO of Family Menders. We have been a partner and delivered service provider for DFACS since 2003. For decades, DFACS has relied on over 200 direct support provider agencies like ours to ensure child safety, stability, and reunification. I'm here to not only represent Family Menders, but also those 200 plus direct support agencies that provide services under the leadership of DSU Director Kristen Tolliver. These providers serve thousands of Georgia residents in each of the 159 counties. We provide services across the entire continuum of care and are often the sole support for the most vulnerable families in Georgia. We provide services ranging from prevention to support of those families involved with the department that still have custody of their children, to services for foster youth and families working towards reunification or adoption. We provide needed supports for our fellow foster homes, group homes as well.
We are the frontline services for Georgia, and DFACS has always looked to us to help fill in the gaps. I am a licensed professional counselor. I'm not a public speaker, so I'm very nervous. And I'm a certified professional counselor supervisor. I've spent my entire career invested in child welfare with experience working at both DFACS and DJJ and the last 16 years on the provider side. During this time, we have weathered many storms, but none as dire as the current situation. Department of Family and Children's Services guidelining principles include empowering families and providing effective service. However, on November 7th, the directive was issued to suspend contracted services due to a federal government shutdown and budget deficits. This move has been described by some as potentially impacting DFAC's ability to fulfill its core mission of prioritizing the safety of Georgia's children and partnering with families on their path to independence and build stronger communities with caring, effective, and responsive service. The November 7th directive required new contracted services for assessments, counseling, behavioral aids, parent aids, wraparound care, and other prevention measures to receive written approval from a state official before proceeding. They then clarified that they were managing the existing services and not outright halting them, while requiring state-level decision-making for those new services. However, during the last 6 weeks, for my agency alone, we have gone from assigning nearly 100 referrals a week to 5. This is an alarming number because we all know that the needs of the most vulnerable population in Georgia has not decreased during this time, yet services are not occurring. We have been told by DFACS case managers that the tedious approval process of 3 people at state office approving the entire state's amount of service authorizations is very backlogged and time-consuming. Furthermore, our agency has nearly 1,200 services that are set to expire in 13 days. We are not alone. Most delivered service providers across Georgia are in the same position because case managers primarily use December 31st as the end date on service salts. Without reauthorizations on current cases, the statewide provider network will cease to function on January 1st. As a clinician, it's extremely disheartening to see the current level of client abandonment and case regression occurring due to this directive. Providers that have been working for a family for months have had to halt all progress and rapport with clients due to the service authorizations ending and these long wait times. Furthermore, many service requests are being denied by state office, and DFACS case managers are being told to look at alternative community services to start completely over with a new provider. Traumatized children are being re-traumatized as they have built a caring and trusting relationship with their service provider, and that relationship has abruptly ended. This goes against every aspect of my licensure board code of ethics and trauma-informed care. Directives are harming the very children that we have a responsibility to protect. Many of the providers out in the community require in-office settings. We go to the home. We meet homeless in the park out in the community. We do understand that DFACS needs to utilize insurance services, more community services. However, the mental health provider network is already very overwhelmed. I know Allison spoke about very low on the totem pole as far as statewide. And if you switch funding sources, it can take months. There's wait lists out there. Majority of the services that we're contracted to provide are not billable services under insurance. I know someone asked about this earlier. Even if every provider became insurance-based tomorrow, it will not solve DFACS's needs. Insurance cannot be billed for parenting programs, parenting assessments, supervised visitation, transportation, or drug testing. These are the services that are the backbone of case progression, and they only exist because of the DFACS funding. A mental health diagnosis is also required to bill anything to insurance. Oftentimes, our children do not meet that threshold, which is not a bad thing. We don't want to label a diagnosis if they don't meet that criteria. While we support expanding the use of Medicaid services, it can take years. You've already heard that. And by the time that providers apply and become a Medicaid provider, they're no longer going to be an agency in service. Staff will be forced to leave for other jobs, and once that workforce disappears, it cannot simply be rebuilt. Georgia cannot afford a gap in service delivery during a time when the child welfare system is already under severe strain. The agencies like myself that are already credentialed and trained to provide these DFAC services must be able to continue serving families now, or they're not going to exist when they need us. Funding support services is a cost avoidance strategy. When families receive timely services, the state funding is actually decreased because those families can complete their case plan sooner. When services are halted, cases last longer, cost increases, and outcomes worsen. I think I can speak for every provider here that we all have ideas for solutions on how the department can save money without harming the youth and families with this current directive. The solution cannot be to abruptly stop services for families who are actively working towards reunification or these new families entering care. The halt is already creating significant harm to children, families, foster parents, DFAC staff, and the provider community. Children are not visiting their parents. Parents are not getting needed assessments to even begin working their case plan. Foster parents are being asked to transport children. This is adding enormous stress to families who have are already stretched very thin. Many foster parents work full-time, have several children in their care, and they simply cannot take to all the needed appointments. DFACS workers are also carrying a heavy burden. They're scrambling to transport, supervise visits, and manage tasks previously handled by service providers. Workers are already overwhelmed and cannot absorb this workload. This will increase turnover, which we know directly harms children as well. Family Vendors is an accredited provider, most in this room are. One aspect to strengthen the provider network and overall save state dollars is for DFACS to consider utilizing only accredited providers. It's one of the strongest safeguards against risk, poor service quality, and inconsistent documentation. And this would not cost the state any expense. However, it's important to note that takes time as well, just like getting a Medicaid contract. Accredited providers are part of the long-term solution for Georgia, but Georgia must allow time for agencies to meet these standards while keeping the provider network stable and operational during this transition. One other aspect of accredited providers is we have to do outcome scores. Many of us in this room use evidence-based support services with proven outcomes. Our data shows that these services work and are a responsible use of public funds. For last year, our outcome score, if you worked with family members and was compliant, we had a 92.42% success rate with families. 9 out of 10 families that comply with our services make measurable progress towards reunification or family preservation. The direct contributions of services we provide are lower reentry into care, prevention of abuse and neglect, which decreases foster care placements, residential care, and emergency interventions, shorter time to permanency, reduces court time, attorney costs, and foster payments, and then linking our families to community resources so they don't have long-term dependency on state dollars. To conclude, if the state does not allow authorizations for families involved with the department, children will remain in care longer, which increases both emotional harm and state cost. Case plans will stall or regress. Families who are gaining stability may lose momentum. Foster placements will disrupt due to lack of support. Got a phone call about that yesterday. Long-standing providers will not survive to resume services when funding eventually opens, and DFACS workers will face overwhelming workload increases. We urgently request that the state allow reauthorizations for all current cases that are working their cases. This will maintain continuity, keep families moving forward, and preserve the provider network that DFACS relies on. We also ask that DFACS allow services for new families that have entered care since November 7th. Children entering care cannot wait months for support. We have immediate timeframes that need to be met. And of course, the supervised visitation, the parental supports, transportation, all of those things to help stabilize the family quickly. If new families cannot receive services, then the entire case plan timeline is delayed We already had questions about why it's delayed already. Without immediate action, the harm will extend for years, and the cost to the state will be far greater than the cost of authorizing these services. We want to partner with the state. We support tightening oversight, improving systems, sharing ideas on how to save state dollars, and increasing the Medicaid-based services for those that can. But none of these goals can be reached if your provider network collapses. We need these authorizations now to keep Georgia children safe, stable, and moving towards permanency. Thank you for your time today and listening to my shaky voice. Family Mentor's motto is the quick and caring response. I'm asking you to also be quick and caring in your review of this information. Effective child welfare leadership involves guiding systems to ensure child safety, family well-being, and permanency. Commitment means being a champion for change, supporting staff, advocating for resources, and centering the voices of children and families in all decision-making. Leadership isn't just about steering the ship. It's about standing up for what's right, even when it's difficult or unpopular. It's about having the courage to challenge the processes and protocols and make necessary changes to serve all of Georgia's residents better. Your leadership and your commitment to child welfare are needed now more than ever. I did compile a pamphlet, thank you, for you to have some supplemental information. I know that's a lot. I know it's redundant to some things that have been said, but I've cried many tears the last 6 weeks, and so I just had to come and speak from my heart. So, any questions?
Thank you so much, Ms. Kluger. Your testimony gave a lot of great information, so thank you for being here. You do have a question from Representative Oliver.
Are you able to tell us, do you know how many of the 1,200 services that will be terminated this month are court ordered?
I can't tell you that. I do know in talking to DFAC's leadership, it has to be worded a certain way in the court order. So some things might be in court orders, but it's not the wording that's needed.
That's a problem.
Yes, ma'am.
All right, thank you. While everyone else compiling their questions, I wanted to ask a question. You said there was a backlog with the state getting approval for these various services. Do you have any idea or what you were told the timeline is on that backlog?
So when this all first came out, we were told case managers submit it to their county director, who sends it to regional, who sends it to state office. And we had a DFAC's leadership meeting with Together Georgia. It was stated that it would be 24 hours. And talking to case managers, ones from before Thanksgiving have still not been approved. And I got an email from one county yesterday that it could be 30 days.
Okay. All right. Thank you.
Yes, ma'am.
All right. Well, thank you so much.
Thank you. Thank you.
Oh my. Thank you so much. You are a great speaker. Thank you for sharing your heart. True, I do have one question, just one question, if you can come back for just a second. We've heard today and sort of in the work leading up to this about the challenge that transportation is, and you brought that up, transporting. What would be an answer to that? Like, what do you see that could be done differently?
We thought we had the answer because in October, they cut that rate in half and we absorbed that. But now we're not getting, I have not received a transport authorization since November 7th.
So you went from whatever number to half of what?
Well, if a child's not in the car or during wait time, you get paid a half rate instead of the full rate. Providers were like, okay, we'll do this, but we never knew it was going to go to the next level or we're not getting any authorizations. And I think that's why I had to bring up about the Medicaid aspect is so many of those aren't in home like us. They have to have transportation there.
Mm-hmm.
And we're in 4 regions with DFACs, but I live in very rural Georgia. We don't have public transportation,
Right.
you know? So I know kids are not getting to their appointments. We had one yesterday. The service ended on November 10th and they were shifting it to some other kind of provider. And yesterday they emailed and said that that child's been seen one time, they're regressing and about to disrupt, and they want to do the manual invoice now, that could take 30 days. So you're going almost 3 months with no services for children that are in foster care.
So beyond services too, for visitation.
Yes, ma'am.
sometimes children have to be taken where the parent is or the parent taken where the child is.
Yes.
Do you have any solutions for that concept at all?
I mean, if the parent has transportation and can come, of course, visitation is the key to reunification. It needs to occur. I know that Mr. Lyon's going to speak. We've heard of clients relapsing because they're not seeing their children right. I don't know the answer to that. I mean, mileage rates going down January 1st. We got that memo recently. Visitation centers can, but it needs to be meeting the family in the middle. That's our job, asking them to drive. And that's the other thing. A lot of kids are placed hundreds of miles from their biological parents.
Well, thank you. Hoping we can find some pathways for some of these things.
Thank you. I appreciate each of you.
So next up, I think, is Joel Lyon with Pro Family Georgia.
Chairpersons, members of the committee, thank you very much for allowing all of us to speak today. We sincerely appreciate it. My name is Dr. Joel Lyon. I hold a PhD in marriage and family therapy. I'm a licensed professional counselor. I'm a certified peer. I'm also the owner and CEO of Pro Family, which happens to be one of Georgia's oldest family preservation agencies. Pro Family was founded in 1991 as one of 5 pilot organizations in the state charged with a singular mission: preserving families and preventing children being removed from their homes. While I've been the CEO for the last 19 years, my agency has been standing shoulder to shoulder with Georgia's most vulnerable children for the last 35. We've been here through policy shifts, funding changes, evolving clinical demands. We've adapted every time. What we're facing now, however, is fundamentally and catastrophically different. Before I do speak about the crisis at hand, I want to be unequivocally clear, expressing my gratitude. It is an honor to work alongside Georgia's Child Protective Services and foster care system. Across the state, providers, clinicians, paraprofessionals, psychiatrists, support staff, child placing agencies, child caring institutions, we are all deeply committed to this work. We continue to serve not because it's easy, not because it's profitable, not because it's stable, but because we believe in service to families who are too often marginalized, overlooked, and underserved. Unfortunately, gratitude alone cannot sustain a system that is actively unraveling. The provider community in Georgia is in distress, and the child welfare services infrastructure is now at serious risk of collapse. For years, reimbursement rates in the foster care system have failed to keep pace with workforce costs, competitive wages, inflation, or the escalating clinical complexity of the needs of the children we serve. Those pressures have been building quietly year after year. What once was a strain has now become an acute emergency. The situation has been dramatically and dangerously accelerated by the department's massive budget shortfall less than halfway through the fiscal year. In practical terms, this shortfall has resulted in a near total shutdown of services for children and families involved with defects. And while you may hear assurances that services have not technically been stopped, the reality on the ground tells a very different story. Prior to November 6th, our agency was assigning between 300 and 500 new referrals each month. Since that date, like with family members, we've received 5 new cases. While at the same time, on December 31st, 1,257 active cases are scheduled to terminate. That represents 99.6% of our service volume. And let me be absolutely clear. The number of families involved with defects has not decreased by 99.6%. The need has not decreased by 99.6%. The trauma has not resolved by 99.6%. What has disappeared is 99.6% access to care. Since November 6th, the approval process for services through DFACS has been centralized and effectively throttled. Decisions that were previously made by county workers based on direct knowledge of the child and family they were serving now require approval from a small group of senior staff at state level. What once took hours now takes weeks, and as you heard previously, sometimes as much as 30 days. For children in crisis, those delays are not administrative inconveniences. They are clinically consequential. Our agency is not an outlier in this drastic decrease in services. As chair of the Family Preservation Unit for Together Georgia, I have spoken with dozens of agencies experiencing the same devastation, many of whom are in this room. To date, I've documented 28,314 service authorizations, impacting 10,446 families, all scheduled to close December 31st. These numbers only reflect Together Georgia agencies. I can't speak to non-Together Georgia companies. I want to put a face to this crisis. A man we'll call James, disabled from a car wreck and unable to drive, found out 2 days ago that DFACS would no longer be providing transportation for him to his parenting classes or his visits with his children. Mary relapsed into her addiction 4 days ago when she found out DFACS would not be taking her to her visits any longer, saying one of the major components that was keeping her sober was visitation with her children. There are literally thousands of these stories that I can share, that other providers can share. This is not a localized problem. This is a statewide failure occurring in real time. Many of my peers already have, and I'm sure will continue, to speak to you about the immediate harm being done to families. They are correct. Families are being categorically failed right now. But I want to draw your attention to something equally alarming and equally difficult to undo: the long-term destruction of Georgia's provider network. The demand for mental health professionals is extraordinarily high across every sector, yet foster care reimbursement rates lag significantly behind nearly every other payer, including Medicaid. With the near total impending cessation of DFACS-funded services, the idea that agencies will be able to retain staff under these conditions is simply unrealistic. This is not a temporary disruption. This is catastrophic. Our staff are already leaving. Many, if not most, of our staff are paid based directly on the work that they provide. And that work has vanished almost overnight. They are being recruited into positions that offer stability, predictability, and competitive wages, things that we can no longer offer. The exodus is not theoretical. It is happening right now. I got a resignation yesterday. This is happening. When staff leave, they do not leave behind empty desks. They leave behind continuity and frequency for children. Children with trauma histories, disrupted attachments, and a deep mistrust of systems that have repeatedly failed them. Each departure of our staff fractures continuity of care, delays progress, and further compounds harm. Even more troubling, replacing these professionals is neither quick nor is it inexpensive. DFACS rightly maintains high standards for those serving its clients. Meeting those standards, however, requires months of recruitment, training, and supervision, during which time agencies bear significant financial cost and children go without services. It took me 19 years to build ProFamily's current provider network. It's taken less than 2 months to begin a thorough dismantling of it. As of today, 30% of my most reliable providers are actively considering leaving not just their positions, but the field entirely. Let that sink in. They're not moving to another agency that can maybe provide better income. They're leaving the field entirely. Once this workforce is lost, it's not going to be easily rebuilt. Georgia risks losing decades of institutional knowledge, clinical expertise, and community trust. Reconstructing that infrastructure will cost far more in both dollars and human suffering than stabilizing it now will. Providers are not asking for unreasonable concessions. This is not about profit. Most of our agencies operate on razor-thin margins and remain in this work out of commitment, not convenience. What we are asking for is sustainability. We need the ability to retain qualified staff provide clinically appropriate services, and prevent the collapse of a system that Georgia has spent decades trying to strengthen. I'm appealing to you. Please remember James. Please remember Mary. Please remember the thousands of families that are impacted by your decisions here and now. We want to continue saying yes when the state calls. Yes to the child in crisis. Yes to the overwhelmed family. And yes to stepping in when no one else can or will. Without a stable or competitive funding, however, our capacity to keep saying yes is rapidly disappearing. Georgia's children deserve a system where access to care is reliable, timely, and grounded in clinical excellence. Providers deserve a system where dedication is met with stability, and the state deserves a provider network that's strong enough to meet today's challenges, rather than a network struggling to survive them. Thank you for your time. Thank you for your attention, and thank you for your commitment to Georgia's children and families. I appreciate the opportunity to speak with you today, and I stand ready to support the work ahead. Thank you very much.
And thank you very much for your comments. You do have a couple of questions. The first is going to be Representative Oliver. Oh, I'm sorry. Excuse me, Representative Panage.
Thank you. Thank you very much. First, may I get a copy of your remarks?
Of course.
Okay. Do we know if the commissioner is listening to this hearing?
I don't know if there's any way we know for sure.
Is there anybody here from DFACS?
Yes, Regina Quick is here.
Oh, hey, do we know if the commissioner is listening to this? This last speaker articulated the 5-alarm fire that we're dealing with right now. I assume the commissioner knows about this, but I really want her to hear this.
Well, certainly I'm not with the commissioner. I've been here in the room. So if I were under oath, I couldn't answer your question, Representative. But my understanding is she's in the office and she's been observing and also probably trying to do some work. But
it seems the work is here.
But yes, ma'am. The work is ever present.
Okay. Do we know if she's coming this afternoon?
Absolutely.
Great.
She's on the agenda.
Great.
All right. Thank you so much.
Thank you.
All right. Thank you so much, Representative Panage. Do we have any further questions? Thank you. You did an eloquent job explaining the situation. So thank you for that.
Thank you very much.
Thank you so much. Okay, our next speaker is Sally Buchanan with Creative Community Services.
Madam Chair and members of the committee, thank you so much for the opportunity to speak. Really appreciate it. I know it's been already a long day. My name is Sally Buchanan, and I am the CEO of Creative Community Services, which is a nonprofit that I founded 43 years ago. So the way we actually started the nonprofit I did was working with adults with developmental disabilities, and that was in 1982. And then in 1988, actually one of the representatives from Chatham County called me and said, hey, we need to return children that we are shipping out of state for services. We want to create community-based services, and we've been watching what you've been doing with adults with developmental disabilities. Will you go down and start bringing kids back? And we started in Florida. So I started the first therapeutic foster care agency in the state in 1988, and we haven't abandoned that model at all. We've stuck with that, even though it was actually dismantled and not paid for in year 2007. So for more than 4 decades, CCS has partnered with Georgia to serve children with complex needs in foster care. On November 10th, CCS was formally notified that our SOAR therapeutic foster care contract was being terminated and effective in 30 days. This contract supported our foster children with the highest needs of behavioral, developmental, and mental health acuity, and its termination occurred without a transition plan sufficient to replace the lost capacity. SOAR existed for one purpose, and that was to make family placements possible for children who otherwise would not remain in homes. There are children at high risk of placement disruption, psychiatric hospitalization, or placement in hotels or offices. Many were teenagers. Many had already experienced multiple failed placements. At any given time, SOAR served approximately 50 DFACS youth each month. The average length of placement for youth in our care is 2 years and 7 months, which is a level of stability that's uncommon for children with this degree of need. This includes children that are placed just weeks ago, as well as who have been remained stable in their homes for years. Through SOAR, CCS provided intensive in-home behavioral intervention, foster parent coaching and respite, educational advocacy, and tutoring and clinical coordination for youth with autism, developmental disabilities, and trauma-related behavioral challenges. These services were not optional enhancements. They were supports that allowed foster parents to safely maintain the placements. The contract also funded 4 days of respite each month, an extra difficulty of care payment, tutoring, and medical supplies that were not covered by Medicaid. These elements are core components of therapeutic foster care, and without them, many families simply cannot continue caring for the children with extreme needs. Research has shown throughout the years that people that become foster parents are not your people that are from high incomes. They are your working families, your middle class, blue collar families, actually. And they are very, very committed to our children, and they have to be. Without them, many families actually couldn't continue caring for children with these extreme needs. Most of these parents are single parents now. And in order for our foster parents to be able to work with our foster children, they have to have a job that allows flexibility, which means that it's not going to be a regular job that would pay higher wages because they have to have that flexibility. It's a must because our children have high needs, which require weekly therapy appointments, psychiatric appointments, and some have extensive medical appointments. Also, our youth are constantly having difficulty in school, and they're suspended due to behaviors that the schools do not have the personnel that knows how to deal with these children with extreme trauma. This is why it's so important to provide an extra difficulty of care per diem so they can take less demanding jobs that unfortunately are lower paying jobs. Now that we cannot provide an extra difficulty of care per diem, the parents can't afford to have these kind of jobs. An example of a child that we're going to have to discharge is Larry. So Larry is an 11-year-old. He was placed with his foster parent over 6 months ago. He came to us in an emergency because this child was at risk of being out of a placement and going to a hotel. He has autism spectrum disorder, trauma and stressor related disorder, academic and education concerns. He came into care due to unsanitary conditions, lack of supervision, and most important, the parents' mental health needs. Larry's been exhibiting extreme behaviors at school, and due to his explosive behavior on the bus, he can no longer even ride the bus. The parent that he is with works for FedEx. I have to say hats off to FedEx because they have been very, very accommodating and letting her take off when she needed to take off. However, the services were provided and helped her take care of this child and go to the school. They're no longer there because we can no longer provide those behavior intervention services. Now our parent has to be the one to go to the school almost every other day. Because of DFACS also cutting the behavior aid services that they had, we have no services to actually offer for her to be referred to. This parent's in tears. She just talked to me yesterday, and she said, I've made such progress with him in the last 6 months, and that's really an accomplishment for our kids, honestly. And she said she hates to let go of him, but she can't afford to do it anymore because she can't, not have a job. That's just in our economy, especially with single moms, you can't not work. For 10 years, CCS held this contract. And during that time, funding increased from like $350,000. As a direct result of positive outcomes, it's now $1.3 million. We include proved placement stability, successful step downs from psychiatric residential treatment facilities. We regularly accepted children who could not be placed elsewhere, including youth that were transitioning out of PRTFs and children who had experienced hotel placements. The termination of this contract directly impacts more than 50 children. Without the behavioral intervention services, foster parent supports, the contract provided, many of these children will not be able to remain in their current homes. As a result, CCS has already had to lay off 14 staff and has lost the capacity to serve many high acuity children going forward. I just got a text from my intake provider that said, my phone is blowing up. The kids that had the enhanced waiver from other agencies, when it ended, the parents are saying, I can't take care of them. And they're turning to us because we work with those children with very high needs. Well, I'm asking, where are these children going to go? And how will their needs be met? Absent equivalent services, the foreseeable outcome is increased placement disruption, greater reliance on emergency psychiatric care, and a renewed risk of children sleeping in hotels or in DFACS offices, an outcome that this body has worked hard to prevent. I respectfully ask that this committee to exercise its oversight role by requesting that DFACS 1, explain how children previously served under these contracts will be safely placed going forward. 2, identify what services, if any, will replace the therapeutic supports that were eliminated. And 3, provide the data on placement outcomes of affected youth, including disruptions in hotel placements. These children are not suddenly less complex. The need has not diminished. The capacity has. Before I conclude, I've been asked to also bring something forward that I didn't know I was going to have to do. I'd like to ask for the committee's assistance on a matter of payment of the services that we have already provided under our contract. This is for other agencies as well. We, like many other providers, the last services that we have been paid for were in August. This has caused an extreme cash flow problem. I've never faced this in 43 years. It's been explained to us that DFACS is having some financial challenges. I appreciate that. And there are financial challenges, but I think you know that if your mortgage company was told by you that you could not make your payment since August, I don't think you'd have a home. I don't think any of us would, unless you have a very understanding mortgage company. I appreciate your time and your commitment to Georgia's most vulnerable children. I'm happy to answer any questions.
All right, thank you. I do not see any questions at this time. Oh, you have one? Okay, thank you. I'm sorry. Representative Rice, please go ahead.
Hey, thank you for sharing with us. And I was trying to write as fast as I could, but do you mind, you had the 3 requests and the 4 additional. I got the first 2. Can you review with me that third?
Sure, to provide the data on placement outcomes for affected youth, including disruptions in hotel placements.
Thank you.
I do have a handout. I know that Amber was gracious enough because we've been very busy. And I also have handouts that include some other information too, just on what I said and stuff. So Amber, I want to get this to you. Thank you so much.
All right, thank you. Very informative. Thank you very much for being here.
Okay. So next up is Tanya Anderson. Reduce Villages. Good to see you, Ms. Tanya.
Good to see you too, Chairwoman Dempsey. Thank you. Good afternoon.
thank you again, sorry, Chairwoman Dempsey and members of the committee for allowing me the opportunity to participate and speak with you this afternoon. My name is Tanya Anderson, and I'm the Executive Director for Youth Villages here in the state of Georgia. Youth Villages is a national nonprofit agency, and we are currently providing services in 29 states and the District of Columbia. We here in the state of Georgia have been providing services since 2008. Our entry into the state of Georgia has been by way of community-based services. And I'll talk a little bit about the 3 lines of services that we offer here currently. In the state of Georgia, as of last fiscal year, our fiscal year runs July to June. So when we look back at our data for fiscal year 25, we serve more than 600 young people here in the state through our 3 service lines. Here that you have in front of you, the 2 columns before we get to, the 2 columns before we get to residential are community-based programs. And I do want to talk about those programs first because I am very much in alignment with my colleagues here in the room to talk about the value of community-based services, the things that we are losing when there has been contract cuts, and what it means to young people, families, and young adults. Youth Villages provides community-based services by way of LifeSet. That is our model for transition-aid youth services, and we have been providing that service since 2008. Those are young people that we're helping to move into independence, and we do that in partnership through the Department of Behavioral Health and Disabilities, as well as through a MARE group. The age range for that program is 17 through 22. Our second community-based program is Intercept, and it is a prevention-based services that we have here in Georgia, and it serves youth and families from 0 through the age of 17. It is a family-based model. It is evidence-based, and it is well supported on the 4E prevention clearinghouse. For our residential program, which is where I want to spend the most of my time talking, and it is because there have been a few questions asked about what happens to the children who are not receiving services for contracts that have been cut. So when there have been cuts to prevention services, when there have been cuts to educational programs, when there have been cuts to enhanced rates for foster care, what happens with those children? Well, the reality is they're going to escalate into higher levels of care. One of those higher levels of care will be your psychiatric residential treatment programs. And there are 6 of us here in the state of Georgia. Youth Villages is one of them. Our Inner Harbor campus out in Douglasville, we currently have 144 beds, which we have really focused on the efforts to enhance the number of beds that we offer for residential. So we were able to grow our program through some campus enhancements and increase the number of beds that we have from 128 to 144. Our construction project is still underway, and we'll be able to enhance our bed capacity from 144 to 172. There has been an ongoing need for residential services for lots of various reasons. And Youth Villages is one of those programs that have really answered the call to say, how is it that we can get more beds to serve the young people who really need this level of care? When they have exhausted the community-based programs that everyone has spoken about that are excellent, great programs with really good outcomes, but there are still going to be those young people that need residential level of care. So we have answered the call in terms of increasing our bed capacity along with my colleagues when it comes to the other PRTF programs. The challenge that we are going to experience as a residential provider, particularly those that are licensed as PRTF programs, is that when our colleagues call us and reach out to us, or when families call us and reach out to us, or when crisis stabilization programs or ERs call and reach out to us about the need for a residential bed, we're not going to be able to answer that call. It is less about having the beds to be able to meet the needs, but it's about not having the right financial model in terms of the rates that we are reimbursed through Medicaid to be able to keep our doors open, to maintain a high quality workforce, and to meet the growing operational needs of residential programs. So I'd like to take a couple of minutes and just give you a landscape for youth villages in particular. And while I am sharing more about the youth villages landscape for residential and some of the challenges in our future ability to not answer the calls of our partners for this level of care, it's true for all 6 PRTFs, and I'm just a representative of the entire group. Youth villages in fiscal year 25 received over 1,000 referrals for our psychiatric residential treatment program. Over 1,000 last fiscal year. This fiscal year, which started in July, through the end of November, so far I have received nearly 500 referrals for psychiatric residential treatment facilities. And these are Georgia referrals that I'm speaking of. However, my program right now with 144 beds, I'm only able to allocate about 40 to 42% of my operating bed capacity to Georgia youth. That is low. And while the experience for my PRTF program, I'm able to speak more candidly about, it's the same for my other 5 colleagues. We are having to find ways to diversify our funding sources and our funding mix to keep our doors open, to cover the cost of operations. And it's important to note that your biggest cost of operations, and Joel talked about it a little bit, is about salaries and benefits for the staff. It's about your workforce. We want to be able to retain high quality staff. And for those that we lose for unfortunate circumstances, we want to be able to recruit other high quality staff members. It's hard to do that when you are already struggling with meeting your operating budget. And so when I've talked about the number of referrals that I have received, the thing that I want us to be able to focus on a little bit more under the landscape is that currently the Georgia Medicaid rate is $649.22. PRTFs did receive a rate increase in 2024. It was announced in 2024, but through the support of DCH and CMS, we were able to retro those rates back to 2023. There were some CMOs that supported that and retro the rates back to 2023 for kids that had been served in the programs. And there were some CMOs who did not retro that rate back and did not honor those rates until spring of 2024 when the announcement came out to everyone. If I am only able to operate 40 to 42% of my bed capacity for Georgia youth, think about the number of people that we are not serving. And through the collaboration between the Department of Community Health, and at the time the commissioner was Commissioner Noggle, we were able to work together and collaborate on a better formulary for PRTF rates. And at the time, what she was able to strategically do is to consider the rate for the inpatient Medicare costs and allow there to be an opportunity for 75% of the Medicare inpatient rate to be allocated for PRTF, and that was approved through CMS. And that's how we got to the $649.22. When that happened, you could see, and we do have data, and there have been briefing letters sent out to several legislators and to the Department of Community Health that collectively all 6 PRTFs were able to increase their capacity of Georgia youth. And for youth villages, as an example, I maintained about 25% of my bed capacity at the time being Georgia youth, because that's all I could afford, to keep the doors open, to keep the quality of programs high, and to make sure that we were able to get really good outcomes. After that rate increase went into place, you can see that particularly for youth villages, we were able to sustain and move our capacity of operating for Georgia youth only from 25% to about 42%, and I have been able to maintain that. However, the cost of operating residential programs continues to rise. 70% is because of salaries and benefits for the staff. You have other ongoing concerns and challenges with the increase in liability insurance, and all providers are experiencing that, not just youth villages, not just PRTF providers, but also our community-based providers. There's also the additional cost for us to all have to look at how to bring in additional professionals into our workforce. And while our community-based programs have had to diversify their professionals and their workforce, PRTS have had to do the same because we admit really complex cases. So an example is that Youth Villages has had to onboard a part-time and a full-time psychiatric, a family nurse practitioner to care for the medical needs of young people. In addition to that, we're having to onboard an occupational therapist, again, to care for the complex needs of young people that we serve. So it's not the basic care of psychiatrists and nurse practitioners and nurses and mental health techs. As we continue to want to make sure that we provide high quality services, we have got to think more broadly about the professionals that we have to bring into our workforce to do that. And part of that building your workforce means that you have got to branch out to additional professionals. And if you want occupational therapists, and if you want nurse practitioners to move out of private practice or other forms of practices and come and work in these environments, you have to have competitive salaries. And oftentimes you have to look at how to offer bonuses. And so the increase is happening. For fiscal year 25, my overall cost per day to serve young people in my residential program was $765. And my rate was $649.22. That was in fiscal year 25. In fiscal year 26, so from July, and my first quarter, from July to September, the cost has been $800 per day. So there's a pretty significant gap between what we get reimbursed and what it actually costs to operate our programs. There are bordering states that we work with, not just Youth Villages exclusively, but a lot of PRTS work with bordering states because we have to. We have to work with bordering states because they have been more complimentary and in a lot, not necessarily complimentary, they have been more accommodating as it relates to being able to offer higher per diem rates for the young people that are being served in our residential programs. And so in general, we're getting anywhere from $800, and some providers are getting more than $1,000 from some bordering states to serve their young people. Again, because we are operating really high quality residential programs, we're getting really good outcomes. And for us, it's becoming more of a disservice to be able to offer more of our residential bed capacity to other states who are offering better rates versus what is happening at home here in the state of Georgia. And we want to be able to right size that and work with the Department of Community Health and our CMOs to really enhance and improve our residential rates to be able to answer the call of our partners. If in fact there are going to be struggles with restoring contracts, which that is the primary purpose of the conversation today, it's important that we do what we have to do. And everybody in this room, whether it's you all as committee members and us as providers, we are here because we care. We are here because we care about the well-being of young people, family members, and young adults. We've heard from a lot of young adults today, or a few of them from Empowerment. These are voices of young people who are saying, protect the system as it is and help to grow and expand it. And so restoring contracts as best we can, protecting them in terms of sustainability, as Joel has mentioned. But as we're talking about protecting and keeping contracts intact as best we can, we cannot forget about psychiatric residential treatment facilities. So that when there's a need and a call for young people to be placed in these levels of care, keeping them safe, helping them get well, move into resiliency, then we can be equally as supportive and available for our community-based partners as they have been for us. PRTS cannot exist and do well without the community-based partners in the room, because we want to make sure that when our kids are stable, that they have a community-based program to go to. The greatest and biggest one are intensive in-home services. Aside from that, when that is not available, having those foster homes and hopefully foster to adopt. Our group home programs are important because there are young people who need to transition slowly, and that's okay too. It's really meeting the young people where they are. So this importance of making sure that we can grow the capacity bed-wise to meet the needs of young people as it relates to residential services is important. The only way that we're going to be able to do that is to really look at how we can work together and support DCH, because we understand and we have had conversations with DCH and we've sent them letters, and they have been very respectful in their response that the state agencies are asked to have a neutral budget. And so when we're asked to have a neutral budget, it is really hard for them to be able to explore more on how to align with us and advocate for a rate increase. And we're concerned that we're going to be stagnant at this 649.22. And while we have worked very hard to grow our bed capacity since our last rate increase, we will stall out, or we will eventually have to look at how to decrease those Georgia beds even more, which is unfair to children. And again, it prevents us from having the ability to rise to the call of our partners in the room whose young people may be escalating because they're not getting those community-based services that have allowed them to sustain in the communities with their families in less restrictive settings. So there's a big challenge there. With regards to the overall impact, as I mentioned, we're going to have to continue to diversify our funding source and our funding mixes if we are not able to increase our Georgia Medicaid rate, and we're concerned about that. There's a lot of conversations we've heard about, do we add on more PRTF beds? You could do that. Some of us have done that. Youth Villages has done that. There are other providers that have already added additional residential beds, but adding beds doesn't equate to being able to serve more children because the rate is more of the challenge than it is bed capacity. There are a total of 620 beds across the state for all 6 PRTF programs. What we're asking is essentially, let's make sure that we right size the beds that we do have by honoring and exploring how to increase our rates. But beyond that, before kids need residential services and residential care, how can we stabilize them in the community? We have a very sophisticated provider system here, and we think that both things are equally important. Investing in community-based programs and protecting those contracts for community-based programs, but when there is a need for residential, being able to make sure that residential providers are positioned financially to be able to serve those kids and more of our own kids here in the state of Georgia. There are some concerns that with this forecast of contract cuts, if we're not able to find a way to restore them and to grow them, because while today we're talking about contract cuts that have happened, all of us as providers have been exploring how is it that we can increase more prevention services across the state and not be in small pockets. There are more kids and more families that need prevention type services across the state. So while today we're talking about contract cuts, before today there's been more discussions about the underutilization of prevention services. So we're going backwards a little bit and we have some concerns about that. There's always a major forecast for us that kids are going to become more and more disconnected from their natural families and their communities, and we should all be concerned about that. When we're not able to protect community-based programs. But again, when they're having to be removed and escalating into higher levels of care, are we going to be able to keep them in the state of Georgia? And even if we keep them in the state of Georgia, are they in the right placements, receiving the right services with the right providers and the right treatment? Because the other part, as some of my colleagues have mentioned, is the challenge of we're forecasting the increase in the rise in hoteling again. And that is costly, and it has been costly. We are very concerned about young people being stuck in ERs for more mental health and therapeutic reasons than medical reasons. And so then that prevents kids who have medical reasons getting the attention and the time that they need with those providers. We are very concerned that if in fact we are not able to address the rate issues with psychiatric residential treatment programs, not only will you see some of us have to regress with the number of Georgia Medicaid youth that we serve, but for some, we may maintain the same number or a higher number, and it requires us to go out and do fundraising. And fundraising is not sustainable. I think those of us as providers know that, and honestly, fundraising should be used to help with innovation, to help expand services, and to do some project and program improvement. So we're using, when we do fundraising, sometimes it's to cover things that really should be covered by state contracts and then Medicaid rates and Medicaid contracts. I have 2 recommendations that I want to share with you, which is kind of things that I've already talked about. Let's invest in rate increases for your psychiatric residential treatment programs. And I would recommend that we look at investing in these rate increases in 2026 while we can still afford to be where we are with our bed capacity and what we have committed to since we've gotten our last rate increase, because I think somewhere in mid-26, 2026, we may see that the residential providers may have to start reducing the number of beds that we right now operate for Georgia Medicaid youth, and we don't want to see that happen. But the second recommendation, which is probably the biggest, all 6 PRTFs have gotten together quite often and talked about and looked at the history of rate increases, when did they happen, what was the formulary and the methodology. We do all feel like the last rate increase was the best formulary. And we appreciate Commissioner Nagle at the time kind of thinking more innovatively about, let's look at what the Medicare inpatient rate is and how can we take a percentage of that for all 6 PRTF providers to make it consistent and fair across the board. What we are asking is for a better formulary that looks at the true cost per day for residential providers. And then that we also look at a more predictable cadence. So while we have a better formulary to cover true cost per day, we would also like to make sure that the cadence is somewhere between, if not annually, maybe every other year. That allows us as providers to be able to keep up with the rise in costs, to protect and preserve our high quality workforce, and to also make sure that we're in a position to be able to recruit other quality professionals who want to join our teams. Any questions you all have for me?
That was quite comprehensive. Excuse me. That was very comprehensive, and thank you for providing all that information, especially since you're a residential treatment facility. That's really important in this conversation. So thank you. And we do have a question. Is it Representative Sharper? Go ahead.
Thank you so much for this information. I'll have other questions I'll do later on in the midst because we have other people that's coming up. But one thing I want to ask, if you can answer this, what's the average time someone would stay at the village from the time you get a child? What's kind of the average length of time?
My average length of stay is about 200 days currently. And we do see young people who stay longer are in foster care. And those are individuals, one, it takes them a little bit longer to stabilize because they've been so transient and they have really complex care needs, in addition to the ability to stabilize them at a reasonable rate. Then there's also the challenge with placements and where they can transition to in a safe manner that is best for them. And I will say that the providers that are behind me are the ones that I typically rely on most to transition a lot of my foster care children, particularly here in the state of Georgia. So Sally spoke before me. We have often called on her when it comes to those really difficult cases and young people who may be lower functioning that need her level of care. And she has done an amazing job at finding the right environment for these young people where they are sustainable. I'm concerned that I may not be able to call on Sally when these things happen. And so what happens, to your point, is that when I don't have my community partners and providers to be prepared to serve my young people who are stabilized and they deserve to discharge when it's time for them to discharge and they have done the work and they're stable, it then increases the length of stay for them being in a psychiatric residential treatment program. And in a lot of ways that violates their rights. So one kink in the system, and I think one disruption in the system impacts all of us. And I wanted to just take the opportunity to talk about how this disruption will inevitably impact your PRTF providers by also saying, if we want to grow the bed capacity that we have already worked really hard on, we have got to do something different in terms of improving the psychiatric residential treatment facility rates that we have right now.
Okay, thank you.
Great question. Thank you.
And thank you so much, Ms. Anderson. This is very informative. Thank you.
Thank you so much for your time.
And before we jump to the next one, I just wanted to say we do have several members who are online right now via Zoom, and they're observing and listening. We may have some questions pop up from them, but it's Floor Leader Wade and Representative Jenkins, Representative Townsend, and Chairman Gullett. So they are listening at home or wherever they are via Zoom. So they'll pop in at some point in time. So just be aware of that. So thank you.
Thank you. That was a great deal of information. I have visited, some of my committee has visited, of course, and we know the magnitude of the work that you're trying to do. Appreciate it very, very much. So we have three more speakers, y'all. Hang in here. We might hear from maybe one or two more and then maybe take up a stand up and stretch just a minute, okay? We might do that just so that everybody can refocus just a little bit. So next we have Heather Rolls from MAC, the Multi-Agency Alliance for Children.
Good afternoon. Thank you so much for having me. I'm Heather Rolls. I'm with the Multi-Agency Alliance for Children. If you would like, I can yield my time. I know the commissioner's here and people have asked to speak with her, so I'm happy to do that. I can speak after, whatever is your pleasure.
Well, I think we're okay for you to go ahead. Are you sure we're okay? Okay.
I know time is limited and it's right before the holidays, so I want to be respectful of everybody's time. So first of all, thank you so much for having me. Like others, we have had a longstanding partnership with DFACS. We have responded to and been honored to work with DFACS to fill the gaps and address the needs of our child welfare system. I've been in my position for over 20 years. It's hard to believe, but we've worked on partnership with DFACS my entire career. I've worked with over at least 7 DFACS directors over the years, coming up with innovative programs and different things. When DFACS has needed the provider community, we have always come and answered the call, all of us. Max specifically has worked on many projects over the years, like Home in 5, Road to Home. We've worked on several initiatives to support transition age youth. We worked with DFACS several years ago to do town halls that involve the empowerment advocates. But what I'd like to talk to you today about is LEADS, which is one of those programs that we designed in partnership with the state. The DFACS leadership at the time needed to get out of Kenny A's education outcomes and improve graduation rates for kids in foster care. We started LEADS in 2017. Since then, we've served about 2,300 students. We've helped get out of the Outcome 17 and the Kenny A consent decree. We've maintained an over 75% graduation rate. This program also, I should mention, is for young people in Fulton and DeKalb County. We currently serve, or we were serving 9th grade through 12th grade plus GED. We've maintained over a 75% graduation rate. This year it was 82%, with 40% of those enrolling in post-secondary education. We were able to increase graduation rates, of course, to get out. We provide a variety of services and supports to ensure education services and their needs are met. And as you know, and as you've heard from my colleagues, when kids are stable in school, they're stable in their placements. It kind of goes hand in hand. On November 10th, we were given 30 days notice to close the program after 7 years. We were extremely surprised. We weren't expecting that to come. It comes right at the end of this semester. So we were trying to transition with DFACS in the middle of exams. As you can imagine, it was quite challenging. The DFACS leadership at the local level, we were the ones that informed them of this change. They did not know this was coming when it happened. We have been meeting with the local counties on a monthly basis. We've been meeting with the state office on a quarterly basis this entire time. And as far as we knew, we were providing what we were asked to provide. Through some various relationships and things like that, after this all happened on November 10th, we were able to secure some private funding from a foundation to help us support juniors and seniors through the next semester and help get them through exams this year. And we'll hopefully be able to work with DFACS to determine the needs and how we can help support education success moving forward. I do want to say a special thanks to the commissioner. We really appreciate that her letting us support those juniors and seniors. I understand budget cuts. I understand how the child welfare system works. I've been working in this system for a really long time. I think what's important and what you've heard from my colleagues earlier is we have always tried to answer the call. When DFACS needs something, we've always tried to do it. We've always tried to do our best. And we try to make sure that kids and families get what they need and so that they can be successful in life. we understand that the shifts in child welfare and funding and all of those kinds of things, but what we would like is to be at the table. We want to know about these things before they happen. As Sally explained, when you have 30 days notice to shut down a program and services that you are providing, that ends up with a decrease in workforce. We have incredibly high quality staff that are out there doing the good work. DFACS does not have the capacity to provide all of these services and supports. That's why we have a very robust private provider community here in our state. And we've always been able to really work with DFACS in order to provide those services and supports. I personally welcome the opportunity to partner with DFACS to meet these needs, and I'm sure that my colleagues feel the same. And I will not, that's all I have today. I do want to just say, quickly, I really I support what my colleagues have said around the workforce and all the work that we've done and the partnership with DFACS, and we hope to get back to that. And I will be happy to answer any other questions.
All right, at this time, we don't have any questions for you, but thank you very much for
I was
what you
trying
do.
to keep it short. So.
Thank you. Thank you so much.
Okay. Next is Wayne Noggle with Families for Families.
All right, well, good afternoon. Thank you, Madam Chair, for allowing us to talk for a few minutes today. My name is Wayne Noggle, for those of y'all who don't know me, and I always say my joke is I didn't want to be in foster care, but my wife and I fostered and adopted 2 little girls, and we ended up leaving what we were doing to start an agency that would help children. We started in 2014 with another agency in Loganville. We've always believed in a public-private partnership. In fact, I saw Mary Havoc just came in the room. I was at the very first Home in 5 meeting that they ever did in Region 5 to get that started. And in 2017, we started Families for Families. We started in Loganville because that's where we lived at, and really served the kids in Metro Atlanta. And we found out very quickly when our office started that we were getting phone calls from all over the state of Georgia. And one of the youth said it so good today that when he was in South Georgia, he got placed in Metro Atlanta, hundreds of miles from his home. And so we learned very quickly that the kids from South Georgia, the kids from North Georgia, they were all being brought to Atlanta, and transportation was a big issue. And so we started some emails and some communication with the department on wondering if we could get a little more funding to go down to the rural parts of Georgia and keep these kids close to home. And I've heard people talk a lot about today about why our kids not going back. We know the farther they're placed from their birth families, the less chance we have of reunification, the less chance we have of visitation, and all that drags those cases out longer. So our plan was to go to where the kids were instead of bringing the kids to where the families were. And I think you guys have a little flyer from me. I hope y'all got that. In 2019, Georgia had 7,510 foster homes. We dropped in 2021, 2023, and we're up just a little bit this year. But the bottom line is in the last 5 years, we have lost 2,500 foster homes in the state of Georgia, which means that children have less placements. They're placed farther from their birth families. Many times siblings are not placed together, and they're being moved all over the place. And so our goal was to keep these kids close, even if this costs us some more money. Families for Families, we are co-accredited. We have 9 offices now in Georgia, and we raise $2 million a year to make budget. So we put a lot of money back in the child welfare system in our state. And so that first chart right there is a chart that I brought to you guys in January and February of last year when I came to all of your office and shared with you our vision of Families for Families. We had about 232 kids in care at the time. And on the back there, if you look, the legislators gave us $250,000 to go and start these offices and to get this thing going. We also, in the money that we received, we have to give a report to Chairman Dempsey and to Chairman Tillery in December. And so we knew that we could not wait till the funding started, that we had to go ahead and start. So in good faith, we started that program and we started placing kids in these rural offices. I'll tell you today we have 285 kids in care. Last year in 2024, before we started doing this, we placed 186 kids. This year already, we've placed 275 children, which means that we've almost done a complete flip of our census this year. Almost every child that's been with us has either gone home or gone to adoption. We've brought a whole new set of kids in. And so we know the state average that we have heard is that kids stay in care about 24.4 months. Our kids stay in care about 12.8 months. So we know the closer we can place those kids to their birth families, the more services we can provide. We can keep them in their schools, we can keep them in their communities, the better it off is for children. So we started this program, we started recruiting, we started paying staff. We thought our contract was going to start on July 1st. We never heard anything. We emailed on July 30th to the department. We heard on July 30th that we will get back with you when we feel it's appropriate. We emailed again on October 3rd or September 3rd with no response. Emailed again in October, again with no response. And so now we have a program running. We have received no funding for it, but we are going to keep it running and we are going to raise money because we believe that is the best thing for children. And so a lot of the stuff that's been talked about today, I don't want to go over because I think we're all kind of saying the same thing, but I did want to share just a couple examples with you because I've heard things that the services have not been disrupted, that they're just being changed a little bit. And so I have some emails. I have 4 emails. I just want to show them to you. I got some copies if you guys would be interested in them. This is a family up in North Georgia. They have had a little girl. We're going to call her Emily. That's not her name. They've had her for almost a year now. And they were told that she has visits on Monday and Wednesday with her birth family. She's about 45 minutes away. It's a 2-hour visit. And they asked the foster family to take the child. They have to leave at 2 o'clock on Monday and Wednesday. They would get home about 6 o'clock that evening after everything's done. Okay, and then to supervise the visit. The family says, we're not sure we can do that. So the next email from the department was, we're coming to get the children. So that's very good placement stability for this little girl. And I just wonder sometimes, where are we going to put her at? We do not have an abundance of foster homes. We're down 2,500 foster homes. The little girl, this girl is in South Georgia. We'll call her Kay. She has been in care for 18 months. She is 10 years old. She's been grossly abused and molested. Her parents found a letter in her room that she had planned to kill both her foster parents. She was on an enhanced waiver. She has 3 therapies a week with 5 therapists because they swap out on the therapist. We got an email on December 3rd that the state office had denied her waiver and they were backdating it 1 month. So we've already paid the foster family for months of services that we will not get paid for. Our family will not get paid for that. They also cut the behavior age of this little girl. So 3 days before Christmas, so they had to put a 14-day notice in just because they can't afford to take care of her. So she's going to get a bag of toys from Clark Howard and not have a home to take them to. They put their 14-day notice in. We did talk to our family. They're going to keep her till mid-January, and we are trying to find her another home. But without services, and Sally's talked about it, Heather's talked about it, but without services, it's not that the families don't love the kids. It's not they don't want to keep the kids. They can't afford to take off work. Sally did a good job. These families are not wealthy. They take off work. They have to have flexible schedules, and they don't have the support to take care of this little girl. So she's coming back into care by the end of the year. She's 10 years old. By the way, she's been 10-13 3 times since they've had her. So I know this placement move is going to be very good for her stability. Here's another email. One more family. They're in Loganville. This is Jeff and Stephanie Merritt. In fact, Jeff's Merritt here today. They have adopted a special needs child. They have a little boy named Kay. He waited for a kidney for 2 years. Let's say he's 10 years old. They also have a little sister that is also in care in their home. So they have 2 foster children, both with special needs in their home, medical needs, and they've adopted a special needs child. The birth family of these children, they live in DeKalb County. The father has been arrested multiple times for domestic abuse to his wife. And the DFATS case managers too have complained they don't like going to his apartment because they're scared. That makes sense. So the plan was for Jeff's wife, and Jeff's here today, for her to load up the 2 kids and their special needs adopted 2-year-old and take them to this man's apartment, and for her to supervise the 2-hour visit and then bring the kids back home. So I look at that. The court ordered a tutor for Khalil because he has been because he's so far behind in school. The Merritts found a tutor, somebody at school that offered to do it for him. She ran up a bill of $1,600. When we turned it into the department said there was no money to pay the bill. Now that's okay to make that decision, but when you're the foster family that takes your kids to school every day and you see the counselor every day, it's a little bit different for them. And so I just found out about this week. We have a donor on our board that's going to pay for the bill. And I'm going to share one more story and I'm going to sit down. Last night I got an email. We have an info at familiesforfamilies.cc, and a family reached out to me down in South Georgia. And I want to read what she wrote. And I actually called her this morning And I asked her if I could share her story. Her name is Sarah. Husband's name is Ricky. And she said, hey, I have a defects case. We have a lot of problems. The government has been shut down. Haven't seen my girl since November 6th. Foster mom is involved with Families for Families. I need an advocate, someone willing to help us get our children home. DFACS does not do anything, and they have stopped all services. It is very difficult for me during this holiday season. It makes it the hardest. Is there anyone who can help me? Well, I was going to pass it off to my staff, and I called her this morning. She answered her phone, and she says, I haven't heard from anybody in a month. And I said, well, what can I do to help you? And she said, well, this is what the judge ordered. She said, Mr. Noggle, she said, I have a learning disability and I have some mental health issues and I don't understand what the government shuts down. I don't understand what's going on. Will you just at least talk to me? So I began to talk to her and share with her. We talked a little bit about what was going on. She said, I haven't seen my kids since November 6th, but this is what she told me. She said, my husband and I have to do regular drug screenings, which we've done since our kids came into care March 6th. We have to go to individual therapy. We haven't missed one. We have to go to couples therapy. We've gone every time, and we have to see our kids when they transport them to us. We haven't missed a visit. And on November 6th, they cut individual therapy, couples therapy, drug screening, and our visitation. We're going to go back to court in April. And she goes, I'm afraid they're going to take my kids from me because I haven't completed my case plan. I told her, she says, I can't get anybody to call me back. And I said, well, I'm gonna get somebody to call you back because I have a meeting today. And really, I'm gonna find out how I can help you. And so I said, was there anything I can do for the meantime? And she said, well, if you could just do one thing for me, I would appreciate it. And I want you to hear this. I'm not trying to do an emotional pull, but these are not numbers that we're talking about. These are names of kids. And it's not just about finance. It's about the families that we serve. And I talked to her and I said, was there anything I can do for you? And she said, yeah. She said, I bought my girls Christmas gifts, but I guess now I'm not going to get to see them. So I don't get to give them to my kids. She said, could I bring them by your office and you take them to them? I said, no, ma'am, I'll send somebody to your house to pick them up. And I'll make sure your girls know that they're from you. And she said, I said, is there anything else I can do for you in the meantime? She said, there's one more thing. She said, could you get the person to take a video of my girls opening their gifts so that I can watch the video and know my girls had Christmas? And he said, ma'am, I'm going to call some people. And if there's any way we can do a visit, my family may drive down and spend Christmas with you on Christmas Day. And I know we can sit in this room today and go, oh, let's find out what that situation is and go fix that problem. And we probably can do that. But that problem, like all the other providers have shared, it's happened hundreds and thousands of times across our state right now. And I'll say this in closing. You know, the bio parents down there in South Georgia, they don't know they have a federal right to see their kids. They don't have attorneys. They can't do anything. Our kids that are in foster care, they don't have a voice. None of them are in this room. They don't get to choose whether they get moved or not. They don't get to choose which families. They don't get to choose what services. All of us in here, we're going to go home. We're going to have Christmas with our families. I'm going to go home today and probably get something to eat on the way home. But there's a group of people in Georgia that I feel like sometimes we villainize and sometimes we don't listen to. And I believe they're one of the largest stakeholders in foster care, and it's our foster parents. And they're talking. They're more loyal to each other than they are to us. And they are all talking to each other. Let me tell you what they're saying. Don't foster. Because you're going to take a child and get attached. And then you're going to get an email and they're going to say, if you don't do visits, we're coming to get the kids. And then they're going to say, we need you to take some high-end kids. And you're going to take a high-end child into your home. And after you've had that child for a couple months or a year, and they've been 10, 13, and you've sat in the hospital with them and you work through the hospital and behavior aids, they're going to cut your waivers and they're going to cut your funding. And then if you don't supervise that child and that child acts out, they're going to come after you for unsupervising that child. And then they're also saying, hey, when we recruit families, we recruit about 100 new foster homes a year. When we recruit families, we talk a lot about partnership parenting. And we want our families to partner with the birth families. We want them to walk with the birth families. As we've started more office, our reunifications are up and our adoptions are down. And that's exactly what we want to see in foster care. But now they're saying, hey, listen, if the state won't partner with us in reunification, how do our families do it? And what does a family do when they hear that the family they've been supporting now doesn't have visits? They don't have counseling. And how do our foster families work with those birth families? And so I believe that is one of the challenges. I believe we've got to figure that out. I don't think anybody's here to throw rocks at anybody. for DFACs or anybody else, we believe in a public partnership. I know you guys can't do it alone. As providers, we can't do it alone. And so I believe we've got to find a way to work together. And if there's some budget cuts that need to make, and we all need to talk about that. And somebody said it's so perfect a minute ago. We just want to be I think it was Heather. We want to be at the table. We don't want to get an email that says, oh, by the way, we cut your waiver 45 days ago. Just thought we'd let you know. We want to have a conversation about it, because at the end of the day, we raised $2 million to do what we do. And somebody talked about earlier about providers. What if providers go out? What if Families for Families goes out? Does it really matter? It doesn't really matter, because I'm sure some other agency will step in. But as Families for Families goes out and other providers go out, you don't just lose the provider, you also lose the staff. You also lose the $2 million that we raised to put back into the community of our children. And so I have 2 children. They're 12 and 13 that we adopted, that were abandoned babies here in Fulton County. They both have special needs. This is very personal to me. And so thank you guys for letting me share. And that's all I'm going to say.
Thank you so much. That was very moving. Thank you. Does anyone have any questions for Mr. Noggle? No. All right. Thank you.
Thank you.
Oh, well, Mr. Noggle, looks like we might have one. Representative Glaze, do you have a question for Mr. Noggle?
First of all, I want to say thank you for sharing. I am always at a loss for how humanity is said to be emotional. So thank you for the stories that are true that you shared with us. I can't figure out why we have to say one is not the other. One is the other, and we need it. So my question, how many years have you been doing this work?
So I started my first agency in 2014. I was there for 2 years, and then we started Families for Families in 2017. And we've started 9 offices in Georgia since 2017.
And you gave us a number of 2 million. Do you know what those dollars really look like when they go into the economy of the communities?
So I know this. So DFACS pays us about $8 million a year. 4 million of that goes into our account and out to our foster families the next day. My payroll's about $3.7 million a year. So really all the money that we get from DFACS really just covers our payroll on the Families for Families side. And then we raise money for support services, whether that's date nights for mom and dad and all that kind of stuff. Whether that's we buy a lot of meals, we buy a lot of clothes, because there's just not enough funding for that, which other providers have already talked about that. But I would say a big part of it is just payroll and providing jobs for our people. And know this, we're getting 1% raises. Cost of living is going up 7 or 8%. So we are giving raises a lot quicker than we're getting paid for our staff.
So it sounds like just the math, you're doing $1 really turns into $4 into the economy.
Yes.
Thank you.
Thank you so much, Mr. Noggle. You have a good day. Thank you for being here.
Thank you.
Okay. For some of you, this may seem like a long and unusual day, but this is often what my appropriations subcommittee hearings are like, and usually several days of them. So learning to listen, learning to really hear what people are saying, and then trying to figure out what we can possibly do. It's important to always hear all sides. Next up is going to be Commissioner Broche, and I want to make it clear that it was requested that she speak last, that we let everyone else go first. So it's not that we're saving her as an afterthought at all. I want everybody to be aware of that. I don't want anybody to leave the room unless you absolutely have to. Let's stand up, take a deep breath, and just stretch your legs 1 minute, sit right back down, and we'll get to it. Feels good. Okay. Yeah. Is your leg better? It is kind of right now. I'll lift my ass. Okay, let's all sit back down now. Let's get back to it. I know everybody wants to get home.
Could you check and see if we have additional Zoom members on? Yes.
Taylor, Draper, and Nickerson. Darlene Taylor. Linda Taylor. I think we have a couple of people on Zoom. Chairman Camp, can you tell us?
Sure. Okay, so additionally, we've had some shifting today, and I certainly appreciate all the members being here and everyone who's participating in Zoom as well. And we have Representative Rhonda Taylor on Zoom with us now, Representative Draper, and Representative Wilkerson. So we, in addition to Gold, Wade, Jenkins, Gold, Wade, Jenkins, and Townsend. So we have a number of members participating today, so we're very thankful for them. We're thankful for technology, but we're very thankful for everyone who's here in this room with us today to be a part of this. So thank you. And Commissioner Brose, thank you for being here.
Sure, I'm glad to be here. Good afternoon, chairwomen and committee members. My name is Candace Brose. I currently serve as the Georgia Department of Human Services Commissioner and the state DFACS Director. Our agency has three main divisions: Aging Services, Child Support Services, and DFACS, and we currently employ just shy of 9,700 workers statewide. Today, I'll focus my remarks on recent budget adjustments in our deficit. And before I get into that, I'll just give you some background. Right now, there are 9,976 children in foster care in Georgia. And over recent years, the number of children in our custody has remained largely steady, despite the pandemic's effects on child welfare agencies across the nation. Still, like our counterparts, Georgia's child welfare system has too few foster families, limited group home space, healthcare gaps, workforce and provider shortages, and budget constraints within which we must operate to ensure compliance with the law. Child welfare agencies everywhere are grappling with these issues. If you do just a Google search, you can see other states that are dealing with this, having to go to their legislature and ask for additional funding. And I've talked to some of my counterparts too, just to see if there are any lessons or anything we could compare, and we're all sort of coming up short. Some of the variables that go into this overall equation aren't new, but some of them certainly have changed. So hopefully I'll be able to convey why we've had to take drastic measures. And it is truly to keep the lights on. Under state law, DFACS investigates child abuse 24 hours a day, 7 days a week through Child Protective Services. Last calendar year, we received almost 121,000 reports of suspected child abuse. Out of those, we launched almost 38,000 investigations, and ultimately we worked nearly 24,000 family support services cases and 78,063 family preservation services cases. And that is with 2,494 caseworkers. In those instances, in family support services cases and family preservation services cases, we're trying to keep the family intact with community-based resources, with care coordination and similar measures to ideally avoid those children coming into state custody. But if we uncover abuse or neglect and the child's safety cannot be assured, we seek custody in juvenile court. To enter foster care under state law, a child must be dependent. In other words, abused or neglected. The system is not designed for non-dependent children. And I know some of you have heard me talk about this. Some of these points may be redundant, but it's important for this overall conversation. The system's not designed for non-dependent children. It wastes precious resources, it demoralizes our workforce, and it inflicts irreparable damage on families. Ultimately, we strive to seek a child's removal from their home only as a true last resort. Usually, the most pervasive form of child abuse that we encounter is neglect. But as you know, child abuse exists in many forms. Physical abuse, it can be sexual abuse, it can be educational neglect, it can be medical neglect, it can be abandonment, and more. Importantly, DFACS has no authority to unilaterally take a child into foster care. We need judicial approval. Courts are legally mandated, as we are, to exhaust every alternative before ordering a child into foster care. If they place a child into our care, it triggers a cascade of events. The Juvenile Code mandates that hearings occur at very specific intervals. A child's parents get legal counsel, the child gets legal counsel, DFACS has legal counsel. At the outset of custody, we try first to find a safe relative or family friend, fictive kin is what we often look for, with whom the child can reside while legal proceedings pan out. If those are not options, we will look for a foster home next, or a congregate care provider for their room, board, and watchful oversight. Along the way, appropriately so, the judicial branch is holding us and other parties accountable. Juvenile court judges order services to be provided to parents and foster youth. They monitor the parents' progress and ours. They can and will hold parents and DFACS accountable for shortcomings. The child welfare system is statutorily designed to pursue reunification of that family, although reunification, unfortunately, isn't always the outcome. So permanency for the child is ultimately paramount. DFACS pays for preventative services in cases where we can safely keep the family intact with the right support, and we're budgeted to cover per diems for the adults and providers who house and protect kids in our legal custody. How we pay for all of it is wildly complex. Some of our spending is discretionary. Case managers and supervisors in local DFACS offices work together to determine what referrals a parent or child needs, if the child is in our custody or not. And we have a network of hundreds of providers who do this work day in and day out as invaluable partners. If a court is involved, we'll take our recommendations to our lawyers, the parents' counsel, the child's counsel, guardians ad litem, court-appointed special advocates, the people who have the child in their care, and the judge. And the judge usually gets the final say. Our spending choices are driven by our mission, policies, and standards to ensure a child's well-being, but we're not the only people making those determinations, which is a good thing. So some spending isn't discretionary, and statewide, judges order DFACS to provide very specific interventions and care as dependency cases pan out. Most of the time, we agree with those additional supports. Sometimes we don't. But we must comply because the consequences can be quite serious. We don't want children to be sent home to unsafe situations, first and foremost. We want to make sure that we're providing meaningful social work and assistance to vulnerable families. And we also don't want to go to jail, which is a possibility. The code contemplates the judicial circuit through county funding can absorb some of these costs, but the vast majority of the time, DFACS is the payer to the tune of hundreds of millions of dollars every year. Some of you have heard me say in prior budget hearings or committee testimony that the needs of Georgia's children, the ones with whom we're working, are growing more and more complex, and complex care is time-intensive and expensive. In recent years, the overall foster care population hasn't grown or shrunk in big numbers, but the proportion of children in care with complex needs, as well as the cost of caring for those youth, have skyrocketed. Caseload-wise, a few hundred of the most complex children require the majority of our bandwidth. And long before this exponential increase, we were stretched too thin. Over the years, our responsibilities have grown far beyond keeping children safe from abuse and caring for foster children. We do a massive amount of preventative social work, keeping thousands of children appropriately out of state custody. And children are entering foster care who aren't technically dependent. Some examples. They've been skipping school. They have pending criminal charges or related history. They are medically complex and their parents are struggling to get access to care. Or the child's mental health needs have completely exhausted their caregiver's capacity or willingness. Instead of probation or detention, with juvenile justice reform as well, some youth will get referred to DFACS. Policy-wise, it makes sense for many, many children. We also get referrals for children that have serious mental health concerns. But resource-wise, for those general categories, we're not covered. Those resources exist primarily elsewhere, sister agencies, or for us, they're non-existent because we cannot find those providers. Those children, often teens, are very hard to serve. Your average Georgian also does not think about calling the Department of Community Health, the Department of Behavioral Health and Developmental Disabilities, the Department of Juvenile Justice, their local community service board, a federally qualified health center, etc., to get access to services for themselves or vulnerable children. To them, that is just alphabet soup. But everybody knows about DFACS. We're not resourced for the magnitude of behavioral and mental health related work that we're now performing. Several other players in the child welfare community play a role here too. I've previously spoken to the challenges stemming from lack of access to timely, comprehensive health care for foster youth. Denials are frequent and providers are too few. We will pay, though, for outright for denied or inaccessible health care, even though on paper it's covered by Medicaid. So those are duplicative payments. We don't want our children to go without. Judges, as I mentioned, play a huge role in the child welfare system. Sometimes children with complex needs or history enter DFACS custody over our and our parents' objections. We'll be ordered to provide services even if we don't have the provider's expertise or money. I'm not saying that that's their fault. I'm saying that there are so few options for everybody operating in the child welfare space, especially these days. Those children needed community-based intervention long before they reached that judge or our agency, but we cannot go back in time, and now we cannot risk the alternatives. So we comply with those orders, but technically those children may not even meet the legal definitions for dependency. Legal caregivers who choose to abandon their parental responsibilities to care for a child who's ready for discharge from a hospital or detention facility are often placed in DFACS custody, sometimes before we've even gotten a report or had an opportunity to investigate ourselves. It's not just DFACS stretched too thin. Our providers are operating far beyond their actual resources. The governor and legislature, thank you, have funded provider rate increases in recent years, tens of millions of dollars. So most of our partners have been able to stay somewhat afloat, and we're very grateful for that. But you've heard testimony today about the number of providers that have gone away. For every provider, that's multiple places for a child. They're gone. We are hundreds of beds short from where we were a few years ago. Providers also still cannot find workers. They struggle to recruit foster parents. Every day, in various ways, it is becoming harder for child welfare providers to stay in this field. Although the foster care population has been stable in recent years, the milieu of children is not the same at all. Our staff are not caregivers, they're social workers. So that is a huge struggle. We also don't control foster youth healthcare coverage, and we don't run any psychiatric facilities. Back in the day, that wasn't necessarily the case. Today, we don't. Our kids more and more need mental health treatment and psychiatric facilities. The pandemic decimated an already struggling adolescent mental and behavioral health system, especially in Medicaid. The nation's most vulnerable children with safety net coverage like Medicaid, and even some of those with private insurance, often have no one to see and nowhere to go. If families with private insurance cannot find mental health services for their children, vulnerable families that are grappling with unemployment or housing insecurity and hunger face absolutely insurmountable challenges. And we get those calls. And these days, our phone is ringing off the hook. If we're trying to get any behavioral or mental health treatment for a child, whether we're working a case where they're still living at home or the child is in our custody, we will encounter insurance denials, months-long wait lists, and more. And hopefully we also don't have a looming judicial deadline. Specifically for residential psychiatric treatment for foster youth who are getting Medicaid, child welfare leaders have been forced to compete against their similarly Medicaid-reliant colleagues in other states and non-foster youth with private insurance for bed space at an extremely limited and shrinking number of mental and behavioral health facilities nationwide. Bidding wars are rampant. At this very moment, according to our records, about half of the bed space at Georgia's psychiatric residential treatment facilities is occupied by out-of-state children. Other states with higher federally approved reimbursement rates crush the competition for services and residential treatment for their foster children on Medicaid. And I want to be clear, if families cannot get community-based treatment, if they can't get this type of treatment, they are coming to us. And that is not where they need to be. One child welfare agency or its managed care company can negotiate a Medicaid reimbursement rate of $700 plus or $800 plus a day at a Georgia-based crisis stabilization unit, psychiatric residential treatment facility, or substance abuse treatment facility. Georgia children being served by Georgia agencies will lose. A colleague of mine said it best. It's a seller's market. The rates keep creeping up. And as a state agency head, you have no choice but to say, where do I sign? At all costs, we avoid sending foster youth out of state because we want them to stay close to their loved ones. But we need access to the right services and facilities within our borders. If it doesn't exist and a child needs it, or we've got a deadline to avoid contempt, we are going to pay what's demanded, even if it's thousands of dollars per day, and that's routine now. Or we'll turn to our own providers to negotiate a rate for them to accept the child and do what they can. And thank goodness that we have them willing to do that. The alternative is putting that child in a hotel, which is not only the worst place we'd ever want to house a child, but also financially problematic because those dollars could be spent better with the child in a better equipped foster or group home. If we're talking roughly $1,500 per day, which is the hotel room expense, meals, transportation, contracted supervision for behavior aids around the clock, and more, we would rather spend it on our providers. So how do we pay for all of our work? The traditional casework, preventative services, and foster care. Again, it's a combination of federal and state funds. We've got state dollars and several federal fund sources and grants, some of them big and some of them are smaller, to make our ends meet. Medicaid, I've talked about, that should cover health care. That's not always true. We've got the federal TANF block grant. Plenty of people before me today have talked about TANF. Georgia heavily relies on this fund source for child welfare expenses. We are an outlier compared to other states. This was a decision made many years ago, I think during the recession, that we would use TANF specifically to cover more foster care related costs. We also use Title 4E funds. Both of those come with serious strings attached, and specifically for 4E, it's tied to outdated eligibility standards and family dynamics. Not every expense can be billed to those, and under existing frameworks, federal frameworks, child welfare agencies everywhere and their providers are hamstrung. For 4E funds specifically, Georgia is uniquely disadvantaged, even compared to our neighbors. Title 4E's maximum income threshold for children entering foster care has not been adjusted since 1996. It's something Congress would have to change, which means, though, that Georgia cannot leverage this fund source for thousands of children who have or will enter state custody. And we're talking tens of millions, potentially hundreds of millions of dollars we cannot get. There is a complicated multi-part eligibility test to determine if a child meets the criteria for 4E to cover the cost of their care, and only about 35% of Georgia foster youth are even eligible. Even if we find an eligible child, recent changes to federal law have capped our ability to use 4E as a fund source for the child's congregate care, group home type settings, for those expenses beyond 14 days unless the facility meets a statutory exemption. I'm talking about federal statutory exemptions. I can go more into those nuances or you can trust me when I say that the criteria is really strict, and our providers, frankly, providers everywhere are not clamoring to convert to exempted models of care for us to leverage those dollars. We're not talking about a ton of kids that are even eligible for it in the first place, and these are incredibly complex changes that they'd have to implement in order to convert a group home into something that we could bill federal funds for under 4E. When those federal changes went into effect in 2021, we had to stop using 4E to pay for those stays and switch over to state dollars. So overnight, we had a roughly $11 million hole. That same federal law did, however, expand how we can use 4E to pay for preventative services, which we applaud, and we are running pilots in several counties. But that expansion will not fix our current deficit or serve kids already in foster care. Our current projected state funds deficit is roughly $85 million. That is just for state funds. The most simplistic explanation is that we have more expensive children on our caseloads, and we do not have full control over managing those costs. Before the federal shutdown occurred, we already had indicators of a spending deficit in the out-of-home care budget, which is where we pay for services in foster care. But there was also significant talk that TANF, specifically our $329 million annual block grant, could get cut. Throughout the shutdown, that block grant wasn't funded. Only gotten access to it this week. We're nearly at Christmas. The federal fiscal year started at the beginning of October. We moved money around. We became more reliant on state funds immediately, despite already being in the red. As the shutdown dragged on, as we continued to run the numbers, it became clear that we had to make changes and fast. And I waited till the absolute last second to do it because I knew that what they would come and talk to you about would be tragic and catastrophic. But that's where we are. First, we had to limit what transportation providers can bill, and we put more constraints on behavior aids. For those who aren't familiar, we use transportation providers to take children and often their parents to and from visitation, for example. Visitation is court ordered, but it's also regularly ordered at a higher frequency than maybe what we've originally established, or it's on days, at times, or at locations to accommodate parents, like weekends or after hours if they work. We support that. As for behavior aids, we use those to provide additional supervision for our children, often at the request of our providers who believe the behaviors and complexity of our youth necessitate it, especially if the child really should be in a psychiatric facility, but no bed is available. We will pay for that. The most complex kids might need a behavior aid several hours a day. They might need it around the clock. They might need more than one around the clock. The provider with whom that child is living might need one because they're short on staff or to avoid having to eject that child. Behavior aids can be court-ordered too. Next, we identified state-funded contracts providing specialty, but not legally necessary care, and even some of it you might consider duplicative. And we gave 30 days written notice to terminate. Then we implemented state-level review of service authorizations for things like drug screens, behavior aids, transportation, certain behavioral and mental health assessments, expert testimony at court, and other categories. The memo that we sent out to our staff said specifically that we suspended access to these service codes such that our case managers could no longer put them into the system that we built, Argo, without higher oversight and approval. So for a few weeks now, state office leadership, I'm one of them, has been reviewing every service authorization request to determine if we have the appropriate documentation and court orders. Importantly, many of these impacted service categories already had constraints. Staff have long been expected to properly document need For some, we also have asked for proof that Medicaid wouldn't cover it. And there are spending caps where staff have to seek a waiver from regional level leadership if they want to exceed certain thresholds, which is usually in the several $1,000s range per family. So this process wasn't entirely foreign, but it definitely was additionally bureaucratic. And I don't know what else we could do, frankly. Out of these requests, which we get hourly and review for approval or further clarification same day, and I've heard our providers say that those may not be reaching me, and I believe them. But even if every single one of them did, I don't have any money. So I can get a list all day long, and I cannot pay for them. So I've had to make some pretty tough choices. Fortunately, I have not actually denied more than a handful, and I mean truly a handful. I think I'm talking less than 5. But now I've got pretty good documentation that I can provide to you to show why we really need more funding and how I've done everything I can otherwise. One example of something that we do see and perhaps need some additional consideration. This goes back to court-ordered services. The vast majority of our judges are, like our providers, invaluable partners. They work hand in hand with us. They understand what we're going through. We can go to them, and we have been going to them to tell them, we know you've issued a court order. We're going to do everything that we can, but please understand where we're at, and they do. But not all of them. This is an example of a denial that I did. A judge ordered DFACs to provide in-person substance abuse treatment in jail for a mother who had not been working her case plan. The sheriff's office there does not provide in-jail treatment. They also don't let us provide in-person services to inmates. This is known to the judge. So I am violating a court order. But DFACs is not the answer for an adult's substance abuse treatment while they're incarcerated. That is not what we're budgeted for. It's not within our statutory purview. If you want us to do that, we will do it. But right now, we are not equipped for that. For the other denials, we're holding approvals until we lay eyes on court orders. Right now, under state law, we are supposed to be getting these court orders far more often than we do and far quicker than we do. But the system as a whole, right, we all accommodate one another because we're trying to do what's best for the child, what's best for the family. So we're having now to insist, though, that we have those court orders. Again, I need this documentation to be able to show to my appropriators that I'm doing everything that I can. And it's also been a helpful mechanism for getting, the judge to put that pen to paper and actually, really indicate what they think is appropriate for the family. It's good for the parents to see that and have that expectation laid out. It is what state law requires, and so that's what we're trying to do. This revised process has had a lot of value, and also asking our staff to put pen to paper to better document the need for a specific service authorization. And we have found instances where we probably shouldn't have been, but were defaulting to getting, for example, in the realm of drug screens. We would have staff that just, as a matter of routine, would ask for a hair follicle drug screen, a urine drug screen, and a saliva drug screen for a parent when one of them would have sufficed for purposes of our case. And they're expensive, certainly in the aggregate. We've identified areas where we should have instead asked the provider to meet a need. We might have negotiated some of the work that we would otherwise ask a different provider to provide. We would negotiate that as part of the per diem. So, here and there, we're having to sort of insist upon it now. Or for things like supervised visitation, we're finding that maybe it wasn't actually court ordered to be supervised, and it's just an expectation our staff thinks is appropriate for the case, but that doesn't really align with our policy either. So what I'm trying to say is we're learning a lot, and we've got skin in the game too. I mean, we're really trying to do what we can, while at the same time we're asking so much of our partners. So plenty of examples for why the change has borne fruit, but it cannot endure. And I hope it goes without saying, but I did not want to terminate contracts. I did not want to change how we authorize access to services and tie the hands of case managers. I did not want to frustrate the work of our partners, jeopardize relationships with judges, risk contempt. I also don't want to break the law by overspending my budget. So I'm in a real catch-22 right now, and that's probably too much of a euphemism. If we can identify common sense changes to our processes and utilization, or better leverage resources through other agency or community programs instead of spending our own cash, we want to do that, and we are doing that. But I would humbly ask for more resources so that we can stop worrying about how we pay our bills and whether we're going to lose more providers. Over the years, DFACS has faced similar budget woes, but not quite to this magnitude. So this is not actually the first time our books were in the red. We have found ways to manage to our budget. My predecessors would, for example, delay payments. There were monthly staff furloughs for years. They'd implement hiring freezes. I've had to implement a hiring freeze. They'd move money around in other ways. And even with that, the TANF block grant, fortunately, has been available to absorb several $millions in unexpected costs over the years, but we don't have that option anymore. Our current budget deficit is larger than our unobligated TANF. So even if the expenses driving that deficit were all TANF eligible, and they are not, we could not plug that hole. Right now, I am not the only child welfare leader appealing to their governor and legislature for more financial support. My providers are not the only ones either. Nationally, the child welfare system is seeing exponential growth in the cost to operate. By our very nature, we are a goods and services agency. So if those costs rise, things like inflation, those uniquely impact us. Our problems also did not evaporate when the shutdown ended. Until, again, this week, we have not been able to draw down any of our usual TANF money, despite how we've always relied upon it. And that fund source, along with Title IV-E, is dwindling. You've heard from several of our providers today. Please understand that we cannot survive without them. That is where Georgia's foster kids lay their heads at night. Those providers feed and clothe and comfort them when they've experienced the most traumatic event of their short lives. They work with parents and they help them overcome substance abuse issues. They help them work through their case plan so they can reunify. They take our children and parents to the doctor, school. They'll take them to practice, therapy, court. They are doing work in so many ways I could not properly convey today. A colleague of mine recently described our lack of resources and support as fighting a forest fire with a squirt bottle. That is absolutely true. I'm doing what I can with what I have. I do not have alternatives. I've tried to convey the need for more resources. If there's a silver lining to this situation, now everyone knows with certainty how badly the child welfare system needs help. If you feel any anger or disappointment about how this situation has panned out, it is not the fault of DFACS workers or our providers. Absolutely put that blame on me. but I am being forced to make decisions that nobody wants to make. I'll answer any of your questions.
Thank you so much, Director Bros. So we're going to give you just a moment, okay?
Thank you.
Of course, of course. In the interim, I just want to let you know we've had a few more representatives join our Zoom call. Representative Sheila Jones and Representative Kendrick, and also Representative Donahue. Saying thank you. We have more watching right now than we have in the room, but that's okay. Technology works. If any of you have a question, please let us know online and we'll try to put you in the queue to answer questions. This is a tough subject.
Mm-hmm. It's tough to see firsthand.
It is. And we appreciate you being here to talk to us about this today.
Thank you for having me.
All right. We have a couple of questions right now. We've got a number of questions. We're going to start with Representative Panich.
Good afternoon, Commissioner.
Hi.
You mentioned that judges frequently order kids without basis for defects. Can you give us some examples? And how many or what percentage of kids in the foster care system do you think are inappropriately given to defects for purposes of services they're not entitled to?
So it's not necessarily the judge's fault.
Well, you said it was the judges who are ordering.
For why they feel that they have to put the child in our custody. So let me start with saying that once a child reaches them, and it's typically through a delinquency hearing or a child in need of services hearing, what they'll find is that they're faced with placing that child in detention or trying to get community resources, and they can't find them. So we're not a party to those proceedings. And what they'll feel forced to do is they will put the child into foster care because people do in fact believe that we have special access to mental and behavioral health services, and we don't. Perhaps back in the day we did. You know, we used to have fee-for-service Medicaid for our children. We had bundled rates. You know, things were just very different a few years ago. That's not the case any longer. But you don't find in every situation that the parent is being callous about it. I mean, they just can't find what they need for that child. And so that is why some of them will enter custody. Now, there are judges that will do it and it's not at all appropriate. You know, and it will be that there is a parent that is, or a relative that could have stepped in, or there is some way that we could have gotten involved and it wouldn't require foster care. I mean, that's why we work family support services cases. That's why we do family preservation cases. And I guess overall, we're probably talking, it's again, I'm not saying this is a huge percentage of our overall population. And unfortunately, our case management system is too old for us to program to track it this way. But probably my best estimate out of just under 10,000 total children in foster care is perhaps around 1,000 of these, perhaps a little bit fewer, you know, would somehow fall within this category.
May I just follow up on that point? Do you ever appeal?
Oh, yes.
Mm-hmm. How many cases do you think you have on appeal for that reason?
So that's been fairly new. We try not to appeal our judges if we can work out some sort of alternative. You know, what it means for staff on the ground is that it can really damage the relationship with the court. They don't want to be appealed. But what we've decided to do is we just find that it's necessary. And what we'll do is we'll file a motion to vacate custody. We'll cite state law. It's actually a recent law that was passed, explaining that there was a certain procedure to follow before that child could come into foster care. And it would have allowed us to look at these alternatives and optional services.
Sorry. I can go back if you have other people you want to answer, but I have more questions, but I can wait my turn if you want to do, well.
Now let some others ask some questions
Sure.
and we'll come back to you.
Yes.
Okay, I'll put you on the list again then. All right, thank you. All right, we have Representative Oliver has a question.
Thank you. I assume or accept that you had the authority to terminate these contracts.
I did.
And as you said, you expected us to hear, I think your words were tragic and devastating results.
Correct.
And I believe those examples are true. Do you believe they're true as
Yes.
they've been described to me?
Mhm.
My question is, before you had to make this difficult decision, did you ask the governor for emergency money that would give you the opportunity for 1, 2, or 3 months for the General Assembly to come here and pass a supplemental budget to prevent these devastating and tragic circumstances?
I'm working closely with the governor's office and the Office of Planning and Budget about our budget issues. And I can assure you that they are going to do everything that they can to help us get out of this situation.
There's one person who has that authority in addition to you, and that's the governor. Do you think he would be willing to tell us whether or not he's willing to help you reverse this decision you made?
The governor's always been willing to help our agency. I have no doubt about that.
Are you willing to reverse this decision you made based on the testimony you've heard today? And I assume you've listened before.
Of course I would.
Is the answer yes, you will reverse this decision?
If I had the money, I absolutely would. I don't. I don't have a choice. And honestly, I had to make a pretty awful choice in selecting those particular contracts. But I'm having to compare the needs of different children and decide which one is more important in terms of priority.
I don't want to interrupt you. I just think it's very, very hard for me to believe that you don't have the money. I don't mean personally. I don't mean personally. When we have a $16 billion reserve and we have
I don't control that. And honestly, I'm doing the best that I can to provide evidence of why we need additional appropriation. And frankly, I'm not going to try to get into like a blame game or finger pointing. I think what I'm trying to focus on is telling you what we need and how it's impacting our agency and then see what we can do to fix it.
Respectfully, I'd like to know whether or not the governor will step forth and help you in the position that you have professionally.
It always does.
All right, thank you. You mentioned, obviously there's a budget problem. I mean, hello, that's why we're here today. When did you realize the budget cliff that the trajectory the department was on?
It's been, so I've been in this role for a little over 4 years. Each of those years we had a projected deficit at some point or another in the out-of-home care budget. And we're able to manage to that because thankfully, we have those investments from the governor and the legislature, and they've not been small. I mean, they've been tens of millions of dollars every year that I've been here to make sure that we were covered. And I cannot thank you enough for that. You've also, bolstered our workforce. So they've gotten pay raises, and that's huge. But it's been ongoing. And frankly, I think it's been a structural deficit for quite a long time. And that's why when we look back historically, we can see there are certain ways of how even predecessors would manage to it. So that's why you would have once a month staff furloughs. That's why you'd have a hiring freeze toward the end of the year. You're trying to play catch up. That's why they delay payments. 2 days this month, 2 days the next month, 2 days, and over time, maybe you buy yourself a month, right? Those are some of the tactics that we can see historically. And then as a last resort, we would, at the end of the year, right before we need to get into budgetary compliance, we would take a look at our other federal fund sources and see if we build things to state funds that maybe we could build to federal funds, especially TANF. And so that's been something that's bailed us out. We do not have that option anymore. We don't have that balance of unobligated TANF. And these are not all eligible uses.
Okay, all right, thank you. Representative Sharper, I believe you have a question.
Thank you so much. My biggest thing is anything that we do, it all relies on and is all about the kids right here,
Right.
the functional society. And, I appreciate everybody that's been here, giving testimonies, giving us more insight of what you do. Me being a paramedic for 35 years, and I've seen firsthand some of these kids that have to go into foster care. So I know about what's going on. But I think one thing we need to do, not only just this particular department overall, I think we have a technology issue, even when it comes down to the judges, the way things are done. There's different departments here that have been doing the same thing, the same way 10, 20, 30, 40, 50 years. And technology changing every 3 to 6 months now. So one thing we need to look at is the efficiency all the way across the board. We get to times like this and something happens, but there are some indirect things that can be looked at for as efficiency, how the judges, we may have a situation that the judges aren't doing doing what they need to do in an efficient manner. It may be a staffing issue. It may be a technology issue. But the main thing for me today is for us to look at our entire situation in this entire department. You guys, every provider, everybody in this room, look at yourself too and see what you can do efficiency wise to make things better at the bottom line for the children that we have in our community. And some of the people that may not be able to relate to foster care situations or defects, you can't turn a blind eye to it because at the end of the day, if they're affected, you're going to be indirectly affected. So I'm just here for a solution and a quick solution, but we don't want these things to happen again. So we need to all pitch in and say, look, what can we do to be more efficient? What can we do to have more hindsight? And look at what we can do overall for the goodness of our kids in this community. I just want to say that.
Thank you.
All right, thank you, Representative Sharper. Representative Glaze, I believe you have a question as well.
Yes, well, first of all, I want to say thank you. This is my first time, I think, hearing a full presentation of DHS. So thank you for a lot of what you said today. But I'm just looking at this. Okay, it looks like, and I'm going to get to the question on 9/30, there was the 85 million deficit. Is that not correct by here?
On 9/30?
Yeah, of this year.
Oh,
Based on what you gave
our
me.
current projection for the $85 million state funds deficit, it's been something that we've had now for some time. So we run our projections quarterly, so that's been something.
Yeah, so I'm going to
Yes, ma'am.
follow one line, okay?
Mhm.
One line of reasoning, if
Sure.
you don't mind. It says 85 million, right? But it does now say there's a new projected deficit
Right.
of 48 million. So my question was around what you requested in the budget.
Mhm.
So your request for the budget went in when?
A few months ago.
It was after 9/30 around. Yeah, it was after that, right? So I'm asking if there was an 85 million,
No.
why didn't we ask for more money in the budget at the time of your submission to the budget? That's kind of where I'm going. That's why I'm
Right.
using dates and amounts.
Right.
Mhm.
Well, so we submitted projections before that. The new number that you see is if you take into account the cuts that we've had to make and the changes that we've had to
Yes,
make. If we continue those for the rest of the state fiscal year too, which I don't think anyone wants to see. But as you can see though, that means we still would not be out of the hole.
So the real question is, in the budget that you sent to us, it is a flat budget. It doesn't show any of the amount of money that you really need to run the agency in the deficit. So my accounting and my auditing mind is just trying to figure out, why would you submit a flat budget when your budget deficit is twice the amount of what you submitted? I'm just, for me, I can't get past that, just the numbers. So help me understand that, if you would.
So The governor's office sent out the direction to agencies to try to identify ways to be more efficient, given some of the revenue collections and other metrics that they follow all the time. We comply with what they ask, but at the same time, we also work closely with them to make sure that they understand our needs. So they do, and I have faith that that's something the governor's office is going to address in their recommendations.
I just have one follow-up question in the numbers. I believe in October 2025, we're going to have an increase of about 25% in the SNAP program. We're taking on 75% of that now, so that's going to be 25% increase. And so knowing that, I still can't get to the fact of why we would be submitting from your agency a flat budget when there's about 10 to 13 other agencies in the state that did not follow a flat budget. I mean, you've got increases that are way beyond what you have any kind of sphere of influence. They're coming out of the HR1 for sure. And so even adding them, was that not a opportunity, or there wasn't any thought about adding that into the budget request for DHS?
So the HR1 requirements that will apply to SNAP don't take effect for a few years for us. So, but what we have done is that we've been working on in terms of the cost sharing components. And so we are working on what we need for that and the technology changes we need to make and the workforce changes. And so as we do that, we're providing what we think are the appropriate estimates for additional money that we would need in the budget in future years.
Okay, I don't think I got the question answered about why we are in a flat budget when we have a deficit double the amount in the size of the request. And so, but thank you so much for your response.
Sure.
All right, thank you, Representative Glaze, and Representative Rice, I believe you have a question as well.
Yes, thank you. I want to say, first of all, I don't envy your job at all. I know that it comes with great difficulty and magnitude and hard situations. Also, I'm very thankful of our providers that have shared with us today. And for every one that shared, there are dozens around our state that aren't here that are experiencing the same thing. And there's so many different layers to this, but I'm just going to say I'm going to focus on the most vulnerable in this whole situation, and that's our children.
Right.
And so I would like to hear like what immediate impacts do you see that has already occurred that this funding shortfall has on our foster children, and particularly with placement stability and access to services. Stability is absolutely crucial. I know that you're aware of that. I see that we are stripping that away. And that not only gives me heartbreak, it angers me. And I'm gonna be honest with you on that. So I want to see how we're collecting that info. And do you have any at this time?
So one of the biggest impacts is that we had flexibility where we were negotiating child-specific rates for providers for the ones that have really complex needs. And outside of the normal, we have a 3-tier structure for the per diems that we pay. But we injected that additional flexibility because frankly, that's what the child needs. And so that's when you've heard about the enhanced rates or waivers, that's gone. So that means that we're having to take away that additional financial support. On top of that, it means that we've had to take, additional supervision away from certain children, behavior aids in particular. So we may have had a behavior aid that's accompanying the child in their placement, or taking them out into the community, and we've had to dramatically curtail that option. I've neglected to mention this, but I think it is important. You know, the biggest cost drivers for the deficit, those are behavior aids and transportation. And so another big impact to it is that we're having to make really hard decisions about how we facilitate transportation, how visitation between children and their siblings and their parents. And, you know, we're having to ask case managers to take on far more of that transportation responsibility. And look, a lot of them have done that for some time, but they cannot do it all the time, and it takes away from all of their other cases. So you have one case that then turns into all their other cases being, you know, set aside, and it just does not bode well for their overall caseload. We're having to ask our providers to take on some of these responsibilities without compensation.
So let me ask you on that. So on the transportation, if it's not provided, and whether that is a group home or an individual foster family because of work, they are not able to do that. Does that potentially put non-compliance with the judge's order with visitation and or the repercussions for that? So, you know, if the transportation's not there and it's being stripped away, how can they continue to operate with the judge's order and compliance?
So we wouldn't be in compliance with that if it's court ordered. And fortunately, we have so many judges that are trying to do what they can to help. I mean, quite literally, we've had judges try to go find resources for us in their community. I have been approving so many of these service authorizations. So we're just going to go further into the red. And for those, you know, it's because I've had to balance the absolute worst case scenarios. And, you know, I don't have a choice but to go more in the red.
Okay, and can I ask one final question? Just to confirm, the TANF funds that are unobligated, are you saying that is a net zero balance?
No, it's
So
not.
What is the unobligated TANF fund balance?
Based on what we expect to pay and what we know we have, I have the exact number, but it's somewhere in the $30 million range.
Thank you.
All right, thank you. And Esther Panich, Representative Panich, I do believe you have another question, and then we've got one from Representative Donahue online, so go ahead.
I want to go back to you that you said that you had told the governor, or the governor knows, and he usually helps. So we're here. The governor has not stepped in. When did you first alert him how bad this was? Because the ripple effects, we have people who are going to lose their jobs, our providers who are going to not be able to recover. The kids are going to be, you know, they're going to be left with no hope. The parents who are supposed to see these kids are left with no hope. We were told that at least one has relapsed because they don't get to see their kids. And these are people on the edge to begin with. So that just means the hospitals, emergency rooms are going to be taking over, and the jails. And so it's hard for me to imagine that you told the governor just how bad this is, and he hasn't done anything with the $14 billion surplus he has. So please tell me, when did you first tell the governor just how bad this was?
We are constantly working with the governor's office.
That's not my question.
You knew that. I'm trying to answer your question respectfully. So it's an ongoing discussion, but just by how we operate, our numbers change hourly. So we don't have a way to forecast the children that we will need to seek custody for, or the families that will get referrals to us. I mean, we just can't. And this is in other states. So here's a suggestion, perhaps there are some states that have quite literally quarterly meetings even with their legislature to keep them apprised of where the deficit's moving or where the money's going based on the populations they're serving. But the reality is I keep them apprised and they're always asking where we're at. But I mean, this is recent. It
How
happened
recent?
very
Because
quickly.
it is September 30th. We're already in December.
Sure.
You made $85 million, or we have the deficit, and you cut millions of dollars of contracts. At the time you cut the contracts, had you already told the governor you needed help? And did he offer to help?
Yes, and he will. He is going to.
But when? You've already cut these people's contracts. When do you expect the governor to help? Because he has the ability to do so. When do you expect him to do it?
At the right time. I have complete confidence in that.
How is this not the right time several months ago when you stopped paying these providers? If now
It wasn't several months ago.
When is the right time? How much more in the deficit do we have to be? How many more kids have to suffer until you believe it's the right time?
Do you think that I've chosen for us to be in this position or I've somehow mismanaged the funding to get to this point?
I have no idea, but $85 million has been cut. You've known about this for several months. We didn't know about this for several months. You could have asked for a special session. You could have asked the governor to give you emergency funding, and we don't have that at this point. So we're left trying to clean up the mess that your agency has made.
Okay. I did mention in my testimony that we're not the only ones that actually control the costs that we incur.
I know, but you're the leader of the agency.
I do not manage judges. I do not manage the number of people.
10%. 10%.
I also said that those are the most expensive children that come into our care, that they take up the majority of our bandwidth.
Please send me the numbers on the ones you have appealed showing that you have been pushing back on the courts. I'd appreciate if somebody can send that to me.
Absolutely, we will.
Thank you.
All right, thank you. We also have Representative Donahue, and I believe Katie Dempsey is going to do her best impression of Emory Donahue.
Actually not. Don't look forward to that. So he has been in a place where he's had to leave right now for the moment. So he's asked me if I can ask a question or two, and I'm just going to ask what he's sent, okay? To what extent has the department's policy on high cost, no non-reimbursable placements such as PRTF group homes or emergency placements contributed to the deficit?
Can you say that one more time?
To what extent has the department's policy on high cost, it says no, but it's non-reimbursable placements such as PRTF group homes or emergency placements contributed to the deficit?
So we will, I think what he's asking is, how much are we paying for like psychiatric residential care when maybe it should be covered by Medicaid? Related services, and every year it's going to be tens of millions of dollars, state funds.
Okay. So it would be fair to say that it has definitely contributed to this.
Absolutely.
All right. Okay. That's his first. Here's the second one. Also, what extent has the department's policy on enhanced rate approval for RBWO providers and DFACS foster homes contributed to the deficit? How much was spent in each of the 5 fiscal years on placement?
I have those exact numbers and I can provide those to the entire committee. But again, we're talking about it's a substantial number. And the justification is that otherwise, in most circumstances for those type of youth, they would have been in a hotel or they would have had an office stay. And so, it's a better use of our funding to actually negotiate a specific rate with providers as opposed to spending it in a hotel setting.
Yeah, so if I can take a minute, and then we're going to get back to a couple of more questions that are on the board right now. I know some of the committee that's in here is not on appropriations. So this is the first time that those who are on Judiciary Juvenile is hearing some of this. This is a process that we go through. I'm not going to say that it's usual. It is the usual process,
Right.
but we're in a very unusual time where unforeseen things are taking place. Many, at many levels, some that are completely out of our state's hands at this moment. Now, appropriations responsibility, with the help of everyone here, I'm not saying that y'all are not going to be involved in it from that committee, because it matters. It matters to you. It was brought to Chairman Camp, so we decided we would do this together. But it's going to be very important for us to work very hard to figure out how we make this better and how we do that quickly, and who can help us do it and who can help you do it. So I don't want you to feel like we're not going to do that. Chairman Hatch and I are texting a little bit.
Right.
We both realize how intense this is. The providers in this room are facing a very critical moment in time, loaded with frustration for the work that you want to do and people who want to do it, but who also have to be paid to do it.
Right.
That's the reality.
Right.
We're going to get there somehow, some way. Want everyone to understand that these monies were to last until the end of the fiscal year too. It's very important to realize that this money was to be in place to fund everything we're doing and other services that we're not talking about today as well until the beginning of the next fiscal year, which is July 1. So this is serious. I don't want you to think it's not being taken very seriously by everyone involved. I want everyone to ask all the questions that they can. I know the commissioner will answer them, but I want us to have a walk in reality of where we are, that in the 15 years that I've done the budget, we've had challenges, but we've never had one like this before. So we'll get there somehow, some way.
I will say we've had some recent analysis done by the University of Georgia professor there named Daniel Gibbs. And so we can circulate this too, because to me, it's very, very compelling and very eye-opening. He used numbers that states report to federal regulators. And so these are not numbers that we've given him. But what he found is a truly exponential, actually exponential increase. I think it's from 2022 to now of children with what would meet the category of severe emotional disturbance coming into our custody. And it's not just us, but every other state's child welfare agency. And so it is very much a sudden onset of very complex children that now are on our radar and we're trying to serve. And that's in the aftermath of us losing so many providers and so many homes. That's what we're having to deal with right now.
So my goal is to say, let's not all panic, really and truly, because we need each and every provider. We need this agency.
Right.
And we have a huge responsibility to take care of these children and families and other parts of your agency as well, who are in great need. So
yes, ma'am.
Let's go back to the questions. I think you take us.
Okay, well, thank you, Chairman Dempsey. Thank you. All right, so we've got a few more questions. Representative Glaze, I believe you have another question.
Well, first of all, I want to thank our chairwoman, Dempsey, for sharing what she just shared. And I know the place from which it comes, this experience, but it's also from a place of knowing that if there's anything that can be done, she's going to be advocating. So I want to say thank you. I do want to just close this out, having sat here all day. Sorry, hope nobody gets sick today, but I wanted to be here because this was gravely concerning me, that we are here and on the brink of a service expiration to children who, for us, our basic obligation is to protect them and support families when they need us the most. And that's what all of us do as we sit in these elected seats. I would ask, and I hope that, and I believe the governor's office is listening, that not one jot or tittle, yeah, I'm going to the Bible, should fall from the support of these children when none of this had anything to do with them. And there is a great amount of money, 9 billion unrestricted funds sitting in the coffers of the state of Georgia. So my appeal would be to those who are much higher than you and I, that the children would be at the focus and that the work would be done in the coffers of having that kind of money for such a time as this will tell us if Georgia is the right place to be as a family, as a child living on the edges of society. What we do with this problem, I believe we can resolve it because we don't have to look far to do it. The will of the leadership is what we and what I asked to appeal to. And I'm honored to sit with this group here today and to learn and to hear from all of you guys who sit and have helped me and many of us be clear about what is at stake. And so I want to say thank you for an entire day of your work in hearing that. And I'm honored to work with you. And I believe that Georgia must understand our reputation, but also our honor sits on this and how we will handle our children and families who sit on the edge of society when we have the money to do it. Thank you, Chairwoman.
Blaze. All right, we have a question from Representative Santos.
Can you hear me? Okay. Thank you. I just want to say I realize that it's very high emotion for everyone in this room, and I believe I've seen a few of you wipe tears. And so I just want to, I guess, remind everybody in the room and who's listening that this meaning the issue that we're facing today should really be a priority for all of us, and we really need to put other things aside. You know, as a single parent, I can tell you I've had to go without food to feed my children. And I'm hoping that Georgia can go without some other things that we budget for if we need to if it means taking care of the vulnerable children that don't have parents, children that are now adults in this room have shown how great they can be with the right support, right? And so I think this is a moment that we have to show who we are as Georgians and rise above these challenges. And I'm just hopeful that everybody in this room can advocate leaving out of this room for these children, regardless of who they are. And the reason I say that is also because I want to know about the children that are falling through the cracks, specifically children that have absent parents because their parents are held in immigration. If the children in DFACS are court triggered and are only dependent children, does that also include those children that are left without their parents due to their parents being detained?
We do, in fact, have many undocumented youth in our custody, and we we seek custody of them. We make no distinction based on someone's citizenship status. I mean, we're just focused on the child safety. Really, the only distinction in terms of how we care for them is that, they are ineligible for some federal programs, and so their care is state funded.
Okay, Madam Chair, may I ask a follow-up? So I think earlier I heard you say that we could not have forecasted this. So with the current situation that we're all seeing, I think personally, I think that we could have known that there would be children left without parents because of what's happening. So could we have possibly prepared for that?
I don't know. I mean, we just try to operate within our means for what's been appropriated. And so, certainly in recent years, the number of undocumented youth that we work with has increased. And we try to meet every need that they have.
And a lot of those are American citizens,
Sure,
as well.
Oh,
I would
sure.
imagine.
I mean,
Yeah.
sure. We don't make any we don't pay attention to a child's citizenship status.
Well, thank you.
All right, thank you. We've got one more from Representative Oliver. Please go ahead.
Oh, thank you, Chairman Dempsey, for reminding us that panic is never an option. I say that, try to use that often, so thank you for that reminder. It might be helpful to those on the Appropriations Committee, as others too, to have a timeline about the last year. I don't remember, but you probably do. In the public hearings of appropriations in January 25 to this subcommittee, did you say we had a deficit at that time of about $36 million, if I remember correctly?
Over my tenure in this position, we've been sharing that, honestly, each time that we've provided estimates, we're operating in a state funds deficit.
Is that number accurate from January 25?
It was at that moment in time, but again, I mean, it changes so frequently, and it's so contingent on the availability of federal funds. So, another unforeseen variable about this is, the access to the TANF plot grant. We didn't have that for the federal throughout the shutdown, and even still until this week.
In fiscal year, for all of this, when the budget was passed for fiscal year 26, what appropriation was given to satisfy the deficit? What was the dollar amount?
I think it was it
40 something, 36 million?
No, not right.
It might be easier if you gave us this timeline to put it in writing to us. And because your board voted in September for a $40 million increase. Your board voted for a $40 million increase, and that was not passed on to the governor. Is that correct?
Well, we provide all of our budget information to the governor's office. Again, it's an ongoing conversation.
Did you ask for the $40 million increase your board asked for to the governor?
Yes.
Okay. If you could give us this timeline, I think that'd be helpful.
Sure.
So we could see where, is it accurate that to restore the contracts that have been terminated, it would cost $8 million? Is that an accurate figure?
I can tell you. I don't know that it's quite 8 million, but I don't want to constrain the number given some of our other challenges. The MAC contract, I believe, was I don't have that number in front of me, but it was between 1 and 2 million. I believe that Creative Community Solutions was a similar figure. Is Sally still here? Services, I'm sorry. That's right. And then there are several hundred thousand for the other ones. Okay, here we go. Childkind is a provider that does significant work with children with medical, like very medically complex needs, children with trachs, for example. That contract as a whole is worth $649,601. The MAC contract, one of them, is $729,600. And then the
I'm not doing the math in my head.
okay.
Is it
No, I don't, what I'm trying to say is, no, ma'am, I do not think that those get up to 8 million, but we are talking about between 2 and 3 million.
And you're aware in other administrations, the DFACS has been awarded emergency monies based on various crises that came up. That's a precedent for our state. You're aware?
I'm not aware of that, but I believe you.
I'm just going to renew my request that we look at this let's assume it's $8 million to restore this contract. So I'm just renewing the request that let's do something. And that's when I say we, but I'm looking at you. See if you can find the emergency money either through the governor or through the TANF reserve or whatever. Through the DOT lawn cutting budget would be okay with me. It's $11 million to cut the budget. To cut the
I agree.
I'm making a
Sorry, Russell.
serious request that you find that $8 million to restore these contracts. Thank you.
I'll do what I can.
All right, and I can vouch for Representative Oliver. I sat a few seats down for her for 3 years, and she is a wealth of institutional knowledge.
Oh, she is. She comes after me every time. I have to be ready for the tough questions. I know.
She
Very passionate about
wealth
this
of
area.
institutional knowledge, and much appreciate her. I do have a question from Emery Donahue, and I'm not sure, did you get the same question? Okay. Anyway, his question is, could we have a breakdown of where this kind of went sideways of the deficit? I know we've got a number of things from transportation, long-term psychiatric inpatient care. You've mentioned a lot of different things. And I mean, we've all had our household budgets individually to get out of whack because there was an unforeseen this and that happen all in 1 month. We recognize that, but I think for us on the committee, we just kind of like to see where this is. And if we can show a pattern that maybe over the past 4 years, there's been something that's 10% over every year, that we can certainly address that, because we don't want you to be in a deficit. We want to make sure all of these children have all the services they need, and it's not in the situation that you're experiencing right now and we're experiencing, where we're all very passionate. That's one thing I must say. I've just now become the chair of this particular committee, but I was vice chair and I've served on this committee for many years. And that's one thing that I really appreciate about Judiciary Juvenile is the love of the children that we are so diligently trying to protect. And so the passion's got a little high today, but just know it's because we want to make sure that all the children, especially the children that are in foster care, have all the services that they need. And it's not a situation where you're robbing Peter to pay Paul, for lack of a better term, because there's just nothing there.
Right. So we absolutely can demonstrate that pattern. But again, there are just some variables that were put in the equation. We didn't know the shutdown would occur. We didn't know how long it would go. We didn't know we'd be going this long without TANF. All of those things go together. The federal law changes I mentioned, that was a whole, and again, the governor and legislature, you've given us so much investment in recent years. And so, we're really grateful for that, but truly it's been like exponential growth in very, very recent time. And our numbers change so often that we could give you a daily estimate of our deficit if you wanted it. We'd be glad to do that.
I think it just helped illustrate, because I know there's some confidentialities. You can't say child A, child B, but if you could just kind of say, this category has gone, over the past whatever months or years, this has escalated beyond our budgeting for these components. I think it would help all of us kind of better understand what our challenges are.
Right.
So we could help.
I'd be glad to do that.
Thank you.
Okay.
So looking at this, doing a little quick math, it does look like at least these provider cuts are in about the $8 million range. So
Is this for the contracts that were
I
terminated?
think so, yeah. Yeah, for Creative Community Services, ChildCon, MAC, Youth Villages, Gigi's House, Family.
So for those, for Gigi's House, that was not one that we haven't terminated. Some of these contracts are there, we pay for them as services are rendered, right? So when I was answering the question, what I thought was you were asking about specifically the ones where we issue termination letters to them.
Okay. Well, I think it might be good to look at those and see what we can do first for that, for these providers that are, have situations in place that could immediately probably use some of that funding and get back into help stabilize some situations, I would say let's make that a priority and just get us the numbers and we'll all start working on what we can do. It certainly cannot wait till July and get worse. We cannot let that happen without a doubt. But I wonder, so as we are sitting here, but before we go, it looks like there aren't any questions right now. Do you feel that there is a sustainable solution in the future to avoid these recurring deficits? And I know it means, yes, give us more money, but other than that, what can we do to take care of the children who need it?
Significant investments in recent years, hundreds of millions of dollars, state dollars that have been put into preventative services, especially mental health in other agencies. But unfortunately, we aren't seeing that yet. So when we interact with these families and the children, they've not interacted with their CSB. You know, they've not interacted in other ways with DBHCD. They may not know they're eligible for Medicaid. Or if they are on Medicaid, they can't actually get any services. And so what it means for us is, you know, we're really struggling then. We have to bridge that quickly. And we're not resourced for it. I mean, so that's I think hopefully soon we're going to really start to see that and we'll start to see it firsthand. But I think that's what my staff would say too, is when families get to us, they don't know about those services. They've never used those services. It's not getting to them. That's the answer.
Well, and I mean, I'm aware of how there are a lot of interagency groups that work together on certain things, and it really made some
And we do. We work together all the
incredible
time.
things happen. I know,
Yes.
you know, over in DH, DCH, all those, you know. So if we need to come up with a model, not to add to the work that any of you do in the agencies, but to really figure out how to put together almost like a campaign of sorts to make sure we are educating people to those resources and helping each one of you not try to take care of more than you can, but making sure that families, especially children, are getting the right care at the right time. So, you know, if there's something we need to do legislatively to help with that, I'm offering it. And then I would say, you know, because we need to lead with a couple action steps here, I think. And then also to find out what is needed to put these providers that, and I don't just mean the ones in the room, there may be more, I don't know, but to put them back where they can start taking care of people. And then we'll be working on a longer term solution, no doubt. But let's see what we can do because there's immediate needs for each of those families that they were caring for. Yeah, and I think we have another light there.
We do have another light. We've got one more question. Representative Sharper.
This will be my last question for sure. But I'm going to say this, when, you know, they're asking the questions about some correlations between some things, That's why I talk about automation, AI, different data. Everything is about data. So if you just look at this year, maybe we know the causes a lot of times is the substance abuse. So maybe in the last few years,
Right.
substance abuse has went up. Finances, money wise, you said that the negligence of the children, a lot of that's correlated even when it comes down to the immigrant situation. All these things are tied to this. So I guarantee you, if you look at some numbers, you're going to see where the things I just said had a big effect on that budget of having more kids having to be taken out of their homes due to those top things that we talk about that, put them in that situation. So it's just we need to look at our technology as well. And these numbers can be moving like this. You'll be able to correlate because even the mental health, some people with mental health issues, then if the kid has to be separated from them, and then you find out that these kids not only have just regular problems, but have a mental issue problems, but it's coming out of your budget. So
Right.
these are things we got to look at technology wise and see how all these things move. So when this lever moves here, you understand that this lever, you can anticipate a
Right.
little bit better that we're here, but you know what? I'm seeing the numbers over here because, in mental health may say, well, our budget's going down for some reason. That's not one probably going down, but somebody might say, hey, mine's going down a little bit. But this person say, well, mine's going up. And then you make that correlation, say, this is why my budget is going up and theirs looking good. So that's just the big picture of thinking of what we have to do to correlate and understand how important data, efficiency, audit is.
I could not agree more because our technology is just not nimble like that. It's not even close.
Okay.
Not to add to your budget woes, but is there technology that exists out there that could assist?
Yes, we need a new case management system desperately. If you ask any case manager what they think about Shines, which is the case management system.
Heard. I've heard from others, but this is also a pretty good.
Yeah.
Yeah.
I don't think I've ever Georgia Tech nerd, right? I like technology. I like technology projects. I've worked in a lot of systems. This is the worst one I've ever seen. Point blank. It is not user-friendly. I've had to work a case in the system, and if it takes, me 3 hours, and that's not an exaggeration, 3 hours to add healthcare characteristics about one child into the system. Imagine what that is doing for the productivity of a case manager every single day. It is destroying it. So we so desperately need that to be replaced if I had to ask for one thing, but that is also a substantial investment.
Do you have a ballpark for this substantial investment?
Those kinds of systems. So the most recent estimate that we had is we suspected the state match would be somewhere, I think, between $25 and $40 million, and that's just the state match portion.
Okay.
And the return on investment you get back for the time, the efficiency of the kids, the whole system would be better, period.
Yeah, it would be. Yeah, the return on investment would definitely be there.
We can see also, we do have that system integrated with other agency systems. So, it's not awful, but if we could better integrate with other systems, we also could see things that are maybe being cared for by another agency or had been tried, Medicaid claims. We're not reinventing the wheel. But right now we just don't really know.
So there would be software that could exist that could bring in Medicaid aspects. It could bring in other agencies so we could kind of see what services they'd be eligible for.
There certainly is. But right now what we do is it's ad hoc. So, case managers are asking for all these records one by one by one by one by one.
Okay.
Great question. Great. That's kind of a great way to wrap this up, actually, because I want all of y'all to be very proud knowing that the House has advocated for that dismantling and rebuilding for years.
Yes.
It doesn't make it in. But perhaps this year, in light of what's going on, we can give it a little more push for some people who don't necessarily, I mean, it's hard to balance a budget. And we should be very proud that we're in a state that does exist under a balanced budget every year. Twice a year, we balance two budgets. Y'all are great. You're all a part of that. This is a priority. Now, two committees know it, not just one.
Thanks.
So let's go see what we can do, y'all. But as I said, please remember, it is so important that all of you that are here that have shared your stories, and they are heartbreaking, no doubt about it, that you hang in there with us. Let's see what we can do. Thank y'all.
Thank
Long
you.
day.
Thank you.